of Demystifying Finance for Clinicians. A few people are still rejoining, and so we'll give it a few moments, but I can see that our next speaker, Edward Tyson, is here. Or is it Tyson? It's Edward Tyson, is it?
Edward Tyson, yes, that's right.
Okay, because sometimes the names are converted, aren't they? Inverted. So we've got Edward here from North Bristol NHS Trust, who's going to be talking to us about NHS costing and patient level costing within an acute care setting. So I'd like to welcome Edward today and thank you for joining and sparing some time to talk to our clinicians on a very insightful and important topic. So I'll just wait a few more moments and then we can get started. I just wanted to check, Edward, do you have your slides? Are you able to share your slides?
I do, yes. I will share
So
them.
we can test to see if that's working. Yes, that's fabulous. I think we can all see the slides. And just happy to hand over to you now, Edward, whenever you're ready. Thanks again.
Okay, thank you. So, hello, my name is Edward Tyson, and I'm the SLR and Costing Business Partner at North Bristol NHS Trust. And I've been asked to talk to you about costing and PLICs within the acute sector of the NHS in England. So I'm going to try and cover 5 areas for you today. First one is what is costing, including the definition of some of the acronyms that you might have heard or will hear in the future. I'm going to cover what is patient level costing and why is that so important. And again, give an example of how costs are related to a patient's journey as they move through the hospital. I've then got a couple of examples where PLICS data has been used to make improvements to patient care. Point out these are just a couple of examples, but there are many, many more. So firstly, what is costing? So I'll start off by saying that every trust in the country will have a costing lead who is responsible for calculating the costs of patients, such as myself. Some trusts have a large team dedicated to the role, sometimes up to 5, 6, even 7 people. But some trusts have quite a small team. Sometimes it's less than 1 full-time person working on costing. So there might be someone who does costing some of their time and does other parts of finance, the rest of it. They have to have different job titles as well, so that doesn't make it very easy to track them down. So my title is costing business partner, but you might have a head of costing or a senior cost accountant. If you want to make contact with your own trust costing lead and you're not sure who to speak to, then your finance business partner or finance manager should be able to point you in the right direction. So costing is quantifying in financial terms the value of the resources consumed in carrying out an activity. So when we talk about resources in the NHS, we're talking about the input towards the treatment of the patient. So this includes pretty much everything that we do in the NHS that relates to patient care. So that's the time a doctor spends with the patient themselves, as well as the time that the doctor might spend not in direct patient contact. The cost of drugs and surgical equipment, the cost of the heating and lighting of a theatre or a ward, the computers that we use, the overhead costs such as finance staff and HR staff, as well as other clinicians, therapy staff, and other professionals who may not be, again, in direct contact with patients, such as clinical scientists and engineers. In terms of the non-pay, it goes right up from the cost of an X-ray machine right down to the pens and paper that you might use to record patient notes. When we're talking about activities in the hospital, those activities are the outputs, the products of our labours, which in one sense is a completed patient pathway in a healthy patient. So if you wanted to use a factory analogy, then our product is a healthy patient at the end of it. But it also includes all the individual parts of that treatment, such as each diagnostic test, each X-ray, each procedure that is carried out on the patient, each drug prescription, outpatient attendance or therapy contact. The activities are essentially what we get out of the process, and the resources are what we put in. Because one of the biggest restricting factors on how much resource can be allocated to a patient treatment is how much it costs in monetary terms. Everything's got a financial cost ultimately. We can use that cost in pounds to compare different treatments with the same denominator. Financial statements and budgets that you may see distributed by finance or in the news can tell us how much a hospital or a service is costing in its entirety, or even how much it costs to employ a new nurse. But what it doesn't do is connect that cost to the end result, which is the patients that we're treating. So essentially, costing is the way we work out how much the healthcare services we provide cost at a granular level. The costs are divided into the resources, and the resources are allocated to the activities they feed into. And then these activities are linked to the patients that they relate to. In the end, we can provide the cost of the final patient bill to the trust, just as you might expect at a private hospital. And I'll go into that in more detail later on. So it's some definition of some of the acronyms that you might hear. So these are quite often used almost synonymously with the term of costing in the NHS, but they have quite distinct meanings. So the first one I'll talk about is NCC. So this stands for National Cost Collection. So this is a nationally mandated data collection. So we have to submit costs to NHS England every year for all the patients that we treat. And this has traditionally been done at an average cost level, but now is being done at a patient cost level. And again, I'll talk to you about that in a bit more detail shortly. The second one is SLR, service line reporting. So this is an internal function of a trust, and it's normally produced on a quarterly or monthly basis, but might be less frequent than that. And this is about reporting the costs and sometimes income of a service with all the absorbed costs of overhead and support services. And the last one, PLIX, is patient level information and costing system. So this, in terms of frequency, could be anything from once a month up to once a year, depending on what that data is feeding into. And PLIX is the way the system we use to accurately calculate the costs of actual patients. So the National Cost Collection, every trust in the country, whether they're acute, mental health or ambulance, is required to make this submission every year. So it's mandated as part of our NHS license. In terms of when it happens, it usually happens in the summer, at least it always used to be July, August time. From the year of the pandemic onwards, that has been moving around a bit. So in the year of the pandemic, we still made a submission, but it was pushed back to the autumn. And in more recent years has moved forward into the summer or been pushed back even further again. Last year, we didn't actually make the submission until December due to problems with the development of the submission tools. It used to be called reference costs in the past. And as I mentioned, that the process for that submission was different. So it used to be on an average cost basis. So rather than accurately costing each and every patient, the costs were allocated to groups of patients based on similar diagnosis and procedures. These groups, called healthcare resource groups, which you may have heard of, could then be divided by the number of patients within the group to provide an average patient cost. From 2009 onwards, a program called the Costing Transformation Program. So objective was to transform the way we cost patient activity in the NHS. And so we now submit the data at patient level. So let's say we submit a single row of data for every inpatient episode, outpatient attendance, or an A&E attendance, as well as a number of other categories. And each of those patient events cost is broken down by the resources that have been consumed in the treatment of that patient, as well as the activities that took place, so which tests they've had, which procedures taken place, how long they stayed on the ward. So that data is pseudonymized, so it's completely anonymous for the end user, and it's collated centrally by NHS England, the NHS digital part of that group, and it's also published. So typically that would be 6 months after the end of the submission. And the data is published in a number of different formats. So the traditional reference cost format, costs are published by specialty point of delivery. So that's whether it's an consultant-led outpatient, non-consultant-led outpatient, A&E attendance, elective inpatient, day case, for example, and HRG for every submitting trust. So this is publicly available data, and you can go onto the NHS England website and see how much it costs for a particular HRG patient in an elective setting for a particular specialty, any trust in the country. And alongside that, they also calculate a national average cost. So this takes all the data from all the hospitals in the country, and it works out what a national average cost would be based on the number of patients that have been seen across the whole country. And then using that national average, an index is calculated, which compares each trust to that national average. So in the index, which is now called the National Cost Collection Index, used to be called the Reference Cost Index, 100 is average. So if your trust has an overall index of 100, it means that on average across all the activities that you do, you are costing an average amount for each patient. And that index can then be broken down across different specialties, pods and HRGs, so you can see how every single patient compares to that national average. Now that we submit our data at a patient level, it's also can be published at a more detailed level as well. So NHS England produced a PLIX integrated dashboard, and that allows the user to drill down into those costs and see what makes up the cost of each of those HRGs in terms of the resources and the activities that have happened within them. This publicly available data also feeds into a number of other data sets that you may have heard of. So the model health system, which is a system that pulls data from all parts of hospitals, such as workforce, performance, estates costs, building plans, and the national cost collection data. And the objective of that model health system is to give you users an idea of what a model health system would look like. So It compares every trust to a group of their peers and identifies where variances exist. And that's not just about cost, that's about all sorts of other factors as well. And the national cost collection data feeds in the cost element of that. Also feeds into the Getting Right First Time program. So that's about trying to get to reform patient pathways so that we're looking at the data available on how patients are treated across a number of different areas and identifying what's actually best for the patient, and then reforming those pathways in areas where we're not performing in the way that's best for the patient. The national cost collection data is quite useful for that because it connects costs to those final activities, and where you've got several patients where the outcomes are very similar, and the only distinguishing factor is the inputs that are being put in, then that NCC data allows you to distinguish between them. And it also feeds into the national tariff. So this is designed by a team at NHS England and contributes to how the income and budget for every hospital is set within the country. So in the past, where we were being paid what's called payment by results, so we get a specific payment for every patient that comes through, that national average cost that comes out of the national cost collection data was used to calculate that national tariff price. These days, when it's we're not being paid per patient as such, the actual cost of the patient is still used to establish budgets in a different way. So the next action is SLR. So SLR stands for Service Line Reporting. It's a business planning technique used to improve the way healthcare is delivered. So the SLR hospital trust is divided into specialist clinical areas or service lines, which are managed by clinicians as distinct operational units. Crucially with SLR, it displays this financial performance data against the service that is driving the use of resources. So rather than it being displaying the costs by the budget holder, so the person responsible for controlling the purse strings for a particular area, it shows the actual cost against the service who is demanding that resource. So as an example, if a doctor or in general surgery requests an X-ray for a patient, there is a cost of that X-ray to the trust that would normally traditionally be sat within the radiology department, but within service line reporting, the cost of that X-ray is displayed within the general surgery service line report. Income is also often aligned to the activity that's generating it within service line reports. And this means that SLR can measure a trust profitability by each of its service lines. So rather than just seeing a surplus or deficit for the trust as a whole, it can be broken down by the individual service lines. And SLR systems allow greater understanding of activity and performance by providing data on financial performance, activity quality, and staffing at service line level. And many trusts produce service line reports on a quarterly or even monthly basis to show the costs of a service based on the resources they consume. These reports are sometimes only circulated within finance, but more and more this data is beginning to be shared with clinicians and service managers to help them make decisions about service provision. The data within these service line reports is often drawn from the same data sets that feed into the national cost collection. And this means that the data is very granular and users can drill down into the data below service line level to understand the drivers of the costs. And this brings me on to patient level costing. So another acronym that you may hear is PLIX, Patient Level Information and Costing System. So a patient-level information costing system is a necessary tool used to calculate the costs of every patient a hospital treats. It normally includes a complex piece of software called a cost engine. This handles the innumerable calculations that need to take place. There are a number of different software suppliers for these cost engines, and their brand names may be used interchangeably with the term. Most trusts have a close relationship with the cost engine supplier, as do NHS England, as the software is a key part of the methodology for calculating patient costs. The process that we use is called activity-based costing, and this is simply where we take the costs that it costs, the money that it costs to provide a service, and then we divide it by the activities to give us a unit cost. So in the case of working in the NHS, that those activities, as mentioned earlier, are our patients. So what we're costing are patient events, so inpatient episodes, outpatient attendances, etc. So the data is loaded in from hospitals' databases. So this includes not just the finance system and the patient administration system, but almost any bit of data that the costing team can get their hands on that can give us an indication of what is driving the use of resources. The parameters are set and apportioned by the cost accountant, and these rules for the national cost collection are determined by NHS England's national cost collection guidance. So a lot of the rules that we use to decide how a cost might be apportioned are set nationally, but there's also scope for us to customize our system for our individual trusts where we think it's appropriate. The cost engine performs billions of micro calculations, and the information is output to a reporting database. And then from that database, numerous reports can be pulled off and displayed in different platforms. So this might include Microsoft Excel, Qlik, so ClickSense or ClickView, Microsoft's Power BI, or Tableau. I've now got an example of the data flows involved in the process. So this will be different for every trust, particularly the names of the systems involved, but the principle is very much the same. So these boxes in purple are what we call the master data feed. So these are recording the patient events. So whether it's an inpatient episode, an outpatient attendance, or an A&E attendance, whether the patient's come in for some renal dialysis, a rehabilitation stay, whether they've had a birth at home. It also includes things like multidisciplinary team meetings where the patient themselves are not actually present, but it's still a cost to the trust and contributes to that patient's care. All that data goes into the data warehouse, along with data from pretty much any computer system that you might be using within your trust. So it could be the pathology system, radiology system they use to record patients going through theatres, clinical photography, patients on critical care wards, and the pharmacy system. Again, there are a number of other systems that can be used, and as cost accountants, we try and get any bit of data that we can, provided that it's in a digital format that we can input to the data warehouse. Along with all that activity information, we input finance data, which comes originally from the general ledger for all our expenditure, and then sometimes a separate income system that allows us to allocate the income down to patient level. And we also input some apportionment tables, which allow us to allocate overheads that aren't directly related to specific patient activities. The cost engine does all the calculations and puts that into another database. and that's where the reports come in, which allows to view that data in a variety of ways. These next two slides show the stages of the costing process within the cost engine. So here we've got the support service apportionment. So these are the costs within the hospital that are supporting direct patient care. So these aren't driven by higher rates of patient throughput necessarily. So they would include things like finance staff, IT, HR, estates and facilities, the cleaning staff, anything that would still go on pretty much the same cost, whether we had a few patients through the trust or millions. And these are apportioned out to the patient-facing areas based on their usage. So for something like HR, we'd apportion it out based on the number of staff present in a particular area. For estates and facilities, costs like heating and lighting, we'd normally do that based on the floor area used by the service. Those patient-facing costs, when they've absorbed those overheads, are then allocated to the activities that they perform. So for pathology, for example, that activity would be pathology tests. For radiology department, it would be radiology exams. For a surgical area, their time would be split between the time they spend in theatres and their outpatient clinics and their ward rounds. And that would use the data from the theatre system, the ward stay system, etc. And those activities are then linked to a particular patient event using the information available. In some areas, in some organisations, there is a single patient ID that will feed into all the support systems. That makes it very easy to link those to the particular patient episode or attendance that we're trying to cost. But in a lot of areas, there isn't just one ID. And a lot of the work that the costing system does is to link those together. So here I've got a list of some of the activities: theatre minutes, ward minutes, radiology tests, pathology tests, drugs, therapy contacts. Those are linked to the kinds of activity, patient events, inpatients or outpatients or activity, and then this matching process that I just talked about links it down to the final patient event. So understanding the patient journey cost, we've got a little example here of inpatient journey. So Mr. Jones has a knee replacement. He spent 2 hours in theatres and then almost a week on orthopaedic ward where he had some tests and some medication. So at the start of his stay, he was admitted. He had an X-ray that cost £40. He had pathology tests that cost £130. The operation in theatre cost £1,500, and the knee implant itself was £5,000. After theatre, he had some medicine, so probably some antibiotics, maybe some blood thinners, £300, and some more pathology tests. He had another X-ray, and then some therapy contacts, so occupational therapy and some physiotherapy. That's £700. He had another pathology test just before he was discharged. So those costs amount to the direct cost of £7,750. And then on top of that, there are the overhead costs, which relate to the cost of the building and all the support staff to support these areas. So a total cost of £10,000. So why is this important? So a number of reasons. For start, it's mandated. The national cost collection is mandated, which is why we submit that data annually. It informs the tariff, as I've already mentioned. We can use it as an efficiency indicator, so that national cost collection index that I mentioned can show us how efficient we are compared to other trusts. And that means that we can benchmark against other trusts. as well as internally between services. And that leads on to productivity, which is a bit of a buzzword in the NHS at the moment. So as well as comparing ourselves against other services and our trusts, we can compare ourselves against ourselves in the past. So we can see down to a patient level how productive we have been compared to perhaps pre-pandemic levels, or how productive we were last year. So we can see, are we providing the same level of care that we were a year ago or 5 years ago, and how have our costs for providing that care changed? I think I'm running a little bit behind time, so I'm just going to skip through a few of these slides. So why is PLIX particularly important? So it gives us a greatly improved granularity of cost data and allows us to highlight inefficiencies and opportunities at a patient level. We can compare similar patients across different pathways, or patients in the same pathway who might have a variety of variable costs. Allows us to identify what we call unwarranted variation, where we've got patients who should, according to all traditional categorizations, should have the same needs from the hospital, and therefore should be consuming the same resources. And we can drill down into those patients and see how those resources differ. And we can analyze that to understand whether, is it because these patients are actually different, or is it just because we are treating them in different ways? And if we can find the best way to treat those patients, we can improve those processes and reduce any waste, which frees up more money to put into other treatments. And ultimately, it's all about better patient care. So I've got a couple of examples I just want to talk through, which aren't from my trust, but they again have been published and publicly available. So this one is from Leeds Teaching Hospitals NHS Trust, it's a urology department, and they used PLIX data to review 2 procedures used to treat inflamed prostates. So transurethral resection of prostate and a urolift. And the PLIX data allowed them to understand that the urolifts incur higher consumable costs, but because they require less time in theatre, they can be undertaken as a day case, and that meant that the patient no longer required to stay on the ward 3 days. So that meant that overall the patient was costing a lot less money, but it was also better off for the patient. The patient got to go home earlier, they could recover at home in their own bed. A second example from Nottingham University Hospital's ophthalmology department. So the PLIX data showed significant variation in the cost of cataract theatre lists. So analysis of these differences identified this was purely because of the number of cases per list. A standard procedure for cataract surgery was implemented, and changes made to theatre scheduling and list planning. So this led to improved productivity of theatre lists. There was less variation in theatre time per case, the standard procedures being followed, and a better turnaround time, and that meant shorter waiting lists for patients, therefore meaning that their conditions were not as bad at the point that they came to theatre. And just in summary then, and to remind everyone, sort of the point of costing, it's not about producing the most income at the least cost. It's about producing the best patient outcomes at the lowest possible cost, and creating efficient services. And this then allows us to make better use of the limited resources available to us. Thank you very much for listening. And if anyone's got any questions, I don't know if we've got any time for that. If you want to contact me separately, my email address is there on the screen.
Thanks, Edward. That was a really informative presentation, talking about the production of the costing at patient level, and also how that important information can be used in decision making, and make some invaluable pathway changes to help our patients. There was one question from Patricia from Leicestershire about the national submissions, such as the MSDS or CDS. Do all national submissions have to be, so do all trusts and organisations have to capture this information and submit this? I guess the answer is yes, but
yes,
I'll hand over to your expert advice.
Yeah, so all trusts have to submit this costing data, and the costing data is based on the sort of other activity submissions that your trust might have to submit, so as CDS, CDS, DS, MSDS. And that is so that the NHS England can reconcile what the sort of activity that is reported throughout the year, how that compares to the data that we're submitting. But yeah, every trust is required to make this submission. Not every trust has to do service line reporting or report internally or their patient level costing data, but most trusts do, because they see that actually it's more beneficial for us to report internally than it is really to submit this data to NHS England.
So again, thank you very much, Edward, and we show our appreciation for you taking your time out to talk to our clinicians and managers today. We now have Claire Jacqueline on the call, senior costing accountant from Humber Teaching NHS Foundation Trust. Is that right?
Yes, that's correct.
That's great. So we'd like to welcome Claire, who's going to talk to us a little bit more about similar concepts, but looking at it from a mental health perspective, I believe.
Yeah,
that's great. So I'll hand over to you now, Claire.
Thank you. I've just shared my screen. I don't know whether you can actually see that. Is that visible to you now?
Yes, thank you.
Yes, we can see
that. Okay. Now I've shared my screen, I actually can't see any questions or any information that anyone posts until I come off at the end. So if you have any questions, please post them in the chat and I'll answer anything that I possibly can at that point. And I'm just going to go straight into my presentation. I'm obviously Claire Jacqueline, Senior Costing Accountant at Humber Teaching Trust. I've been costing for more than 20 years, which I really shouldn't perhaps admit to, because I don't want to say how old I actually am. And I've costed everything from retail products, food manufacturing products, financial products, and now I'm in the NHS and costing our patients and our patients' journey. I believe that you can cost anything with the right information, but costing accurately takes time. And there's always a trade-off between the time that it takes to complete and the accuracy of whatever we cost. And I'm a firm believer in what we cost. There needs to be a reason, a purpose, a so what, so we can highlight issues and effect change for the better. In this session, I'm going to cover a little bit about Humber, what is costing, why we cost, costing in a mental health provider and the differences to that to costing, say, in an acute sector provider, a little bit about patient level costing and understanding the patient's journey, and how we can use costing information to improve patient care. So from Humber's perspective, we cover approximate population of 765,000 people across 4,700 square kilometres, and we cover all age groups, providing community and inpatient mental health services, which is what I'm going to be talking about today. But we have learning disability services, community health and therapy services, addictions, forensic services, and all sorts of bits and pieces, including primary care GP services as well. We have a handful of those, which is not a usual thing for a secondary care provider. We have about 3,700 staff. We provide services across 80 sites, but most of our care will be provided within a patient user's own home. not everything is in a particular hospital or an outpatient clinic. We are a teaching trust, so we work with universities and York Medical School. We have research and development programme, so we do spend time trying to improve the care that can be given. And as a trust, we're fairly small, so we're only £240 million turnover, which compared to some of the acute trusts, which will be in the billions, we're very small fry. But from a costing perspective, I think it flips slightly, because we cost around 180 service lines across those 80 sites and in different individual homes. I think it's about 10% of the population we had as unique patients last year. So what is costing? Costing, according to the Oxford Languages on the internet, is the proposed or estimated cost of producing or undertaking things. So we need to understand, from a trust perspective, how we're doing things and what we're doing and how much that costs, so we can try and deliver care effectively and efficiently and as cheaply as possible. So costing quantifies the financial value of resources, which tend to be our nurses or staff or consumables, like dressings or syringes or personal protective equipment, that sort of stuff. It's around the costs of what we consume when we carry out particular activities. And in mental health, it tends to be community care activities, community care contacts, which may be in group therapy or individual therapy. And we look at, obviously, the cost of admitted patient days when patients have unfortunately been admitted into a ward setting for their mental health illness. But we also cost things like supporting activities. So from a mental health perspective, it's not necessarily always about the contact, because we often have to liaise a lot with other bodies. We may liaise with schools or police or other factors that will contribute and help in the care within mental health services. So we cost all of those things because it's a time that our staff spend doing something that relates to the patient's care, and we can't deliver that care for the patient to get the best outcome without interrelating with lots of other different bodies. So why do we cost? Well, the NHS is obviously a public funded body, and we need to explain how we're spending the money. There's lots of people that are involved in wanting to know how we're spending it, the media, policymakers. Obviously the government wants to know, and it's very sort of key. Obviously we support annual audited accounts each year, but under the Health and Social Care Act, all NHS Foundation trusts that hold a provider licence have to cover 3 conditions relating to costing. So we have to submit costs, we have to provide costing information and costed related information, and we have to ensure the accuracy of what we price and cost in everything that we supply. So we have to obtain, record and maintain sufficient information about costs and how we expend these costs during the course of providing services. So we need to know what we do and how we do it. Then lots of you people will use this information for their own purposes. From a trust perspective, we use this information to make more informed and evidence-based decisions, so we can make sure that we employ the right workforce and the right staff. Do we have non-medical prescribers, say, or medical prescribers? There's lots of different things that we can reconfigure the way we deliver services to try and get a better outcome for the money. There's also where we deliver the care, in the places that we deliver care. Obviously, my trust has 80 sites at the moment. Are they the best places for the types of illnesses that the patients we've got? Some patients may not want to go and feel safe to go into a big hospital-based site. It may not help the type of illness that they have. It might be something that's is a barrier to them receiving services. So we have to look at what we deliver and where we deliver it, and obviously the services themselves, to make sure that we can provide the best services to our patients to make them improve within their mental health as quickly as possible. I guess this is a question that I'm going to put up. I'm not going to expect you all to answer it, because my finance managers will obviously tend to look at how much a team's costs to deliver care against what they were planned to deliver the same care. So if Team A spends £10,000 less than budget and Team A spends 10,000 more than budget, which team is doing better than the other? And often people will say the team that is spending the less. Actually, from that information, we don't know in a mental health setting. I don't know that because we are spending less, is that the better service? We might not be delivering enough activities, or maybe delivering less activities or less efficient activities. So the patient themselves is not receiving the care. They may look cheaper, but we're not delivering the care that we should. So maybe actually spending more for a particular service may lead to more activities, more contacts, better standards of care, provide a better service. So from the question one there isn't enough information to say one team is doing better than other. But often my management accountants will be looking at this to say whether someone's overspent or underspent. But from a delivering care perspective, it probably doesn't give people enough information. So my next question is, with the same teams A and Team B, one's underspending. So Team A is still underspending by £10,000 and Team B is overspending by £10,000. But now I've included a number of patient contacts. And so the average cost per contact for Team A is £180. And the average cost per contact for Team B is £157. Now, which team is doing better? And again, you tend to think, well, maybe the team that's cheapest, the average cost per contact is doing better. But from my perspective, there's not enough information here to say that Team B is better than Team A or more efficient than Team A. Contacts, the number of contacts themselves may not give me enough information. For a mental health patient, the length of the contact may affect the type of care that they're receiving. Some may not be as responsive for say an hour's contact and might prefer shorter bursts or longer bursts of contacts, but more frequently. So it doesn't mean that just because a duration is longer means that care is being better. Then there's no information around the intervention or the purpose of the contact here received or the type of treatment received. And certainly there's no indication in this example or in this question of the outcome. Have we made a difference to the patient? Is the patient happy with the level of care that they are receiving or have received? Is it making a difference to their mental health? So continuing the question of why do we cost? Obviously, the NHS is a public funded body, so we need to understand why if we are providing value for money. Kaplan and Porter of the Harvard Business School in the US defined value as being health outcomes achieved that matter to patients relative to the cost of achieving those outcomes. So are we able to make a difference? And in costing, we tend to look at the bottom part of that equation, the cost bit. And in mental health, the outcomes bit is a little bit more complicated, but I'm going to come back to that a bit later. So calculating value and are we delivering value can be quite difficult in a mental health setting. Another reason why do we cost is to understand if we're providing care fairly and addressing any health inequalities. The health inequalities are unfair and avoidable differences in health across the population between different groups within society. And they arise because of conditions in which we are born, grow, live, work and age. These conditions influence the opportunities for good health, how we think, feel, act and it shapes our mental health and physical health and well-being. So examples of characteristics, I suppose, could be like your socio-economic status and deprivation. So are you employed? Do you have low income? Are people living in the deprived areas that have poor standards of housing, poor education, or levels of employment? There's protected characteristics around age or sex or race or sexual orientation that may mean that your type of care is different, but we want to ensure that each person gets the care that they are entitled to, no matter any of these characteristics. So health status obviously can affect people's life expectancy as well. If you are not receiving the level of care because you're in a sort of more deprived area and you've not had the education or the health benefits or the sort of education, it can impact on the way that we live and the life that we have. So costing information can provide us information to make sure that we are offering services in the right way to our patients. I've put a bit of an example of two of my CMHTs, community mental health teams. Both have different demographics of patients within them. So at the moment, Team A has a lot of patients in decile 1, which is the most deprived areas. The 10 deciles go from 1, which is the most deprived areas, to 10, which is your least deprived areas, more affluent areas. And the profile in Team A is a lot higher deprived than the Team B is, which is a more affluent area. If I add to that the total costs of delivering care in those different deciles for the CMHT's patients, they tend, looking at it, to follow the same pattern of their activity. So here we've got the higher cost in the least deprived areas for the more affluent area, and it follows the activity that's already there. But when I add in the average cost per patient decile, the thing that we want as a trust is pretty much to have a flat line across the average cost per patient. We want to be spending the same amount for delivering care for those patients equally and offer an equitable service. If anything, it could have a slight incline up from right to left. So as you become more deprived areas, it might cost us more to treat patients within their areas. They will need potentially more support. Maybe we'll need to work harder to provide links with social care, maybe for housing or different things like that. But the table that I actually want to look at is the one on the bottom right. So Team B's average cost per patient by decile. There's so much more variation in this CMHT's delivery of care. The two bits that I want to focus on are in decile 3 and decile 4. We are spending more than double to deliver care in patients still in high need area, but than we are in the patients in deciles 1 and 2, which are the highest need clients or highest deprived clients or highest decile. So as a trust, we need to look at what's causing the barriers of entry to see the patients in deciles 1 and 2. Is there something that's stopping these patients engaging with us? Why are we're spending more on an average cost per more for patients in decile 10? Is that because the demographic patient type is more willing to ask for care than those in decile 1? We need to look as a trust at how we deliver care so this flattens out and we can offer care fairly to all patients. So costing in a mental health provider, I said earlier that you cost anything with the right information, and we cost things at the most granular level that we can. Every contact, every bed day, every drug, every supporting activity. But The data doesn't have to be perfect. In our mental health ward setting, we don't actually record a contact. So a medic or a nurse has been and spent some time with a particular patient. And so we use things to estimate that activity based on, say, the clinical notes that have been recorded, which gives me an approximate staff time against each patient as an estimate. It enables me to put some variation into our costs for each patient day. Otherwise, if I was just taking total cost of the ward and dividing it by the number of patients in the beds, everyone would have the same average cost per patient, which isn't true. So this is data now from one of my mental health assessment wards, and it shows both of the charts show the top most expensive patients for the calculation, or the top 13 most expensive patients. So the average cost per occupied bed day by patient is slowly falling there, and the total cost per patient overall. And if I say that for none of the patients in the top highest average cost per occupied bed day chart fall into the top 13 most expensive patients, it's because the ones in the chart on the left are all in a bed for less than 5 days. So they're all part of the very early assessment phase of their care. This care is more intense, so there's more clinical notes recorded. It's not perfect because it doesn't record the actual minutes staff members have spent with patients, but it records all of the notes to do with the type of care that we've delivered. So without using our clinical notes data, as I've said before, I would have just had a flat line of cost across each of these things. These would have all been equal, and our total cost per patient would have been equal, but be dependent on the number of bed days that they had stayed in. So the next two charts, the patient that was admitted into the ward for the longest level of time isn't actually the one that cost us the most to deliver care for. They're only the fifth most expensive patient to deliver treatment to in that particular unit. And you can cost anything with the right information, but difficulties in costing mental health services do include the accuracy and recording of data to report on costs with. My acute peers had payment by results for a long time, so they did get paid by each activity and it was recorded well. But mental health have never actually had the payment by results tariff. That's been something that helps you. If you're going to get paid for it, only if you record it, it will improve your recording. And also, we don't have any clinical coders employed within the trust, although we do hire in a couple for some of my community services, not mental health. And the groupings and categorizations that what we're costing so that we can make meaningful comparisons are not quite the same as in the acutes, where they've got all their nice HRGs that can health resource groups that they can break down into being able to compare hip replacements with different bits and pieces and different levels of severity. We don't have all those categorizations within mental health. It's very difficult to put mental health patients into little boxes to group easily and then to be able to compare. And also, obviously, the care that people can have for mental health is not often a very short and sweet 5-day journey, like maybe a hip operation could be. I don't know how long they actually do take, but it can be for life. So the groupings for mental health is changing. It was mental health care clusters for a while. That has been now scrapped, and they're developing mental health and neurodevelopmental resource groups, MHNRGs instead of HRGs. This work is still in its infancy. I think there's a launch by NHS on the 20th of March, a launch webinar that they're doing that provides more information on that. And I've shamelessly stolen one of their slides to say that this is their proposal for mental health resource groups around adults and older adults, children's, the adults and older psychosis and bipolar, mood and anxiety, eating disorders, neurocognitive and personality and PTSD sort of categories, where they're going to break things into costs for inpatient currencies, community currencies and crisis. But it's still very early stages, so we don't have the little categories to be able to compare patient X with patient Y within trusts and between trusts at the moment. The final difficulty in costing mental health is measuring and costing outcomes. So, as I said earlier, value is the health outcomes achieved that matter to patients relative to the cost of achieving those outcomes. So how do we measure, have we made a difference to a patient? We do have things like patient reported outcome measures, clinical reported outcome measures and patient reported experience measures. So here the PROMs are things like questionnaires ask about your health and well-being, and they're designed to measure how you rate your quality of life and your experience of the care you receive. CROMs, these are used in the rehabilitation to evaluate and track patients' health and status of recovery. Things like health of the nation outcome scales on us is one of the methods that you could use, but there are a variety of different things that you can use. HONOS itself comprises of like 12 scales that measure behaviour, impairment and symptoms and social functioning. And PREMS here are the patient's views of their experience while they're receiving care, and they indicate the quality of the patient's care being received by the patients. Things like friends and family tests will fit in that sort of categories, but it's very difficult as to when these can be measured. If it's at the start and the end of someone's treatment, how do you measure that if the treatment is for life, and often can be for a very, very sort of long term? And certainly in some instances, patients will deteriorate. Things like dementia or dementia care, patients will gradually deteriorate. But it's, I suppose, how do we maintain a good quality of life for patients for as long as possible in those instances? So patient level costing is certainly a change in the costing methodology to a bottom-up approach. So instead of just taking costs, total costs, and divided by units, we are units of activity. We can now take like a cost of something and multiply up to build up from the bottom up the cost of delivering care. And I'm not going to spend too much time on this. We do follow the approved costing guidance, and it looks at materiality, data, information and engagement. So as I said earlier, the more complex your costing model is, the longer it might take to build. And does that then mean that it's too late for you to use that data to make decisions? And maybe if the thing that you're looking at costing is really granularly but doesn't cost a lot, maybe that's something that you take out from what you do. It depends clearly on what questions you are trying to answer at the time. So within patient level costing tools, your costing colleagues will be using, well, they will obviously use a patient level information and costing system. For us, we use CACI Synergy 4, which includes ClickView, but for our trust's reporting software is actually Power BI. And so we report out our costing information back to services and clinicians using Power BI. Costing team has some knowledge of SQL, so we have to take data from everywhere that we can get our hands on. As my previous presenter mentioned, we want all sorts of different information. The more we can get hold of, the better the costing is. But we try and do it as efficiently as possible, so it's not manual process. And if you can code using SQL, some of that becomes a lot easier. But the biggest thing from our costing team's perspective, we have to build relationships. As I said, we cost 180 services. I am not a clinician. I do not have the understanding of how a service is delivered. So I have to build relationships with the services, with the people that are the knowledge experts, with my informatics colleagues who can provide me with the information, and with the stakeholders. What do the people want to see at the end of this? So costing is very much about me talking and my team talking with others, so that we can provide something that is useful on the ground, not what I think's useful in costing, although obviously some of the stuff we have to do is things like national cost collection, and it is prescribed what we have to do. But if in my reports I can add another field that will make something more useful to my colleagues, that's what we aim to do, and that's the service that we aim to do. I've mentioned earlier that obviously costing is about allocating your costs of your resources to the activities. From my trust perspective, pay is the biggest cost in our trust. It takes up about 80% of our cost. And I've seen a variety of different ways of allocating pay costs to patients. And in mental health, because it's very granular, it may be one single staff member at a particular grade that's travelled half an hour to go visit a patient in their own home, to spend time doing an intervention or treatment with them or assessment with them, and then travelled back. It's very staff member and patient specific. And so the first method of allocating pay that I have seen takes the total cost of somebody's pay and divides it by the number of activities that they've recorded. Those activities could be duration of activities, which is what it would be if in most trusts, I would have thought. But there is a disadvantage to this method, particularly when you are in the situation where it is an individual seeing a patient, in the fact that if that staff member has recorded one activity against a patient and then gone off on long-term sick, I could end up using this method. I would end up adding the full cost of that patient's pay to that one contact, which would be distorting for the patient's cost of delivering care. So we don't actually use that within this trust. The way that at Humber we use a two-stage approach, so where we work out a cost per minute based on their available cost per bed day. Available minutes that they have, which is adjusted for holidays and training, and we apply that to the minutes that they've recorded against patients. Then that doesn't allocate all of somebody's pay, because nobody records 100% of their time. And so we do it in the two-stage approach. The first stage is, as I say, to work out the direct cost per minute. And the second stage is then whatever's left is allocated based on the activities of the team, almost like an overhead of the team, which gives a fairer reflection of the cost of pay when a staff member maybe goes off sick or records low. It also allows us to monitor staff and compare the staff resource usage. So here I've got staff member A and staff member B. One is recording 75% of their time clinically. The other one's only recording 51% of their time clinically. And we like to understand why that's happening. Is there a barrier? If these are similar staff delivering similar care to patients, what's causing the disparity, and how can we increase the time we spend delivering with patients? But the main disadvantage of this is obviously it becomes a lot more complicated and takes a lot more time. I'm going to try and speed up because I suspect I'm overrunning. So we do allocate costs in different ways. We have estates costs, which we use, again, the metre squared. HR costs, we use whole time equivalent. IT costs will be based on the licenses that people have, and so on. And we follow the national cost collection guidance for a different number of. There. Sorry,
can I just just want everyone to, if you can just turn your microphones off so we don't disturb our speaker. That'd be great, thank you.
Based on the information that we have in our costing system, I can see the patient journey. So this is, at the moment, is an aggregated view of how we deliver care. And in mental health, they don't tend to just be within one team. This is a patient's journey that cost £132,000 in the year to treat. They saw our general practices, they saw our community mental health teams, they saw our physios, they saw our crisis teams, psychology teams, and they also required inpatient admissions. And we can view that data in a number of ways. But one of the things that I want to be able to do once we've got our groupings correctly is to start comparing patients if we put them at a sort of a time zero. And if somebody comes in with this particular type of illness, that what would we expect the care and the resources to be able to deliver and treat that sort of care going forward. You can view it in different ways. You can view the data looking at by month, or whether it's a contact or a GP or a supporting activity, whether it's by telephone or telemedicine activity. You can view it as a patient bill. So it's just the same information cut in a different way, but it depends on your purpose. So we can slice it and dice it by setting or location or what staff were involved in the care. So there's lots of different ways you can look at this sort of patient level information once you've built it up. Costing information is not perfect, but the more it's shared and the more it's viewed, the better it becomes. And it has led to improvements in our internal processes for data entry, because we weren't ever paid by payment by results. We didn't have enough activity actually being recorded in the system. It wasn't always there, and sometimes if it was there, there were difficulties in the way that somebody typed. Maybe somebody mistyped something. It was never picked up before. Maybe a contact us of 120 minutes and it had been recorded as 1200 minutes, and that wasn't corrected prior to that. But it is now. Now, some number and frequency of DNAs, we look at that and we cost that as well, and we highlight those, particularly those incurring a significant amount of travel time to the patient. So for those, it's changed the process in the fact that staff now ring before setting off, so we reduce the wasted travel time to make sure people are in when we go to them. We've reviewed the way we provide care as well, given to some patients. We focused on the highest cost patients and had a look to see whether actually in the right and appropriate service, or would they be suitable for a different service that would help with their recovery in a better way. We've improved the way that our internal guidances work, so on how people actually record data, how they trained to record their data. So reviewed sort of glossary of terms and making sure that people record things appropriately. And the big focus in our trust is around capacity and demand and productivity. So I can see who's doing what, who they're doing it to, and when they're doing it. It has opened a few eyes when we've looked at some of the data and realised that occasionally somebody hasn't been recording or seemed to be recording, which would mean that in things like national cost collection, my cost collection index would be too high because I don't have enough activities recorded correctly, which makes us look inefficient to what we are. But we've been looking at things like that. And it's allowed us to explore clinical variation across teams and services. We can compare average costs, highest cost, lowest cost, range of cost per contact. We can look at average times on caseloads. We can look at how we how we compare with other teams of similar shapes and sizes, and are we able to look at the capacity and demand of those teams to make sure that we have designed services in the right way to effectively deliver the care for the patients. it's been quite a thing where staff get a little bit competitive as well, in the fact that nobody wants to be the one that's recorded the least contacts on the leaderboard in there. So people like to make sure that they are doing and seem to be doing the correct level of work. And obviously we look at things like referrals and discharges by teams and the types of contacts and episodes for that. So it does allow us to make comparisons and see variations and highlight potential areas of concern or best practice. Where I looked at the health inequalities information before, it doesn't always give you the answer, but it gives you somewhere to focus and to say, why is this happening? And makes us look at whether we are delivering services in the right way. And so we're obviously allowed to focus on the productivity and see areas of overlap and work with ourselves and others to improve patient care across providers. We did a bit of work with our local acute trust around A&E attendances and frequent flyers there. So there are areas where we can try and look together to see how we deliver services and can we do it in a better way. But it's not just working with the NHS providers. We do work with people like Mind and that, so non-NHS providers of healthcare. So it helps us understand all of that information. So that's all I wanted to say. So I'm going to stop sharing now. Is there any questions?
Hi Claire, thank you so much for your presentation. It was very informative. There was lots of engagement on the chat. We've run slightly over, so we probably don't have time for a lot of questions. I think just navigating through the chat, I think there was one question around what is the kind of single biggest driver in terms of costs. So what increases the costs? And I think you kind of mentioned that in terms of staffing there. But if there's anything else, then happy for you to share. Otherwise, we can move on to the next
staffing is
presenter.
the biggest cost for us, and actually making sure that by looking at what staff do, we've been able to look at things like when we have team meetings and MDTs, and actually making some of those things more effective and efficient and not duplicating. And some meetings roll off sometimes we've got now meetings that will roll off the first meeting, so we don't have to repeat things. So it's just a bit of joined up thinking, I think, and taking a fresh look at how we do things and the best way of doing things.
So thank you very much again, Claire. I think you sparked a very sort of interesting debate, which I'm sure we can do a bit more focus on in future sessions. And just want to show our appreciation for you taking the time out for us today, and wish you a lovely afternoon. So thanks again. I'm just going to see if our next speaker is available, who is, I think it's Sam from Manchester University. Is Sam on the call?
Yeah, I'm here.
Hello, Sam, you're right.
I'm good, thank you.
Yeah, so we seem to have run over a little bit. I think we were planning to have a coffee break in 10 minutes, but I'm sure if we can try and get to as close to finishing around 3 o'clock, that would be great, just so that we can give our delegates at least 5-minute comfort break before our next speaker arrives at 3 o'clock. That would be great. So sorry to
Sure, no problem.
sorry to make your session short, but just trying to keep on time. So thank you again for joining, and I'm going to hand over to you if you'd like to share your slides. Thank you.
No problem. Okay, thank you for joining, everybody. My name is Sam Levy. I'm the Deputy Head of Clinical Coding at Manchester University Foundation Trust, and I'm going to speak to you a little bit today about clinical coding, the how, the why, and the what. So the first question really to answer is what is coding and why do we do it? It's one of those areas that everyone knows that clinical coding's there. They know it's a thing, but they don't really know what it does or why we therefore do it. And a lot of that's just due to it being a little bit clouded in mystery when you try and Google it and find out. There's not a lot of information available online, and what is there isn't very accessible. So it can be quite kind of hard to understand it. I think one of the other barriers to understanding it is also that there's lots of different types of coding, and that can confuse people. So I say that I'm the deputy head of coding. I say I work in coding and I manage coders, but it's clinical coding that I'm talking about, because there's computer programming where we're talking in programming languages like Python, there's RTT coding, there's outpatient coding, there's clinicians interacting with electronic records and using SNOMED coding, and they're all completely different types of coding. So just understanding kind of the actual type of coding is probably the first barrier. So what clinical coding is the translation of medical terminology into alphanumeric codes. So what we do is we take everything that's been documented in the medical record by the clinicians, and we read the lot. We read all of it that's there for that patient's inpatient episode. We extract everything that's relevant, relevant past medical history and chronic comorbidities, and any procedures or interventions that have been undertaken during this day. We then convert that information into ICD-10 codes and OPCS4 codes, and they correlate to those diagnoses and procedures, and that creates a coded record for that patient. So everything that's stored within a health record, whether it's on paper or in electronic format, is then codified, and that can be submitted as data or used for analysis. There's loads of different uses once you've made that codified data set. One of the sort of the biggest things that these ICD-10 and OPCS4 codes do is underpin the HRG logic, and that drives the national tariff within the NHS payment scheme. And that's something I'm going to talk about in more detail as we go on. We can also use depth of coding, so it's the number of diagnosis codes, ICD-10 codes, as an indicator of complexity. So the more codes there are, the more complex the patient is, because they've got more things wrong with them. And we can use that for case mix analysis and activity planning. So, for example, what you might be able to demonstrate is there's been a 10% increase in activity in our service, so we need additional funding. And the pushback on that is that everybody's had a 10% increase in their activity. Why should you get extra funding? We can't give everyone extra funding. But you could then use that data to say, okay, but the 10% increase has also correlated with a huge increase in acuity, and we're treating a lot more complex cohort of patients than any of the other hospitals in the region. Therefore, it's not just an increase in activity, it's also an increase in complexity. So that's one of the really valuable uses of these coded data sets. And less relevant for this conversation, but the ICD-10 codes are also used in risk modelling for the national mortality, expected mortality and disease, SHMI and HSMR. Coding improvement is something that's becoming a lot more common within coding departments these days. It's sort of the other side of the coin to what I manage within our trust. And it's a quality improvement program, so we use loads of different tools that can benefit the coding department itself and the trust on a sort of wider scale. These are done by doing post-coding validation processes to make sure that we haven't missed any information, and we've realised all of the income and sort of nothing's gone and slipped through the gaps, if you will. We also do engagement sessions similar to these with clinicians and divisional teams, where we'll educate about why coding is important, try and build up relationships with those clinical teams, explain what they need to do to help us, and find out what we can do to help them as well. We can do ad hoc projects, so we've had teams that have come to us to resolve issues, or where they've wanted to create a solution, so they recognise that coding in a particular area isn't very good, and there's maybe a clinical issue that's the cause for that, and they ask us how could we build something together that would make it a better and more efficient process. So a good example is putting together coding pro formas for areas like endoscopy, where they just have to tick off key comorbidities that would be important for us to capture. And likewise with the procedures, they can be really specific in mapping the procedure they've done to the code that we would use. And that just makes us as coders more efficient, and we know that we're capturing, everyone's got assurance that we're capturing the right level of information. And we also have a presence at the hospital mortality meetings. I think that's it on mortality though. So it's also useful to know what coding isn't, and largely this is just to understand that there is limitations to coded data, and that's not to say that it's not valuable, it might just not be the right tool to solve the problem that you've got, or to answer the question that you've got. And so it's just worth, before you sort of invest time in and go down a rabbit hole, knowing what it can and can't do. So we're called clinical coders, but we aren't clinically trained. So we can't make clinical decisions. We can't interpret any test results. That decision-making responsibility sits with clinical teams. So we have to have it documented very clearly and very specifically within the medical record for us to be able to assign the code. We can't make any assumptions, regardless of how much experience we've got, and whether we kind of know that that's what the diagnosis is. If it's not written clearly, we can't just add the code. ICD-10 and OPCS 4-day codes also aren't granular, so they are both classifications, and classifications are designed to be very broad because they're there for statistical and epidemiological analysis, so they don't get into that really fine level of detail. And I've got an example of what that means in a couple of slides' time. Coding isn't catch-all. So we only code admitted patient care, so that's inpatients and day cases. We don't code any outpatient activity. That's pretty much true for every coding department in the country. There are a couple of coding departments that will look after the outpatient activity, but generally speaking, the volume of it is prohibitive for the coding department to undertake it as well. There's just too much of it. And also the national guidance for the rules around submitting outpatient data and what coding needs to be done a lot less stringent than inpatient coding, so it just doesn't require the same skill set as a trained clinical coder to do that. So it's often done by ward staff and outpatient clerks. They'll complete the outpatient coding. So here's the examples I was talking about. So where coded data is really, really good and really valuable is where you've got synonymous terms. So things like a myocardial infarction, an MI, and a heart attack. It doesn't really matter how the clinician writes that diagnosis in the record. As long as they write the diagnosis, they can write it in any sort of way. Because what ICD-10 data does is take those synonymous terms and translate it into one code. It's always the same code for an MI. That last character at the end, the 9, might change to a different fourth character for different types of heart attack, but I-21 will always be the code for a heart attack. So what that does is makes your data really comparable throughout your trust. You can compare all of your heart attack data within your trust, regardless of how clinician A or clinician B document it. It also means that the data can then be used to compare nationally and to benchmark against peers, because everyone in England is using ICD-10 and submitting data with ICD-10. So all of the heart attacks are being coded with that same I-21 code. So that's a really, really valuable use of clinically coded data. But one thing we're seeing at the moment is where a terminology could be more useful than a classification. So I get a lot of divisional managers coming to me and saying the anecdotal evidence from the clinicians is that there's been an increase in complexity in patients, but the data isn't showing it. We're not seeing that translate across. What might be the reason? And I think it's my 2 cents on it is that it could be a post-COVID thing. So we've got patients that have had a diagnosis pre-COVID. So, for example, they've been admitted and they've got coronary artery disease pre-COVID. They've got no other comorbidities and no other complications during that admission. So this is the only code that will be coded for that admission. They plan to have a stent put in electively, but then the pandemic's hit, and like in thousands of other cases, the surgery's been cancelled. The patient's been waiting for a couple of years, and when they finally do come back to hospital, the artery disease has significantly deteriorated. Instead of a stent, the patient now needs a bypass graft. When they come for that bypass graft, we're going to use exactly the same code for that admission. If they've got no other comorbidities and they've not developed any additional illnesses, it's still just going to be that I-25.1 and nothing else. So where on paper, there's nothing to show that that patient's got any more complicated or that the heart disease has progressed anymore, because that's just not what ICD-10 is designed to show. Whereas if we look at something like SNOMED, you've got all these descriptors of how many vessels are affected, and it's much more granular detail. So in this scenario, and trying to answer that question, a terminology is probably better than a classification to try and answer those kinds of questions. Okay, so moving on to clinical coding and clinical income and how that works. So we all know that PBR was the payment process, and that was in place for the better part of 15 years. That did exactly what it said on the tin. You got paid for what you did. So the clinical coding drove an HRG, and the HRG had a tariff associated with it, and that was the income that the hospital received. Excuse me. During the pandemic, that all changed. So we moved straight onto block payments during the pandemic, based on activity from 2019, 2020. There was a few reasons behind it, largely the massive changes in activity levels, and nobody really knew what to do with COVID as a diagnosis and what the sort of the tariff should be for that. So for that first year, we were just on block contracts for everything. The second year of COVID, we then moved to the aligned payment and incentive program, where we had block payments for non-elective care and a variable element. So that was where a percentage of the tariff value was paid for elective activity, and that was the start of the elective recovery. But it wasn't particularly fair because it wasn't always 100% of the tariff value, and there was penalties for not achieving target activity levels. So it wasn't the biggest success. So then last year, we moved to the NHS payment scheme, which is a 2-year plan. It's a 23-25 plan, where we've got the same again, block payments for all our non-elective care, and then we're back to tariff-based payments, 100% of the tariff for elective activity, day cases, outpatient first attendances, and outpatient procedures. What I'd caution here is what I hear a lot, and what a lot of people sort of repeat, is that, oh, we're back to PBR. Only sort of. If you hear people say that, stop them in the tracks, because it's only sort of. A huge amount of our activity is still being paid by block contracts, so where we're getting tariff payments and we've kind of got that control about improving income. It's not at the same level that it was before COVID. However, don't ever let anyone tell you that, well, we're on block contracts, so the coding doesn't matter, because the HRG data still needs to be accurate for tariff setting in the future, so that we get the right tariff payments for what can be paid for by a tariff. And those block contracts will need to be renegotiated. So you want the tariff information, the income information related to them to be as accurate as possible, so you can get the best block contract negotiated at the next round. So HRGs, I've touched on those in the last couple of slides. An HRG is a healthcare resource grouper, and that it's clinically similar treatments grouped together based on a comparable level of healthcare resource. So that's groups of ICD-10 codes and groups of OPCS4 codes that have got similar resource implications. So they're grouped together rather than each individual code in both classifications having a tariff associated with it, because the burden of that would just be absolutely massive. So they're grouped together based on the resource implication of them. About 2/3 of all of the HRGs are tiered. So they've got what's called a CC list. So that's a list of comorbidity, a list of ICD-10 codes, which can drive the tariff up through increments using a points-based system. So an example is this table here. This is an excerpt from the tariff documentation. So the base HRG would be AA50, and then depending on the CC score over in the middle, that would drive the letter change as the suffix. So in this scenario, we've got 3 at the bottom for pediatric patients 18 years and under, and 3 for adult patients aged 19 and over. And in the very right-hand column, you can see that the number increases. So that's the tariff value. That's the pounds. The increase as that CC score increases, and the purpose of that is to show that you might have 2 patients in beds next to each other who've come in with the same diagnosis, or they've come in for the same procedure, but actually they're not exactly the same in terms of resource demand, because one of those patients might have lots more comorbidities and therefore require input from different specialist teams, require a longer stay, require more medications to be prescribed, all of those kind of things that go on. This is the purpose of the CC scoring, to give that differentiation in complexity between 2 patients just who are having the same procedure done. So how HRGs are derived, the logic in the algorithm is very complicated, but essentially it's a sausage machine. It looks like this. So you have the admission method and the length of stay. They feed into the algorithm, and then you have the clinical coding, the primary diagnosis, any comorbidities, and any procedures. They all go into the grouper. Rex does its magic in the middle, and your HRG comes out at the end. Your HRG has the tariff associated with it, and your tariff then leads to safe and sustainable clinical services. So we would like to believe, just remember that safe and sustainable clinical services bit, because I'm going to come back to that in a few slides' time. So comorbidities, I harp on about comorbidities all the time until I'm blue in the face, because it's really where the battle is lost and won. So I talk about depth of coding, I talk about comorbidities. The two can kind of be used interchangeably. Depth of coding is the number of secondary ICD-10 codes, so anything that's not the first diagnosis code in the string. As far as clinical coding is concerned, any secondary diagnosis code is a comorbidity. So it's not just a chronic long-term condition, so a patient having asthma or diabetes or hypertension. It could be the additional acute conditions that they've always also been admitted. There can only be one primary, but that doesn't mean there's only one thing wrong with them when they've come into hospital. So the addition of any acute conditions and any chronic long-term conditions and any relevant past medical history, so stuff that's completely resolved but still relevant to that patient, that's all considered a comorbidity. And it's those comorbidities that drive through that tiered structure and indicate the complexity in the HRGs. So if we have poor comorbidity recording, what the result is unrealised income. And I'll explain a little bit more and use a demonstration of what unrealised income really means. So that brings us on to sort of tariff versus cost. So they're very closely related, but they're really different things. And it's just a case of being aware of the language that you use when you're asking for information. So if you came to someone in clinical coding and says, how much does it cost to do this procedure? They won't be able to tell you. We can't tell you how much it costs. We can tell you what the tariff is for it. So the tariff is the price tag. It's the sum payable back to the trust for the care that's being delivered. The cost is how much it costs the trust to deliver that care. So that's including your hospital bed days, any resources that are used, any consumables, any theatre time, clinical time that's been spent with the patient. All of that kind of stuff is cost. And that's different to the information that I derive through the clinical coding, which is the tariff. So clinical coding determines the tariff by generating the HRG. And this is where the cost and tariff become very closely related, because the tariffs themselves are generated, or they're created using the cost data, which is submitted by each trust annually. So there's a really close link, but they mean very different things. So just beware of that language difference when you go to a team and ask them for a specific request. So we'd like to think that within the clinical record that long-term and permanent comorbidities should show a consistent pattern of coding across the patient's recent history. So a code should always appear. If it's a chronic condition, it should always be there in that patient's clinical record, is what we should think. The reality is there's about 10% of admitted spells that are currently identified as missing a code that we would expect to be a persistent and have an impact on income. So this comes into how we translate the care and how coders can work with clinicians to make sure that those gaps are filled. So the first thing that you should do is go to your coding team and find out what terms within the clinical record they can use to assign a diagnosis. So things like definite diagnosis, probably and treated as, they're quite common to coding departments. Most coding departments will use those, but the last three, presumed likely and impression, they could change. One trust might not accept them within the clinical record, because it's a conversation about how those terms are used by clinicians and kind of the way it indicates what they're doing to manage that condition. So for us, until recently, impression was on the naughty list. We never used to use impression at MFT. However, we've recently implemented a electronic patient record, and that automatically uses impression a lot more frequently throughout the record. As we discussed it with clinicians, we found that they were using impression to more synonymously with treated as, rather than as a differential. So we decided it was safe for us to move that into the terms that we can use to code from. So definitely go to your coding departments and have that conversation and understand what is the language that they can use to code from, to make sure that you're not documenting things in a way that they just can't use, and it's missed income just for essentially an admin error. Like I said earlier as well, we aren't clinically trained, so we can't interpret test results. So things like this that are written in the left-hand column in the record, regardless of whether we know that a high BMI means obesity, it's not our job to decide if that patient is obese. We don't get to see the patient. We don't have the clinical knowledge to understand a troponin blood result or an ejection fraction on an echo. So we can't make that diagnostic decision. It has to be documented clearly within the record for us to assign those codes. This slide never likes to move forwards. There we go. So here's just a worked example to labour the point a little bit and to show that difference between unrealised income. So on the left-hand side, you've got two patients that have got exactly the same primary diagnosis and exactly the same list of secondary diagnoses. But on the left-hand side, all of the secondaries are described in terms that we can't use to code from. So an HB of 87, a Rockwood score of 5, a K of 3.4, and mobilizers with the assistance of 2. We can't take any of that information and then decide that there's a diagnosis linked to it. So we can't assign a code for any of those conditions. So the only thing we would be able to code is that N30.9 at the top of the primary diagnosis. So that results in an HRG that's got a CC score of 0 to 2 and gets us a total price of £974. That's the only income we'll be able to generate for that patient. But on the right-hand side, we've got a diagnosis of anemia. The Rockwood score has been clarified to mean that the patient's frail. The K has been translated as hypokalemic, and the need for the assistance of 2 when mobilising has been described as poor mobility. That's shot the CC score up to 6 to 8. That's the highest range. And now the tariff for that episode has now changed to £3,000. The key thing here is that the information in both sides is exactly the same. So exactly the same amount of resource was used to treat the patient in both scenarios. So in essence, it always cost £3,000 to look after that patient. But if we can only achieve a tariff of £974, we are massively we've got a massive unrealised income there. And it goes back to safe and sustainable care. We can't deliver safe and sustainable care if our income is significantly below the cost of delivering our care. It needs to be comparable for us to be able to continue delivering excellent patient service and having those positive patient outcomes. Likewise, here's an example of a procedure. I'm just conscious of time. So the key on this procedure is this secondary Y code. So there's a femoral, this just indicates the approach for the procedure. So the left-hand side says it's approach to the femoral artery, and the right-hand side says approach to the aortic artery. And there is a huge jump right at the bottom in the tariff from potentially £8,500 all the way up to £13,500, depending on which approach was used. And the point here is just specifying the approach that was used for the same procedure can have a huge impact on the tariff that's achieved. Legibility is a huge issue for clinical coders. If we can't read what's written, at best we'll make mistakes and we'll miss information. At worst, we just won't be able to code it. There's not enough for us there to actually be able to say what's happened, what's wrong with the patient, what's being done. So we just have to send it back, and then it just takes more time. We potentially miss the cutoff date for submission with it as well. Versus a really nicely typed up op note, clearly demarked into sections alongside an anatomical diagram, gives the coder loads of information and a reference point to work out exactly what's been done and where. So you're going to get much more accurate procedural coding out of this. So all of that to say, what clinicians have got a big job on their hands, haven't they, to make all these changes in the way they practice so we can capture all the codes. I'm not saying that, of course, that's not what I'm saying. The job of clinicians is to look after patients. Patient care is your primary focus. It's the job of support teams like clinical coding and finance teams to engage with you, to help you understand what we can and can't use, and to put processes in place to reduce friction in that process, to make your job of treating patients as easy as possible without having to worry about how it's documented, and making sure we can get the right level of income to achieve the patient outcomes that we want. A minute to spare. Thank you.
Thanks, Sam. That was really, really informative. I was trying to answer the questions as we went along on the chat. So very, very important topic, very, very informative. And yeah, can't emphasize enough the importance of coding. which I'm sure most of our clinicians will be involved in at some point. So thanks again, and sorry to rush you through your slides.
No, don't worry.
It was great. It was great. Thank you so much. Just show our appreciation for you and wish you a good afternoon.
Thanks very much.
Yeah, so we're at 3 o'clock now. We were meant to start our next presentation from Miles. Let me just check if Miles is here with us from Devon ICB. Hello, Miles. Are you with us? Well, we'll wait until Miles. Oh, here he is. Hello, Miles. How are you doing? Nice to see you again.
Oh yeah, good, thank you.
We were meant to have a short comfort break for our delegates, so I'm going to let people have 5 minutes, if that's okay.
Yeah, no
if
problem
that's
at all.
all right with everybody, and then we'll start in about 5 minutes. And if you can try and finish for 3:30, that would be absolutely fantastic, and then we can get back on track.
Yeah,
That's
no problem.
great. So we'll start in 5 minutes. Thank you. Hello, Miles. Are you still there?
All right, yeah, still here.
Oh, brilliant. I know we gave our delegates a very short comfort break there, but I think they're all still on the call, and happy for you to start your presentation if you like.
Great, thank you. I'll share my screen for you.
And if you want to give a brief introduction about yourself and what you do, that'd be great.
Yeah, will do. So welcome everyone. My name's Miles Earl. I'm Head of Finance for Acute and Primary Care within NHS Devon, which is the ICB, so the commissioner in the sunny southwest down in Devon. I've been asked to come here today and give you all an introduction to how the funding works for general practice. So I'll run through the slides that I've got. Some of them are a little bit drier than others, so I'll perhaps try and gloss over those a little bit more. I think the presentation can get shared afterwards. And if anyone's got any questions as we go, feel free to pop your hand up, and I'm happy to take any thoughts or questions as they come up. So these are the main parts of the presentation that I'll run through, essentially the different funding streams and how they work for general practice. And in overview terms, so I think when most of us think of general practice, we think of our obviously our local GP, typically sort of fairly small organisations. We think of them as being NHS organisations. And in a lot of ways, when the media talk about them, we think of general practice as being part of the NHS. Whilst in reality, they are all privately owned, generally small to medium-sized businesses, and they carry all of the risk and reward in the same way that other businesses do from that business ownership. However, most of their income does come from the NHS, but they're not NHS organisations. There are a few that are owned and run by NHS organisations, so some local NHS or your local NHS community provider might run a GP, or indeed your acute hospital trust could run a GP practice, but that's not the norm. And increasingly larger corporate entities are becoming contract holders. Again, this is where perhaps a bit of the media sort of gets a bit excited, where sometimes we see, or increasingly we see, large corporate entities. Some of those might be foreign-owned corporate entities bid for general practices, or bid for general practice contracts when they're up for procurement, or they get sold from existing contract holders to corporate entities, and that gets sold in the media as sort of a privatisation of the NHS. Where I suppose the reality is that most organisations, or most of these primary care organisations, are already private entities. Although I suppose from a sort of warm and cuddly perspective, it's nicer that a practice is owned by 2 or 3 GPs that you see every day in the practice, compared to owned by some perhaps international shareholders. So a lot of it's about perception. Most of the contract payments are made based on list sizes. So some of you might know a bit about this, but generally, so you get different types of list sizes where you'd start with a raw list size, which is literally a sort of bums on seats. So if your GP practice has 1,000 patients registered, then that's a raw list size of 1,000. However, who make up those 1,000 patients might have a big impact on the workload that practice sees. So if a practice lives in perhaps a quite affluent area with a very old population, with a number of care homes in their footprint, there's going to be a lot different work, or a much greater workload probably, compared to a practice that exists within perhaps an area that's seen lots of new build housing developments, where typically people are a lot younger and a lot more professional, of working age. So there's a formula which determines a weighted population, so that GP practices are fairly remunerated for the amount of work that goes into caring for different types of patients. So you might get a elderly population where you have a raw list size of 1,000, but a weighted list size of 2,000. Whereas you could get a really young population with a raw list size of 1,000, but you actually get a weighted population of 800 or something of that effect. So that's just a way of trying to make sure that GPs are fairly remunerated for the work that they have to do to care for their patients. Now, the main source of income for practices is core contract funding, and that is per weighted patient. So in this financial year, the opening payment was just over £100 per patient. So your GP picks up £102 per year per weighted patient just for having you on their list. So if you go to your GP, every week for the year during that time, they still only get the £102. Whereas if you don't go at all, they still pick up the £102. There's different types of contracts which are held by general practice. There's typically PMS and GMS contracts, general medical services and personal medical services. They're generally dealt with and managed in largely the same way. There's a few technical details which determine a few differences around payment dates and room for local negotiation, but at least in Devon, fundamentally, we treat GMS and PMS contracts in the same way. We then get APMS contracts, which are alternative provider contracts, and that's typically, from my experience at least, this is where practices are set up or evolve to deal with quite different areas of population, or to provide general practice services perhaps in less typical circumstances. So we've got an APMS contract which cares for just for homeless patients. We've also got an APMS contract that covers sort of emergency framework providers. So where we've had a number of practices that have handed back their contracts in less than coordinated terms, should we say, that they've also been bundled up into an APMS contract where we've got a bit more flexibility about how we can fund that outside of the sort of national rules which determine GMS. The next slide just shows some of the changes which happened later on in the financial year. So not of much interest probably, but the details there if you want it. Another key area of contract income for general practice is the Quality and Outcomes Framework, or QOF, as you may have heard. And this is a national scheme where basically points mean prizes. So practices are incentivized for caring for patients in a particular way based on a number of criteria. And the criteria are assessed sort of by a bulk upload of patient level data, and it will be things like, if you've got condition A, you should be seen at least once every 12 months, so that'll automatically be determined. And it's a bit of a, from my perspective at least, in finance, it's a bit of a black box of the system works between looking at practices, information systems, and running the payment calculations. So practices ultimately pick up, an average practice picks up about £135,000 a year for their QOF performance, but it is a good opportunity for practices to really maximise their income. Typically, practices probably earn about 80% of the maximum that they could earn. So a well-run practice might pick up a bit more than others, but there is a bit of work involved around making sure that you are managing mostly long-term conditions, but as you can see, also public health factors for your population in that. We then commission enhanced services, and this is where payments are less based on population, but based on actual counting of activity. So there's some enhanced services which are linked to the core contract, which are nationally specified, and then there's opportunity for commissioners to locally determine any locally commissioned service they may want. So this is generally if I just pick one, so minor surgery is probably quite an easy one. If you have perhaps a minor lump or bump and you go into your GP, they may have the facility to sort of remove that for you, and they pick up a fee for that. Some practices might want to do more of that, and some might want to do less. So the ones that do more obviously get paid more because it's a sort of cost per case payment. Local enhanced services, as I said, can be for anything, but generally they're some examples of the key ones on the screen there. So payment for phlebotomy, for taking of bloods, for a laboratory to test. There might be minor injuries, LES, contraceptions, a common one, but also for things like the management of specialist medicines. I suppose local enhanced services are in a lot of ways a tool to commission services more locally to patients' homes and away from sort of acute hospitals where care can be more expensive. So if we can, care for patients and provide a common range of services in GP practices close to where patients live, it's generally cheaper and easier for patients to access than dragging them into their local hospital provider. We also reimburse general practice for most of their premises costs. So we pay for their rent, and some of that will be a notional rent if the practices are owned by general practice. Whereas if they lease the premises or rent the premises, then we'll reimburse them for their rent costs. We also reimburse business rates, clinical waste, water rates. So most of the sort of premises costs are covered by the NHS. Notional rent can be quite an issue for practices, whereas if you own the building, you've owned it for a long time, the rental value of that might be quite lucrative compared to what you paid for the building some time ago. And there's a district valuer who will go around and determine a fair market rent for those premises. I'll move on to talking about primary care networks, or PCNs. PCNs, I think, have been around now for 4 or 5 years, and they're groups of GP practices who usually operate within a similar geography. So neighbouring GP practices, typically probably 3 to 5 practices, essentially agree to work together to provide a wider range of services to a big population. So it's about trying to get general practice to get into more provision at scale. So if you care for a bigger footprint, you could have more specific clinicians with a specific focus to provide a wider range of services that are perhaps less common. Some clinicians may have a particular skill set or specialist interest, and they can provide that care across a wider footprint. And it also provides resilience to practices who might struggle with recruitment, and actually being able to provide the sort of type of services that their patients need. There's a number of different payments and schemes that not only reward PCNs for being part of a network and engaging in that network, but also support them to afford additional capacity. So the main one there, I mean, if you just scan through the numbers on the screen, the bigger number there, the first one, the £7 sort of 58 for enhanced access, that pays PCNs to provide access to general practice services outside of the normal sort of 8 till 6 opening hours. So that wouldn't necessarily have to be provided from all sites, but could be provided at different sites across the PCN at different sort of stages of the week. But the big one is the bottom one there, the additional roles reimbursement scheme. And this, I mean, in Devon, we spend about 30 million on reimbursing these additional roles. So that's £30 million, which is just for the clinical staff costs that are employed within those roles. So I can't tell you exactly how many heads that is, but that's a lot of staff that are funded through this scheme to work in Devon, providing additional care to our patients. And you can see on the screen at the moment some of the roles that might be. I suppose the important bit to note is on the list of roles, there's no GPs and there's no nurses. So you might have noticed that when you go to your GP practice nowadays, you've got to see you get triaged or seen by a paramedic before you get to see your GP. And that's about recognising that practice nurses and GPs are a scarce resource. Throwing money at the problem doesn't necessarily give you more GP or nurse capacity, but if we bring in a wider range of clinical professions, then there's an opportunity to buy in more medical capacity to general practice, which means that your practice nurses and your GPs probably only need to see the patients that their particular skills really need to see. So whilst it feels like, from personal experience at least, it feels like you're jumping through hoops sometimes when you have to see the paramedic twice before you get to see your GP. It's about giving as much clinical capacity as we can get into general practice without overburdening the limited GP workforce. There's other payments that general practice receive. So at the top there,
is that you, Finley Chops?
I think that's someone that should be on mute. Thank you. Wondered whether that was a question. I got excited for a moment. So locum costs. So if GPs are off work through maternity, paternity, or sickness, we'll reimburse some locum costs to backfill the work that they would have done. There's some other sort of syringes and needles, so we reimburse some actual or fund some actual consumable costs. We fund a lot of GP IT, so we fund things like their cloud-based telephony systems and their general IT systems that they use in lots of cases. We fund prescribing fees and drug costs. So if your GP gives you a vaccination, we'll pay them for actually dispensing the drug to you, but also for sort of dispensing the drug and administering the drug in the same way. Whilst as a integrated care board, we have commissioning responsibility for most of the services which I've described so far. There are other organisations which commission some activity for other NHS organisations which commission other services from general practice, particularly NHS England commission vaccinations and GP training, and Public Health Commission public health services as suggested on the screen there. And finally, there are some practices will do a lot better than others in generating private income. So perhaps practices that are in more affluent areas will do better at perhaps attracting work for things like minor procedures, which might be dermatological, dermatology procedures, or preparing insurance reports. And that could be for things like motor accidents and that sort of thing. Some do private vaccinations for foreign travel and provide doctor's notes. So that's been a bit of a whistle-stop tour on how your local GP practice is funded. I know it's probably quite dry, but hopefully just gives you a bit of a flavour for how those services are paid for. Anyone's got any thoughts or questions, I'm happy to pick them up.
Thanks, Miles. That's been really informative. Took me back to my GP fund holding days. Not a lot's changed really. But I think we do have, there's not any questions on the chat, but there is, I can't see, oh, Prashant from Hertfordshire's got a question. So if you'd like to go ahead and ask.
Hi, Miles. Thanks for that. Apologies if I missed this. I wasn't able to join right at the beginning. So a specific question. I work in a mental health and learning disabilities organisation, and we have a lot of patients seen in our community clinics, and exploring whether we could move some of the care into primary care. And the biggest challenge would be essentially a lot of it is depot injections. Patients are seen every 2 weeks or every 4 weeks. And I wanted to know, within what you've described, is there an obvious way to look at how that would be funded? Because that would be new work, additional work for our colleagues in primary care. What would be the best way? Ultimately, this is about clinical delivery and monitoring of patients.
Yeah. So I think from my perspective as a commissioner, at the moment, it sounds like someone's already being paid to deliver that work. So it shouldn't cost me anymore for that shift to happen. So we could either work together to take some money back out of your mental health contract and then give that to primary care to provide the service, hoping that the money that you give me back costs me the same as what I'd need to give general practice. You'd look to involve your local LMC, so the local medical committee would probably want to be involved in negotiating that sort of arrangement. Or the alternative would be for you to sort of directly outsource that work to GP practices directly, where you wouldn't need the commissioner as a middleman. You could make your own arrangements with those practices, assuming that you sort of run all of the sort of governance and safety requirements that you'd need to get that done. I suspect the first thing that you would be wise to do would be to get a hold of one of your local primary care commissioners or someone in your local LMC and have a chat really and see whether they think it's got legs.
That's very helpful. Thank you.
You're on mute.
Thank you. Thank you for that. Yeah, so I just wanted to say thanks again, Miles. It was really informative, really interesting insight into GP and primary care services. So if there's no other questions, we'd like to show you our appreciation and wish you a lovely rest of the afternoon and hope to see you again very soon.
Brilliant. Thank you very much.
Thank you so much, Miles.
Take care.
Thank you.
Bye.
So it looks as though we're back on time. I just wanted to see if our next speakers, Michael and is it Momina?
Yeah, that's correct.
Oh, hi. I just wanted to see, yeah, so you're with us and you're going to be talking to us about understanding budgets and spreadsheets. So I'll hand over to you when you're ready. Give a little brief introduction about your roles and what you do, and over to you. Thank you.
Okay, thank you. I'll just share my screen whilst I'm doing that. So my name is Michael Pollard. I'm one of the senior divisional finance managers at East Lancashire Trust, which is in Blackburn for people who don't know it. So it's sort of just above Manchester. So Momina, do you want to introduce yourself?
So I'm Amina. I work with Michael in East Lancashire Hospital Trust, and I work within the Department of MEC. So I help with budget holder meetings, speaking to budget holders, which we'll explore further during this call.
Okay, so hopefully there's a slide on the screen there. Can you see that?
Yes, thank you.
Yes, we can. Thank you.
Okay. So we're just trying to go back to the first slide. So yes, so as says, we're going to try and take you through this presentation. Hopefully it'll be interesting for you. I'm just trying to figure out whilst I talk to you how to actually. So are you seeing it as slides or are you seeing it as sort of a grid view?
We can see the slides.
Okay, that's great.
Yeah.
Fantastic. Okay. So just a bit about ELHT, as I mentioned, we are in the north of England. We're Blackburn with Darwin. We're a bit of a strange hospital in that we've got a significant number of sites. So we've got the main hospital at Blackburn, we've got a hospital at Burnley, and we've got lots of peripheral sites as well because we cover quite a big geographical area. And it's an interesting area in that there's a lot of deprivation in some of the areas, but then some of the areas are quite affluent. So we do have a real mixture of people that we serve. As you can see there, we employ over 8,000 people. We are busy. We treat over 700,000 patients a year. We have one of the biggest and busiest EDs in the area as well. So we are very, very busy with ambulances. As I mentioned there, we've got 5 hospital sites and the community sites. So the footprint is very big, it's very large. We've got 1,041 beds, as you can see there. And we do have some specialist areas, although we're not really a specialist provider. We're very much I suppose you say an all-rounder, if you will, typical sort of old sort of general hospital that we do. One of the things we do have is PFI. So some of you may be PFI.
Sorry there, Michael. I think some of our delegates can't see the slides. They've got a black screen, so
Okay.
I can see the slides. I'm not sure how many other people have just got a black screen. So I don't know if you want. So maybe if you stop sharing and reshare and see if that works. Let's just try that and then we'll just continue. Thank you.
Okay.
Sorry to interrupt you there. Sorry.
No, it's all right. It's a bit pointless if I'm going on and you can't see the slides. It's yeah.
I think it's just a few people, so yeah, it might just be a time delay.
Let me just try again and see how we get on. Okay.
Yeah, can see it. Yeah.
Is that okay? So
yes. Thank you. That's great.
That's strange, isn't it? Where some people can see it, some people can't.
Maybe it's just their access or their laptops or something. Who knows?
Yeah, it could be. Okay, yeah, sorry. So
okay.
It's all right. Just chatting about the PFI. So we have PFI at 2 of our sites, the main Blackburn Hospital and our hospital at Burnley. As you can see, they're significant. So the Blackburn one is the bigger of the 2, which is £70 million. And the Burnley one is 20 million as well. So it is a significant investment, and we do turn over 740 million. So we are a sizable trust. Obviously, they're bigger and smaller, but we are quite one of the biggest ones in our region. Just a bit of information really around how we organise ourselves as a finance department. I think finance departments tend to be very similar, but I'll just quickly wrap up what we do. So we have what we call a financial management team, which some places call management accounts. So that's really what myself and Amina are both working, which is around where we work with the divisions, understanding basically the budgets, etc., and working with them on any particular projects they have, such as business cases and such like. Income and costing, as it says on the tin, really. They look after the income side of it, contracting with the commissioners. They also pull together the costing information, which goes into the annual costing return. And then financial accounts tends to deal with the cash. So like most trusts, we've been challenged this year, certainly in terms of our cash position. So they've been working with that. They manage the cash flow, predict when we're going to be low on cash, and also if we need to borrow, which we have done this year. And finally, we've got a new team which has been set up called Benefits Realisation. It's a relatively small team in terms of headcount, but what they're doing is they're going to be very much linked in with our trust-wide improvement team, but also going back over previous years' business cases as well, just to see if any of those benefits have been realised. Just a little bit of information there for people who don't know anything about the finance values, or future focused finance. We do have the values there, the finance professionals. you can see over here on the right, these are the 4 strengths that we have. So it's finance expert, we drive the value for the patients, we make change happen, and we're a team player. It's really just the ethos that we try and work with in the finance, but also across the whole of the organisation. They're all bought up to these values, and we do have a good representation of faces as well from the clinical side, which is good. So I'm just going to hand over to Mamina now. Do you want to give us a shout when you want me to click on the slides then, Mamina?
Yeah, of course. So just to begin with, does anybody know what a budget is and how it works? Could anyone put their suggestions in the comment section below? I'll give you a minute to let them come in, and then we can kind of go through them.
Are you able to see the chat, Mamina, or do you want me to
Yeah,
read them out?
Now.
Oh,
Thank
brilliant.
you.
Yeah. Do you want me to read them out? Are you happy to?
I'm happy to read them, yeah.
Okay,
so,
great.
Someone's put budget equals income. Not quite. So your budget's based off the income that you've got for the year. And it will determine kind of what goes out. It'll help you kind of structure it so you can kind of budget to what you think would be right. The amount of money you have and what you should stick to. Yeah, that's it. The money you have to provide goods or services, money allocated to a service to spend providing that service, allocation of money. Yeah, I think everyone's kind of got a rough idea of what it is. So Michael, could you switch the slide?
Yeah.
So what is a budget? It's a plan of what you intend to do in each period. So this could be daily, monthly, annually. We tend to do this monthly and annually in the NHS through your budget statements. And through this you can see so for a specific ward, you'll see how much you've got for, say, your agency nurses, so your band 5s, and you'll also be told how much you've got for the year. So this can be split up into pay and non-pay. So you have other factors such as drugs that you may need to budget for, equipment, beds, even linen and clothing that the ward may need, and even the doctors. So Michael, if you could press the slide for me.
Okay.
So those are your examples.
Kind of pound sign.
So we need to set a budget in the first place because it's a critical part of organisation planning so that the trust can identify its expenditure against its expected income for the coming year. In order to control expenditure and ensure the trust gets value for money, and then we've got to make sure a budget holder will ensure costs incurred are valid by authorising expenditure to their budgets. So that's authorising POs, anything that you order for the maintenance or just supplies really for the actual wards. And then you've got to look at performance and accountability, and that's critical to organisational success as they monitor expenditure against the plan throughout the year. So moving on to the next slide, an example of this, of how we set budgets in our organisation, I can pass over to Michael.
Thanks. Yeah, so it's a periodical thing. So conveniently, we are in the middle of our budget setting now. So there are a few different elements there, as Mamina mentioned, and quite a few we picked up in the chat. So contracting, obviously a big part of it to ascertain where we're going to be in terms of income. So there's a lot of work goes on outside of finance in terms of putting together activity plans. So the activity plans will then translate themselves into the PBR side of the activity. So we do have some block contracts, but bear in mind what it's talking about here is last year's budget setting. So obviously we've moved on quite a bit since then. So once we've got past the 1st of April, these slides will be updated. But 23, 24, there was still quite a lot of block contracts, but we still do the piece of work around the PVR side of it. We look at the other income as well. So obviously the education funding we're getting is quite sizable. Overseas visitors, research, etc. These are all big chunks of income that we factor in. And then on the expenditure side of it, pay, what we do, and it's obviously a massive piece of work. We will recost every single employee. So let's say all 8,000 people will be recosted every year. So if you're due an increment, we will budget for that increment. If somebody leaves, we'll make a note of that, and then you'll budget that person's post is then budgeted at the bottom of the scale, so it's kind of reset. So that is a huge undertaking that does take quite a long time. So you've got an individual budget by individual members of staff, then we'll add the pay award on. So for last year we added 2.1 on, obviously it came in higher than that. This year we'll add in an estimate until we, well, in line with the planning guidance. What we also try and do is collate then what we call pressures, developments. So for example, if we know we are going to be moving a piece of software, so one of the licenses is going to end and we're going to move to a new piece of kit, but it's going to be an extra £50,000 a year, we'll build that into the budget. We had non-pay inflation. Last year we did 4%. I'm really not sure what we're going to put in this year. And then we have things like the CNST. Now what we have at the bottom there is WRP, which is what we call it, the cost reduction program at East Lancs. So it stands for waste reduction program. I think it's known by many different names in different trusts, but ultimately it's that savings factor that everybody has to achieve. So we pull all that together. So you can imagine that is a huge piece of work. It takes a significant period of time, months, if we're being totally honest with you, in terms of getting an actual budget together. And obviously the key to that is then getting a budget balance that's acceptable as part of the ICS, because we are, as a part of the ICS now, we have to deliver a collective budget rather than individual budgets. So once we've got our budget and it's been signed off and the ICS are happy, the question often that people ask is, can we change the budget? Can we do this? Normally, no, the budget is pretty much what you will have for the rest of the year, because NHSE will always monitor against our plan. So I don't think it's any secret that last year a lot of the trusts we submitted plans as a deficit. I don't think it'll be any different this year, but that's what we get monitored against from the NHSE. So we can do local service changes, but that is only permitted if we don't alter the overall position. So we can't alter that bottom line position. But obviously, if something happens mid-year, so we know COVID, etc., then the budget can be changed. Or if there's things internally that we have to change, then it can happen, but it needs sign off through the ICS, and NHS England will want sight of it as well. So we tend not to change the budgets once they've been set at the beginning of the year. So capital and revenue. So there's a subtle difference between capital and revenue. So again, just bear in mind these are 23, 24 numbers. So capital for the NHS as a whole was £7.9 billion. For the people who don't know, capital really is around the infrastructure, expensive bits of kit. So the normal criteria is, does it last more than 1 year? Does it cost more than £5,000? So obviously you can imagine, given the amount of kit that we buy, could be buildings, can be anything really, could be anything for the pathology labs, radiology equipment, all that is classed as capital and sits against the capital budget. Now each trust has what they call a CDL, it's a capital resource limit which is set, and it's very rigid on that. So as an organisation we can't exceed that. So what happens is, and just as an example, happened at Blackburn, we invested in an EPR system, which is very expensive, but obviously that eats into the capital resource limit that's been set, so it doesn't leave you a lot of room to do other things on capital. So that's one of the downsides of that, is that it's very rigid, but if you've got something you know is going to be a big expenditure in year, it means that other areas of capital, for example, as I said, buildings or other equipment, can suffer. So it's important that you kind of balance and plan capital, because it is a long-term sort of 5-10 year rolling program. And then revenue, well, it was 153 billion. Obviously, that's going to increase this year, but its revenue is around the day-to-day running costs. So obviously, we're all getting paid, and things like the drugs, medical consumables, etc. And it's only really relating to a period of 1 year, which is very strange in the NHS, because I've worked other places and you normally work sort of a 3, 4, 5 year budget, but the NHS we just seem to do an annual budget, so it's a bit alien to me, to be honest with you. But the day-to-days obviously can fluctuate massively with the salaries. So if you get a generous pay award, I think we all know inflation's running still high, inflation in drugs, inflation in consumables. So it is very volatile, the revenue budget, hence why you'll see a lot of the trusts are predicting deficit positions. Some nice arrows there to give you a total budget for 23-24 of, well, £161 billion. So obviously we do take a sizable chunk of the government's purse. I did see somewhere where I think 1 in 20 people in the UK work for the NHS in somewhere now. So we are massive in terms of the economics of the whole country, really. So in terms of budgets, I'm just going to hand you back over to Mamina, and she can take you through this.
So we can manage them through our budget statements. So your budget holders will check the budget statements every month. Within that, it will entail looking through your pay, so your employee expenses, and there you'll look through your staff that's contracted within the post and how much budget you've got. But you can also see how many have actually worked that month. So you can see if there's any sickness, any long-term sickness, any maternity leave or paternity leave through the statement. So what the budget holders usually do is they look through the budget statement and tally it up with the staff in post, and it should match. And what we get the budget holders to do quite often is to look through the staff in post and declare that they've looked through the staff in post and ensure everything's correct. And the more we check that the staff in post is correct, it reduces salary overpayments and it ensures that people are paid on the correct lines. And this will be shown in the budget statement too. If there are any issues, they have budget holder meetings where they can identify the issues, or they can contact their finance representatives. But also, not just on the employee expenses, you've also got your non-pay side. So you can look through how much you've got budget, for example, drugs, and you can see how much has been spent in month. And you can kind of look through which invoices have hit that month, and check whether to see if they're quite large or if there's anything wrong with the invoices. And you can do that through the actual department looking through which invoices that they are looking to receive, but also to see what they've actually incurred that month. And they can also see their budget for the year and see if they're within the budget for the year, based off their actual spend. So you can do it for drugs, you can do it for taxi contracts, you can do it for patient clothing. There's so many different factors that are involved within that. Michael, if you...
Next one.
Yeah. So what is financial management? So there should be, just like I said earlier, there should be regular budget meetings set up between your divisional finance team and your service managers to ensure that the budgets are planned and monitored effectively. This team should be embedded within the services in order to understand the numbers and to add context to their financial position. So this is usually your matrons, the divisional directors that will join the meetings. The financial management team should be involved in any service developments from the outset to ensure that accurate costings are provided at the earliest opportunity. So that maybe even would we be able to use some of the budget from Band 5 and Band 6 nursing lines to fund a Band 2 because they may need them more than the band 6 in practicality terms. But there could be any queries relating to that. So the responsibility of your budget holders is to engage with the finance team, so meet with the divisional finance teams regularly, ensure accurate budgets are set, so ensuring any affecting changes information is passed on to the finance team at the earliest opportunity. This could be if there are any levers, if there's a VR that's going to be raised, if there are anyone that's been overpaid. So it's just to make us aware, make sure that the financial position looks correct within the month, but also manage budgets in line with the SFIs, manage and contribute to the NHS cost improvement programme, and they can also reach out and ask for support within finance, recruitment, any other department as well. But it's also making sure that they do fill out the budget holder declaration every year to ensure that budget holders understand their responsibility as a budget holder. If we could move on to the next slide.
Okay, do you want to talk about the efficiency cost improvement programme? So as I mentioned before, we call it WRPs. We've had many different iterations at East Lancs while I've been here, but ultimately it's about taking costs out but doing it in a safe way. So you can see there are the two ways which we say is increasing the value for the service user. So it's improving the outcomes without compromising the cost, but then reducing the cost without compromising the outcomes. So realistically, what we're trying to do is make any changes that don't affect the actual users of the service, whoever they may be. So it is a difficult one. What we do in terms of WRP, and it's a big focus at the moment because always helps to the bottom line. So we have WRP sessions, WRP groups within divisions and at trust level as well. So as a division and as a finance team, we will link in with the budget holders, but it goes wider than just the budget holders. It's almost every single person in the organisation to try and understand what ideas they've got to deliver savings. So it can be anything really from one of the ones we've got at the moment, and it seems a little thing, but just putting drugs bins on the wards. So where they've got split packets of drugs, they will put them in the drugs bin, and that'll get collected at the end of the day and then consolidated together back in the pharmacy, so that we're not throwing away just odd bits of drugs. So it's things like that, but which we as a finance team wouldn't be aware of, but that's how we get the engagement with the actual people on the ground working on the wards who come up with these ideas. So you can see there on the right-hand side, it's a significant challenge. So again, 23-24, the £5.6 billion was the efficiency plan for the whole of the NHS, which is huge. So there's no way a finance team can lead on its own. So we very much try and engage with the clinicians, with the operational managers to understand what ideas they've got. Obviously, our role then becomes a facilitator and people who can cost it up. One of the main pillars of our process is around what we call a quality impact assessment form. So they have to complete that, and that's our way as an organisation of making sure people aren't taking costs out which can impact patient safety and things like that. So it needs to be signed off through the execs, through the chief nurse, through the chief medical officer. So that's how we work it. So that it's signed off in that way. You can see there, I don't know if people have mentioned or heard about the Carter review. Again, that's sort of a back office review that was done back in 2020, where they were looking to set efficiency savings around people like ourselves, HR, etc., working differently, working more collaboratively. And that's something we're doing in our ICS, where we're working towards having one finance department for the whole of the 5 trusts in our ICS, one HR department. Now that'll take time, but that's the kind of thing that we're looking forward to moving towards. We've already got it with procurement. So it's about replicating that model with finance, etc. So, I mean, we could probably be here all day talking about what the future holds, but obviously everybody's aware that you know what's happening at the moment in terms of the NHS, you know, shortage of beds, workforce staffing, etc. So all these things are really pulling on the demand, but on the flip side of that, we're having to juggle that against the shortage of actual money coming into the system. Obviously, the bottom ones particularly timely there with the potential election, etc., coming up. So who knows what will happen in the next 12 months? But as we stand at the moment, we're still trying to deliver increased activity, increased performance against less actual funding coming into the system. And there are just a few notes there really to try and understand how we can maybe change things. I mentioned around collaboration. I know there's been a lot of work on standardization as well in terms of standardizing practice, certainly around the clinical areas, GIRF and things like that. So there are lots of things ongoing at the moment, but I'm just conscious of time. So I will stop there and ask if there's any questions.
Oh, thanks, Michael. I think we've been trying to answer the questions as we go along. So hopefully that's been really informative, and thank you for that. Very good insight into the world of financial management, and engaging with our clinicians and operational managers is absolutely key, because obviously the impact of the decisions that we make clinically have an impact on of the cost of services and things like that. So thank you so much for that. Oh, looks like one question has just arrived on the chat from Patricia from Leicestershire. She says that you mentioned benefits realization. How did you implement this, and what benefits do you see with that, with having this approach? So what were the benefits of you?
What's the benefits of the
benefits? So the benefits realization.
Okay, so they are quite new, so there's nothing tangible yet. So, but the intention is that they will be able to go and go into the clinical area. So for things like winter schemes, so every year we put on half a dozen winter schemes, but everybody's so busy, nobody really knows if they make much of a difference, and there's always a cost to them. So what they're doing is they're going through those schemes, so they're almost then going back, stripping that back down and saying, okay, it cost us this much. What do we think it's actually achieved? And then when we come around to next year's winter planning, it'll be a case of, well, actually, we're not going to do that. We're going to do something slightly different. So if we're being totally honest, they're almost there as a, I won't say an audit function, but as something to, at the moment, to go back and see if the things that we've done and the things that we said we'd do have actually done what we thought they were going to do, or if they are value for money. So similar with business cases, everybody puts business cases together that says we're going to do this and it'll help reduce length of stay and all these kind of things. So the intention is they're going to go back and revisit that. And it's just, A, potentially we could maybe take that out, reverse the decision, or B, it's just learning going forward as well. So that's how we visualize them sort of contributing to the bottom line.
That's brilliant. I hope that's answered your question there, Patricia. I just wanted to say it was a great presentation. Really loved the double act approach today. That was great. And thank you, Amina and Michael again. And if we can show our appreciation for our presenters today. And we now have AK back online for our next session. Thank you so much, everyone.
Thank you.
Thanks, Pam. And the team from East Lancashire for doing the last presentation. So I'm back. Thank you for Pam for holding the fort and chairing while I was away and doing other bits and pieces. So I've got the final session of today. I hope you're still engaged. It's been a long day, and it's not the it can be dry sometimes. Let's put it that way. Finance is not the thing that drives you forward. But anyway, so my session is on business cases, and we're going to talk a bit about very, very briefly and tell you this. This is a big topic, and I have spent 2-3 hours on this, but I've got to summarize it into half an hour. So these are the key points. These are very much an overview and a guide to how to put together business cases. This is, every organization has a different process for doing business cases. What we're going to do is put it on the fundamentals, the basics that kind of business cases are built on. And it's something called the Better Business Cases model, or the 5-case model, which is basically what all public sector organizations should be using to do their business cases. And a lot of your application processes, your forms, are based indirectly, either directly or indirectly, on this 5-case model. So that's what we're going to be doing. Sorry. So we're going to use not that slide to start with. It always seems to start on the random slide. So we're going to talk about what a business case is. So a business case, there's two sides to a business case. There is the application process. So it's how you determine how to spend or prioritize your spending, or resource allocation, whatever you want to call it, essentially. And then the other side of business case is a documentation of the process and a thought process behind why you've chosen to do a particular way of solving a problem. And so there's a retrospective process as well, looking at it. Particularly when things don't go as planned, you kind of look back and think, did we miss anything? Or what's what we're supposed to do? So the components of a business case are the who, what, where, when, how, all the kind of questions you've got to put into the business case. But you've got to try and do it in a structured way. And so what we try and do is to put it together in this kind of components of this, something called the strategic case. And this is where you kind of identify why it's needed. So it's your rationale for why it's needed. The economic case is your argument for, is it value for money? Your commercial cases or case is the bit about, is it viable? And I mean, can you actually do it? Or financial cases, is it affordable? And then the management cases, is it achievable? Okay, so can you actually gain the benefits that you are gonna you're thinking of gaining? Okay, and we're going to cover those in varying amounts of detail. There are things like the financial case and a little bit of the management commercial case, which are, you basically need specialists involvement. So you might need your finance team or your procurement team to be involved in that side of things. But we're going to cover some of the key components of those. But we're going to talk a lot about the strategic case, a decent amount of the economic case, and a bit about the management case. So the aims of a business case is to show things are desirable, that is something that the organization wants. Okay, the benefit, the risks and the benefits, it offers value, essentially. It's desirable, offers value, and it's worth the risks. It's viable in that you can do it, okay, and it's achievable. And achievable in this context means that you can get the benefits that you're saying you're going to be able to get. That's what that means. As I said earlier, it's important to understand the process. And by that, I mean, work out which committees, who has to approve your business case. And for different organizations, there'll be different processes. For different ballpark money, different money amount, financial amounts or resource amounts, you'll need different processes. And targeting or changing your focus might be a different way of getting your business case approved. So targeting different pots of money, essentially. But I'll come to that and give you some examples of that in the end, towards the end. So what is the purpose of a business case in terms of what are you trying to do by doing a business case? And I would say that the most popular or most common problem that people do with business cases is having a solution. So you write a whole business case regarding a solution rather than doing it to solve a problem. So when you're writing a business case, you want to be solving a problem. That's the 90% of business cases are designed to solve a problem. Okay, and you have to show how you do the problem. It's very obvious when somebody's come up with a solution and written the business case around the solution. And generally, not always, but generally, if you write something around a solution, it doesn't look as good. It's not as robust. And that's just the process that you have to go through to do it. In past years, in the past, people have done business cases, and one of their drivers is to increase revenue into the organization. But increasingly, because that doesn't necessarily drive revenue, and often what was happening is that the revenue income was surpassed, or didn't really achieve the cost that was going to try of delivering the service. Essentially, you'd lose money rather than just generate revenue. Now we're focusing on improving quality. So in certain circumstances, if you haven't got a problem to solve, then you can do a business case, particularly for smaller amounts, driven to improve quality. So ultimately, your business case has to add value. So it goes back to the equation from earlier, where you're talking about outcomes, experience, safety, and then the versus the cost. Okay, so I'm going to miss that bit. We're going to go into these. This is a broad idea of what each case broadly covers. So we're going to be talking about the strategic case first, and is it needed? And we'll come back to this this slide in a bit. Now, if you are doing a very, very big business case, with asking for a significant amount of money, particularly if it's a multi-million-pound one or going up towards NHS England for approval, then you might be asked to do it in stages. Now, these are more at organisational level rather than at department level. And the standard stages of the business case process is this. Now, for many of us who are involved in business cases, we'll just do a business case. You'll just go straight to doing either an outline business case or a full business case, depending on the terminology being used. But in the official business case process, you do basically do an outline case, which is basically doing the first bit, the strategic case, and a bit of the economic case. By the time you get to the outline case, you have an idea of the commercial and financial implications. And by the time you've got to the full business case, that's just dotting the I's and crossing the T's, if you follow that process. I won't go into it in too much detail due to time, but I'll send you a link to some more information at the back of the end of the slides. So as I said, most of us will be focusing on the strategic case. And this is where you put the context. You put your context of what you're currently doing, what the current situation is, how the problem aligns to the organization's aims and ambitions. So your trust will have your organization will have a plan for next year or the next 5 years, or however many plans you'll have your values, and you need to show how your problem and your potential solution is going to align to those organizational aims and ambitions. Okay. The next bit is all about making your case for change. So this is your argument of why you need to change. And again, this is an area where it's often is not as robust in terms of it's not done very well. And you really need to show data. A lot of business cases, the more data you have, the stronger your case. Sometimes it's easily available data. Sometimes you've got to do some data gathering and data collection. But there are things like benchmarking data. Now, whether that's from Model Hospital or some other benchmarking network or system that you have, that's basically how you compare with other organizations. The CQC, obviously the CQC have recommended or asked for something. That's a very strong push. There's the getting it right first time data, which you often get little packs, which again push for different levels of again, it's a benchmarking data in a different way, essentially. You've got your model health system. It used to be called Model Hospital, now it's called Model Health System. It's at model.nhs.uk. You can sign up for it. You get lots of different metrics that are being used. Some of the GIRF metrics are in the Model Hospital Health System data. The caveat I will put in about the Model Health System is the data quality is completely dependent on what your organization sends in. So if your organization sends in incomplete or inadequate or poor quality data, then the data on that hospital system, on the model healthcare system, will be poor. And it's something that numerous people, including I've come across that problem where you kind of go, well, that's not quite right when you look at your data, when you look at the model health system graphs, and you go, well, how's that work? And it's because the data being fed into it is an issue. Then you've got your NICE and Royal College recommendations. They aren't as strong in terms of adding weight, because if you think about it, NICE comes out with multiple recommendations every year, as do the Royal Colleges, the different Royal Colleges. And so unless they do it as a must or as a specific type of this is something that's mandated, then which they very rarely do, then again it's not as weighted as some of the other things like CQC. And then mortality reviews and root cause analysis can also be used to justify or add weight to your case for change. So an example of, I'm going to show you a couple of examples. Unfortunately, they tend to be very much hospital based, because these are my examples. But just to give you an example, so this is from the Model Health System. So this is about our use of a particular anaesthetic gas that's very bad for the environment. You can see that my trust when we did this data collection was a very high use of it, not great. And then we used this to argue for different types of equipment, essentially, which would take away our reliance on using this particular drug. And we've managed to phase it out completely now. So you can use the data to add to your argument. Another one, again, I'm sorry, it's surgical. This is for emergency surgery, and it's about length of stay. Again, this is from a few years ago. The black line is us in Leicester. We were very poor. And then when you did some analysis, it's not because our surgeons were particularly bad, it's just because our patients are waiting 2 days to get to theatre rather than having a 2-day length of stay in hospital. So you're going to use that to argue for increased emergency theatre capacity. So, and you can use that to build on your solution, potential solution. So what you're doing here is then going, okay, this is the reason, this is the source of my problem. So this is the problem that I have to answer. So we have real issues with emergency theatre capacity. This is why, and then you build from there. The rest of the strategic case is all about looking at your existing arrangements, looking at your business. I say business needs, so it's looking at the demand, your current demand and your future demand. When we talk about potential scope, it's about how big a kind of process are we looking at. So and protection scope and spending objectives are very similar in nature. So scope is, I could build a whole new theatre suite and I could build a whole new set of theatres. That's probably beyond the scope of whatever business case I'm trying to write now. My scope is increasing theatre activity and theatre utilisation, maybe something like that. And so, what is it? What's going to limit your business case? We're not going to talk about building a whole new hospital or a whole new theatre suite. We're talking about just using what we have and increasing how long we use it for. And then spending objectives of what you're actually going to spend the money on. In the theatre capacity as an example, it's actually just for staffing rather than anything else. Again, we're not building, we don't need capital investment for costs of building work. Do we need, if we were to have another theatre, do we need more equipment, all this kind of stuff. So what you're actually spending the money on, what's your spending objectives? Your constraints and dependencies are what's going to limit you. Constraints most commonly in the NHS are estates, so space. So example, as I said, theatres, we have a limited amount of space. It can be staffing, can be limited. You know, we can, you know, and you've got to be realistic here in what's going to constrain you. Within our theatre complex, I could have an extra per member of staff. I could nominally put an extra member of staff in every theatre. We haven't got that staff. There isn't that staff around. We couldn't employ enough staff to have that, just because there isn't that. There isn't the trained staff around to do that. So that's what a constraint is. A dependency is where one project is dependent on another. For example, if this business case, let's think of an example. You might have a radiology business case. So you've got a radiology business case looking for extra staff, radiographers, consultant radiologists. Okay. Now, if you just built an elective hub for orthopedics, for example, and this is something that happened in Oxford, then the functioning of the success of that elective hub for orthopedics is completely dependent on you getting enough radiographers and radiologists to provide the appropriate number of services. So one is dependent on the other. Okay. Then we have benefits and risks. So benefits are good things that might happen, that are going to happen. Risks are things that might happen, that might cause problems. Disbenefits are bad things or things that are unwanted that will happen, almost certainly. It's not a risk, it's a disbenefit. Odd terminology, I know, but that's what they use. I often get asked about demand and capacity modelling. So using the radiology theme at the moment, you can use, this can be anything, and you basically look at your activity over the past 3 or 4 years, look at how much is increasing, predict how much you're going to increase by in the following year, and that kind of gives you an idea of your demand. Okay. And then you can look at how much increasing in capacity you will need to achieve that. Now, the bits in grey are very much dependent on which payment system it is in force at that time. So this is when it was all activity-based payments, and so you drove some revenue which would partly cover the cost of the increased capacity. So, but this is where you can use a demand and capacity modelling. Okay. So you've set the scene, you've highlighted where your issues are, you've set the scope of what this business case is going to be about. Now you come to look at what your options. Again, one of the big problems that people have with business cases is people writing the business cases tend to know their areas quite well, whether they're clinicians, whether operations managements, they tend to know their specific area quite well. The people reading your business cases don't. So when you're coming up with your long list, and this is all the potential options and solutions you can come up with, think about all the potential options. Because there'll be somebody out there that will go, why didn't you do this? Or why don't you do this? Why don't you do this? And you know, because you know your area, that that's a non-starter. Okay. But if you list them out and go, these are the options, these are not viable because of, or non-starters because of this, 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 and this, then you can start going, okay, so I've got my long list. I'm going to now use my assessment criteria, so which is how you're going to judge things. And you can have your essential and desirable components. Okay, so your essential are your critical success factors. That's the key term that they use for it. Your critical success factors are your essential requirements. And you have your desirables. And so you go from your long list, which is every potential option, to what you think And this is where you come up with 3 or 4 different options. You need at least 3, really, ideally 4. And it must include the kind of minimum option or the do nothing option. And you do an economic appraisal. And that's basically looking at the qualitative benefits. So what are the qualitative benefits of each option in terms of value, essentially? You know, what quality improvements is each option going to potentially going to be able to achieve? And then you do a ballpark cost appraisal. Now, this is where you're kind of you have to have some idea of the costs involved, but you don't need to know the details. Okay. And that's where you start with your economic case. Now, people sometimes struggle when they're trying to come up with a short list, or you're coming up with different options. You know, you might have come up with a long list and discarded, and you have your solution. One of the ways of doing it is this kind of what, how, who, when process. And this is basically a method of doing an options appraisal. It's not the only method. You can do if you've got a good long list and a good assessment criteria with some good critical key success factors, you can make your own short list. But this is a way of doing it if you're struggling. Okay. So because we've got such a broad number of people here in different organizations, I'm going to try and keep it quite benign. So we're going to talk about railways, because it's something that people generally can understand, and I'll try and put some context into bring it back to healthcare at times. Okay, so if we were to increase, if our problem was to increase the rail capacity between the south, between London and the Midlands and the north of England, we have varying options. We could improve the capacity between London and Birmingham, because that's where the biggest bottleneck is. That would be our minimum option. Our intermediate option would be to improve the capacity between London, the Midlands, and the Northwest. And then our maximum option would be to do the London, Midlands, the Northwest, and towards the Northeast, Yorkshire. And that would be our scope, our potential scope. Okay. How? The minimum would be to refurbish the existing railway lines. The maximum would be to build new lines. Okay. And then the intermediate is to do a mix of both. Okay. Now, you're not, one is not dependent on the other. It's not like you have a whole, you know, it's not sequential down that the minimums all match together and the intermediate all match together. These are just, for how, there are 3 different options. For what, there are 3 different options. You can mix and match. Okay, potentially. The service delivery is who, and in this case, it is about who the staffing. Okay, so in this particular construction case, it's about whether you can use a local contractor and use a series of local contractors, or whether you can use a national contractor or you're going to have an international contractor. It might be, if you're doing it for healthcare, it might be your staffing. It might be you want one consultant or one registrar or one allied healthcare professional or one specialist nurse plus X number. So your minimum would be X number of staff, your maximum will be X number of staff. Okay, so in if you're trying to do it for a clinic, you might have it one consultant and a registrar would be your minimum. Okay, your maximum would be a consultant, a registrar, a couple of clinical nurse specialists, and maybe some allied healthcare professionals, depending on the nature of the service. You ideally want it to be as much of a one-shop stop as possible. Okay, so staffing is often the who. The when is all about rollout. It's, are you going to pilot it in one area first? Are you going to then do a staged rollout, or you can do a big bang, one click, everything happens. Okay. And funding is much more, it doesn't quite fit the minimum, intermediate, maximum. In this scenario, it's all about whether who's going to pay for it. Is it going to come from the public purse? Is it come from the private purse? Or is it going to be a mixture of the two? In healthcare, it's often to do with departments are going to pay for it. ICB is going to pay for it. NHS England's going to pay for it. Okay. So that's where the funding comes into it. But the first four are the key things. And what you then do is you basically highlight in red the non-starters, okay, the things that don't meet your criteria. You have your kind of potential options as yellow, and then you have your preferred option as green. And in your spiel underneath this options appraisal, you go, this is why we've chosen why we've done what we've done, and why we've chosen these as our preferred options. And you put a rationale behind it. It shows that you've thought about it in a clear and consistent and coherent way. And you've gone, these are the reasons why we've done what we've done, and we've chosen what we've done to recommend what we recommended. Okay. So going back to the kind of main system, main kind of overview. So we talked about strategic case, we talked about the economic case. The management case is all about how it's going to be delivered, and that's all about implementation, but also about impact of service delivery. So you've got to think about what's going to happen both during the transition and after the transition. What's going to be impact on your service delivery? You get positive and negative effects. So positive effects may be that by having an extra clinic or having this, you're freeing up space or scope for something else. So if you were setting up some sort of community health centre, you might be freeing up primary care time. Okay, so you might have it. What's the impact on service delivery? It doesn't have to be necessarily your service, but generally across the board. If you're putting a specialist clinic in, you might be freeing up time in the general clinic. Okay. So you can look at how your service delivery may be affected. Then you've got to look at it in the context of the transition. Okay, and that means during where you're transferring from one to the other, what's going to happen? For example, when you're moving services from one site to another site, do you have to then have, for example, we moved our renal transplant service from one site to another site, and there was a 48-hour period where we ended up having to have another hospital, another organisation take our transplant emergencies just to cover that. Bear with me one second. Let me open school. Right. Okay. So when we're talking about the commercial case, the procurement process, we talked a bit about procurement earlier today, but it's also about looking at things like the whole life. When you're buying equipment, particularly, you've got to look at the whole life cost of something. And so in order to do that, you need to know how much it's going to be used. So you might find that one company gives you something very similar. If you've got two very similar products, one company might ask for a higher upfront cost, but a lower kind of per use cost, if there's consumables or some bit that has a per use bit to it. Another company might have a lower upfront cost, but the per use bit is much higher. Okay, and you've got to work out, depending on how often you use it and the lifespan of the kit, how long you're going to, what the cost is over the lifespan of that equipment is going to be. And so increasingly you'll find products that they've upgraded, so they do free upgrades. So you might find that if a better version comes along, you might find that one gives you a better upgrade. Others, so they're managed, others don't. And there's no point signing up for a 10-year contract for somebody who's for a bit of equipment that probably might be obsolete in 5. So you just need to be careful about when you're doing the procurement process. The procurement levels all vary in terms of how much competition and how much the process behind it. But again, get your procurement team to help you with that. In terms of personnel requirements, again, just work out in terms of if you're trying to increase the staffing on a ward, or you want to increase staffing, you've got to look at the number of hours. So for agenda for change contracts, it's the standard of 30 full one working time equivalent is 37.5 hours when you're doing your calculations. And then when you're looking at consultants, for example, we work the contract, or the way you work it out is on a 42-week delivery. So if you want an extra clinic or an extra session every week of the year, that's not one working time equivalent or X number of PAs. It's a bit more than that, because the standard consultant contracts for 42 weeks. And then finally, a little bit about contract issues. So if you have a contract with already in place, it's harder to break it. So if you want to get a new bit of equipment, whether it's pump or whatever it is, you've got to make sure that the trust is not already in a contract. You might have to wait to the end of that contract, and when they're doing the renegotiation or re-evaluation, make sure you put your requirements into that. Okay, there's subtle differences where if the company that's already providing it doesn't provide a product that meets your requirements, you might be able to purchase it separately, but there are some potential contract issues. And there's also issues with compatibility. So if, for example, all your computers are provided by one company and another bit of kit is provided by another company. So we had all our computers are, I can't remember exactly, but most of our computers are provided by HP, but we bought a bit of kit, so a big testing machine that has kit from a computer built into it that has Dell software in. We had massive compatibility issues for about a month while they all sorted it out, while IT sorted it out. So just be aware of that. If you're saying that there's going to be cost savings, you need to kind of put in over what kind of term and how long is it going to take to do this. And that's basically it. Right. So very quick top tips. Present your ideas before you submit the business case. Get a wide range of people that might be affected by any business case to be involved in it, so they don't act as a barrier. Incorporate people's suggestions and make the process part of the process, so they're less likely to be an issue. Make sure you factor in lots of support services. Recently, not recently, but a number of years ago, we increased the activity in theatres at weekends. So we increased the theatre staffing, we increased the surgical, we increased the anaesthetic staffing levels. We didn't, which is all within our control ish, but we didn't increase the radiology. So just be aware that there are lots of different factors that may impact the success of your project. Top tips, timing is important. Often smaller business cases, so in about January time, there might be underruns in various small capital projects. So there might be some extra money towards the end of the financial year, but often anything big, you probably need to start thinking about starting from the start of the financial year, particularly if it's related to commissioning. You might need to start discussions kind of way back in the previous kind of November time. So if you're starting in April, the discussions potentially start in November. So you need to get your ideas in early. There are different sources of funding. So things like the digital transformation funds from NHS England, there's education funds, there's patient safety funds, there's various different sources of funding. So think about what's the most appropriate source of funding. So we wanted some anaesthetic space for it's just some seminar rooms essentially, and some to where we can do one-on-ones and things like that. We don't have offices as such. And we initially applied for it through this normal funding streams, but actually we learned that we did get allocated money, but it was from the education fund. And so we had to put some caveats in. So teaching was always going to be prioritised in those rooms. The one-on-ones were mostly for small work teaching or small group teaching, but could be used when they're not being used for other things. So you can think about using funds. If you have something that's going to benefit education, then you might be able to get some education funds. Currently, there is a difference between system funding and specialised funding. So if your project's going to benefit specialised patients or patients that are going to be funded through the specialised work streams, then you might want to apply directly to NHS England rather than through system funding. That differentiation may disappear at some point. And the final thing is, if you've got a small business case, and you can add it into a relevant large business case that's almost certainly going to go through because it's a high priority, then you might be able to do that. There are some examples of poor business cases here, but essentially the ideal business case highlights a problem, all the potential options are considered, and there's a rationale for the preferred option. It's got a wide range of consultation. It demonstrates value. There's a feasible implementation plan. It's got realistic timescales. So, you know, there is a timescale for you know, if you want to employ a new consultant by a time, you're looking at least 6 months, because, you know, from my idea now and it being agreed to getting the job description, college approved and various other things to get something in post can be 6 months, can be up to a year. So think about realistic timelines, think about contingency if things weren't to go, if things were delayed or things weren't to go as planned. At the end of the slide pack, you'll get some links to the oversight metrics and the Green Book, which is basically the Treasury's guide to writing a business case. They are designed for massive business cases at government level, but there are some tips in there. Stop sharing. As I said, that is a whistle-stop tour of business cases. Any questions at all so far? Anyone can write a business case, whether you want to or not is a different matter, but you don't need to have any additional qualifications. I would say get help, because they aren't straightforward, and your first time writing a business case can be very daunting. A lot of it is making sure you've got the right data and the right stuff to go through it. There are qualifications out there. Most of them are designed for big business cases and project management. Kind of there's Prince 2, which is project management based. There's the Better Business Cases qualifications, which are made for much bigger business cases and not really designed specifically healthcare. I think that's it. As nobody else has had any questions, you'll get feedback forms. Please fill them out. We want to continually improve these days. And today I've got is it Pam Core is joining me, co-chairing. Yeah, people, I can't see everybody. And she's going to be co-chairing. Pam, do you want to introduce yourself, your proper job title, because I can't always remember.
I hope everyone can hear me. You can hear me? So I'm Pam Core. I'm Head of Financial Development at University Hospitals Coventry and Warwickshire NHS Trust. I've been with the Future Focus Finance programme since its inception, so the last 10 years, and supporting AK and others on educating clinicians and managers in NHS finance.
Thanks, Pam. So we'll be guiding you today through today's programme. So just a couple of things. The slides will be sent out. There'll also be recordings of all the sessions, so you can watch them back. I know people will have to dip out for various other commitments. So you'll get a link to the YouTube channel, which has a lot of our recordings on. We've kind of structured the day starting quite broad and then focusing on towards the afternoon. Different sessions, particularly in the afternoon, will be more relevant to some people than others. Feel free to join the sessions that are of interest to you, or the ones that don't, but you don't have to necessarily join the ones that you don't need to or don't necessarily apply to you. So we'll kick off properly. So the purpose of today is to give you an insight into how finance works within the NHS. It's not about making you into accountants or making you focus on money more than anything else. It's to give you a little bit of an overview of how to navigate the management and financial systems are within the NHS. And as I said, we're going to start quite broad and work our way down to the more specific stuff at organisation level. This is a national programme. We are we are aware that there are subtleties and differences and nuances within each area, within each organisation, within each department. We are going to try and keep things as broad as possible with some case studies and some ideas as we go along. We're going to try and make it interactive, though, with 190 people at the moment. It's going to be limited, but feel free to use the chat, ask questions. We'll have questions and answers throughout the sessions as well. At the end of every talk, we'll have a period for question and answers. But if you do want to ask anything, put it in the chat, and we will try and ensure they're answered. If it's a particularly, if it's something that's specific to your area, we might have to go away and find the answers out, because some aspects are very specific to a particular region, and we have a group of people that in different regions that may be able to help us and get you those answers. So I'm going to start presentation-y type bit. Start at the beginning. At the beginning, so apologies. Okay. So I'm hoping you can see the screens. Please shout if you can't. As I said, we're going to help you navigate the healthcare system. And what we said was we're going to make people, so this is not about making you count, it's not making you kind of always think about the money, but being aware of the financial implications of what we do. So we want people to be clinically focused, with clinical care as the forefront of everything we do, but aware of the financial implications of the decisions that we're making, and using that financial information to try and deliver the best possible value that we can. But you hear value in lots of different circumstances, lots of different areas, and in lots of different ways. But it's never really been clear what value is, and there's a difference in understanding. So to put it into perspective, we're going to talk about value and the different types of value. So there are three types of value that have been described. There's something called allocative value, and this is how you allocate resources. Okay, and this can be done at a kind of ICB. It can be done at national level, at ICB level, regional level, at organizational level. Okay, and that's something called economic value. It's also another term for it. The one we talk about when we think about value is this kind of technical value term. And this is how we make best use of the resources that we are given. And that's called efficient value. And I'll come on to that in a bit more detail in a second. The final one is something that's probably overlooked more often than not. And it's something called personalized value. And that's understanding that what you, me, our patients, colleagues, all have different values and find things of different importance. Now, you see that in clinical life every day. As an anaesthetist, I do high-risk cancer clinics. And you see some patients that it doesn't matter what the risks are, the thought of the cancer and the impact it has on them means that they want an operation, irrespective of the risks. At the other end of the spectrum, you have somebody else whose quality of life is very dependent on, for example, walking their dogs. And if you say to them, you may not be able to walk your dogs after this operation because you won't have the energy, complications, whatever it is, or even if you do, it might take you several years to be able to do that. They don't see that as good value because it affects their quality of life. So it is a way of differentiating. Different people have different ideas and different things that they value. And the Virginia Mason Institute, an American an association which is big on value-based healthcare, have done work on this, and they work with a group in Wales, and they did an example, kind of a quantitative assessment in a neurology clinic, and they asked patients what they wanted to get out of their consultations, and they asked the clinicians what they were going to get out of their consultations. And patients would want, the clinicians wanted to identify diagnosis, they wanted to delay disease progression, and treat symptoms. Whereas the patients were more focused on better sleep, more energy, better appetite. And often those two things align, and they have similar, they're the same thing in many ways, but there are situations where there are slight differences. So it's an understanding that the personalized value is important. It's also called effective value. Okay. So value, technical value, is divided into two things, and you get, make it into equation. And just check if I'm log in. So what I want to try and get you to try and do is think about what one word would be the top line and one word would be the bottom line. Let's see if we can come up with some ideas. So in the chat, see if we can get one word in the top line, one word in the bottom line. So patient value, cost value, okay, close, but one word to give you an idea of what value might mean. Okay, so we've got outcome. So outcome is a potential. Okay. Benefits, again, potential. You've seen to got the bottom word, cost. Okay. Somebody's mentioned that the top word, quality. So the top word put in as quality, and the bottom word is cost. So the next question now is, what is quality? So 3 domains of quality. And the reason we're going into this into detail is to try and get you to think about this in those 3 domains. And when you're justifying a quality improvement project, a service improvement project, you can put it in those these domains. So what is quality? NHS constitution. While people are thinking about it, I'm just going to talk about where this concept comes from. So this is way back from Asa Aradazi in early 2000s. Came up with this concept. It's in the NHS constitution. It's in various bits of legislation. 3 domains of quality. Okay, so we've got some ideas. So we've got outcomes. Okay, and I think we've got most of them. So outcomes is probably the first thing. Now, when you're looking at this, outcomes, you've got to choose the right outcome for whatever change or thing you're looking into. And there are the standard outcomes, you know, readmission rates, mortality, complications, 28-day stays, all that kind of length of stays, things like that. The things that are automatically measured. But when you're looking at outcomes, you have got to choose the right measure for what you're looking into. An example of this is, you know, one of my surgical colleagues developed or did a study on a different way of closing a big cut in the abdomen. It added an extra 30 minutes onto the operation-ish. And it didn't affect mortality. It didn't affect the rate of complications within the time frame that we look in normally. It doesn't affect length of stay. It didn't affect any of those things. Okay. It benefited by reducing the rate of incisional hernia, so hernias through that cut, over 5-10 years. And very few of our metrics look at that. And so it's very difficult to know. And so you've got to choose when you're trying to work out what value is, which is the most appropriate measure. So the other two that people have kind of I've seen here is patient experience and patient safety. Costs, we divide up into two different areas. Okay, you have your revenue costs. So most budgets and most costs are divided into two areas. You have your revenue costs, which is your day-to-day spending, and you have your capital costs, which are your big budget one-off items. You know, buying new equipment, building new buildings, all those kind of things come under capital costs. Now, the guy that came up with this, a Harvard business professor called Michael Porter, there are two kind of concepts that underlie this or underpin this equation and why it's important. The first thing, that when you are kind of show a business case or a project, you've got to show that the improvement in value is worth the cost. Okay. So in some situations, building a whole new hospital will improve all these things sufficiently to justify the costs, but in others it won't. So you can, you know, we could build a whole new hospital, you know, replace every hospital in the country, and for some situations it will improve value, in some situations it won't. So that's where you've got to do that. The second thing that also comes out of this is that generally improving quality reduces costs. The problem is it's not always the costs to your department, to your organization, okay, and it may be not over, you know, it may not be in the next financial year, which is what we always think about. You know, it may be over 5 years, 10 years, 20 years. There might be environmental benefits and reduction in environmental costs. It might be societal benefits. And historically, we've never really looked into that very much. But increasingly, there is that focus in trying to show that if you can show that you're adding value, then you're more likely to get things progressed. Okay. So the next little bit of this talk is talking about NHS structure, a bit about how the money flows through the system, and a little bit about the payment systems that underpin it all. Okay. And again, this is very basic. I'm not going into super amounts of detail because I'm expecting no knowledge. If you have any questions, please ask. So the NHS structure, it's kind of evolved over the last 70, nearly 80 years. Even in 1948, when it was first set up, it wasn't really a formal, it wasn't a coordinated process. They just, you know, nationalized whatever healthcare organizations there were, and they ran out of money. So the financial issues that have been plaguing the NHS are not new. In 1962, they come up with this hospital plan, which was the idea to try and be a bit more coordinated and have a DGH for every 125,000 of the population. They started building that, and they ran out of money. You have health authorities that were set up in 1974. You have the internal market, where organizations were pitted against each other to compete in 1990, and various other iterations. The last major iteration was the Health and Care Act in 2012, otherwise known as the Lansley reforms, which were probably not as successful as they were expected to be. Now, part of that is because between them being concocted and being enacted, the world changed. You had the financial crisis. But also, as with a lot of things in the NHS, the ideas probably were sound, but the implementation probably wasn't. And since then, probably the last 10 years since the Lansley reforms, the NHS has tried to maneuver itself within the legal framework that they provided, and there's been a much more collaboration. So there's been focus on collaboration rather than competition. So the Lansley reforms put into law that duty to compete. So you were obliged, all organisations were obliged to compete, and now we're trying to move away from that. And so that's where the Health and Care Act 2022 came in. So it was originated from a paper that the NHS England put to the government to try and work out how it could change the legal framework to allow it to do all the things it wanted to do. And then obviously there's been tweaking since then. I'll talk about a bit more about the Healthcare Act in a second. So I know somebody's written in that there's a value to staff. So if we go back to the equation has all the things the staff. This is an equation that was set up way back in before the importance of staff was probably truly appreciated. But it's still useful because staff or staffing morale, staffing engagement affects outcomes, affects the patient experience, and affects patient safety. So they underpin all three of those quality values. So you can still use increasing staff as a way of pushing forward those three areas. So as I said, we've had the budget last week, a week ago today. There wasn't anything massive in there that's going to affect the NHS per se. A couple of changes that have been added in. So there's been an extra 2.45 billion announced in revenue spending, actual day-to-day spending, which will may allow us to break even next year. So and an extra 3.4 billion in capital spending, and that's spread over 3 years from 25-26 onwards. Now this is all might change by October when after the general election, depending on how things what happens. But the current forecast or the current planned spending review, which runs until this year, shows the numbers are small, but to give you an idea. So you have the total Department of Health and Social Care, which is the organisation that runs it in England. So this is only for England. So to make this clear, health is a devolved area. So Northern Ireland, Wales, and Scotland have their own health budgets that they set themselves. This is only for England. So the idea is that the NHS England's budget is increasing year on year, and it has been year on year for a while. Whether it's enough, it's difficult to know. The capital budgets are varying, so they go up and down. And the blue areas at the beginning, that's what the Department of Health and Social Care has to fund its own. There's various arm's length organisations and bodies that sit within the Department of Health and Social Care, of which NHS England is one. And the most of the money gets passed through to NHS England, but there are multiple bodies that get funded by that blue box. And when the government, whichever government, says they're protecting or ring-fencing the health budget, it means NHS England's budget, not the Department of Health and Social Care's budget. Okay. And so what you've often found is that there have been multiple cuts to the overall budget, so the Department of Health and Social Care's budget, in trying to protect the NHS England budget. And this year, because the providers have overspent, they're using money from the capital budgets to plug the hole, and which is a not uncommon thing. So they used that pre the pandemic. It was a quite common occurrence for capital budgets to be raided to plug the hole in the revenue budget. Hence the lack of infrastructure in a lot of NHS organisations. So the capital budget, which is the big spending, is often used as a kind of a reservoir, a reserve to kind of plug in other areas. The new funding, it's not really clear whether it's coming from, is it new money or is it going to be taken away from the Department of Health and Social Care? It's not very clear. They haven't actually announced the details of that yet. Any questions on that so far? While people are typing things up. So the Department of Health and Social Care funds 12 or 13 arm's length bodies. NHS England is one. How many others do you know? Let's see if we can name. Yes, CQC. Let me straight in there. So we've got UK Health Security Agency, yes. The Ombudsman, no, they don't actually directly fund that. NICE, yes. Okay. HR, okay. We've got a few of them. Any more? So I will say that local authorities aren't funded directly by the Department of Health and Social Care. So whilst we say it's called the Department of Health and Social Care, it's not actually funding social care. Social care gets funded separately through the local authorities. There is some thinking that at some point there might be some overlap, but at the moment, no. Health Watch is funded jointly by the ICBs and the local authorities. So it's kind of a much more local organisation. NHS Resolution, NHBT, all good. So we've got most of them, I think. So we've got they're broadly classed into three kind of legal areas, but that just states how much influence or control the Department of Health and Social Care has. The Department of Health and Social Care has over them. So you have the Medicines and Healthcare Products Regulatory Agency, which is the area that looks after vaccines, looks after approves medicines, looks after any new innovations that have come through and approves them that they're safe to use. You have the UK Health Security Agency, formerly Public Health England, that also do some work. And now they, bizarrely, so the Department of Health and Social Care funds the UK Health Security Agency, but public health sits within local authorities. So the money goes then to the local authorities from UK Health Security Agency in a kind of a weird way. You have NHS Blood and Transplant. You have the Business Services Authority, which runs pensions, does prescriptions and various other things. NHS Resolution is the kind of not so new name for the litigation authority that look after the indemnity scheme and do lots of patient safety stuff. And then there's quite a small body, which is the Counter Fraud Authority. And you get your slightly more arm's length bodies. So NHS England, okay. So NHS Improvement no longer exists. It's been merged into NHS England. You have NICE, the National Institute of Health and Care Excellence. So they kind of work out whether any new innovations and new treatments and things are add value, whether they are actually worth the money that they cost, particularly drugs. So Health Education England and NHS Digital no longer exist as separate entities. They have been absorbed into NHS England as of last year. Partly because what was happening is that Health Education England's budgets were being massively reduced because they were being funded by Department of Health and Social Care. And as I said, the ring fencing only really applies to NHS England, but partly because to allow a greater kind of joined up thinking between NHS England workforce team and Health Education England. And a similar thing for NHS Digital. And you've got the multiple regulators. So the biggest one is the CQC, Care Quality Commission, but you have the more specific ones, the Human Fertilisation and Embryology Authority, the Human Tissue Authority, Health Research Authority, and then the newest body, which is the Health Services Safety Investigations Body. So that got statutory standing as part of the last piece of legislation. and actually reports to Parliament, but is funded by the Department of Health and Social Care. Right. So what I'm going to play next is a video that hopefully kind of talks about a little bit about a lot of this again. It's deliberately trying to repeat some of this stuff so that it kind of in a different way to hopefully hope it makes sense.
This animation gives an overview of the structure of the NHS in England and describes how the money flows. How public money is spent is determined by Parliament, and more specifically, the Chancellor of the Exchequer. Money allocated to healthcare is determined by the Spending Review, which is usually every 3 years, and amended annually by the Budget Report. The government department responsible for healthcare is the Department of Health and Social Care, which has the largest amount of pre-allocated public money, with an annual budget for 2023 to 24 of £188 billion. This is divided into £176 billion of revenue funding to cover day-to-day running costs, such as staff salaries and medicines, and £12 billion of capital funding to pay for infrastructure and maintenance costs. Health is a devolved function, so this funding is only for healthcare in England, as social care is funded separately via local authorities. From the budget, the Department of Health and Social Care has to pay its internal costs and fund several executive agencies, special health authorities and arm's-length bodies. The biggest of which is NHS England, which legally merged with NHS Improvement on the 1st of July 2022 as part of the Health and Care Bill. NHS England has now also merged with NHS Digital and Health Education England. NHS England received the majority of the Department of Health budget, with funding for 2023 to 24 of £160 billion. NHS England works via 7 regional teams to support the delivery of the NHS long-term plan. The plan was published in 2019 and outlines the key ambitions for the health service for the next 10 years, to create a service fit for the future and get the most value for patients out of every taxpayer pound. The Health and Care Bill builds on the long-term plan to support integration. NHS England has a budget of £27 billion for directly commissioning services, including some primary care services and public health. It directly commissions military healthcare, health services in the justice system, for healthcare for children, young people and adults across secure and detained settings, and specialised services. There are 154 directly commissioned specialised services, which are grouped into 6 programmes of care: internal medicine, cancer care, the trauma programme, women and children, blood and infection services, and mental health. Over the next few years, NHS England will delegate some of its commissioning responsibilities to local commissioners, with pharmacy, ophthalmology and dentistry services fully delegated by 2023. 9 regional committees are being created to commission specialised services from April 2023. They are joint committees between NHS England and the relevant integrated care systems in each region. Following several years of locally led development, 42 integrated care systems, ICSs, were established on a statutory basis on the 1st of July 2022 as part of the Health and Care Bill. Integrated care systems have 4 main purposes. They bring partner organisations together to improve outcomes in population health and healthcare, tackle inequalities in outcomes, experience and access, enhance productivity and value for money, help the NHS support broader social and economic development. The new ICS are led by an Integrated Care Board, ICB, and an Integrated Care Partnership, ICP. The exact composition of both the ICB and ICP will vary between areas, but as a minimum, the Integrated Care Board will include a chair, the CEO, and representatives from NHS providers, general practice, and local authorities. ICBs replaced clinical commissioning groups, CCGs, and are now responsible for developing a plan for meeting the population's health needs, managing the NHS budget, and arranging for the provision of health services in the integrated care system. The majority of NHS England's budget, £107.8 billion, is allocated to ICBs for commissioning local health services. ICBs plan and commission services for their patients. The Integrated Care Partnership will also include the ICB CEO, local authority representatives, and NHS providers, but may also include representation from other organisations. The Health and Care Act has seen a shift to more strategic commissioning and a more collaborative approach to planning care. Allocations are made from NHS England to ICBs as a system funding envelope. ICBs will have the flexibility to manage resources within this envelope to deliver agreed local priorities. ICBs will agree on contracts with providers, with increases expected to be based on aligned payments and incentive basis. Organisations within ICSs have to adopt and adhere to a shared control total, which in effect binds them to meeting a collective target for financial performance. So, in summary, money flows from Parliament via the Department of Health to NHS England, and in the most part, integrated care boards to the organisations that provide patient care.
So, I think any questions on any of that? Now, probably the last 30 seconds, probably the worst bit. So where they start putting a lot more jargon in. Collective performance target just means that all the providers within an ICB kind of sign up to the kind of key performance indicators are now at ICB level rather than at kind of individual organisation level. A shared control total is essentially when at the beginning of each financial year, all the providers, organisations have to kind of come up with an idea of where they're going to sit within their budgets. So some organisations are allowed to run, not allowed, but say they're going to be, £1 million over or £2 million over budget, and so they will, the Department of Health and Social Care will, or NHS England will kind of go, okay, fine, you're going to be, you were £5 million over last year. Try and get to £3 million over this year, and so that's your control total. So it's a kind of a plan of budgeting. And in previous times, previous years or multiple years previously, what was happening was that certain organisations within the ICB would have a positive control total, and generally the acute providers would have a negative kind of budget plan forecast. And so what they're trying to do now is to go across your ICB to encourage collaboration. You've got to break even between the commissioners and all the providers. Break even. That's basically what the shared control total means. Okay. So they're the two big terms in that video that I'll slightly go into a bit more detail and were added in by NHS England. Okay. So as I said earlier, the Health and Care Act 2022 was based on some stuff that NHS England asked for. Everything was delayed because of the pandemic, but it became into effect on the 1st of July 2022. The main kind of changes, I mean, there are 180 or something different points within that. I'm going to talk about just the ones that are specific to the NHS structure, which are about integrated care boards, which we've heard about, and integrated health and care partnerships. As I said, there's now a duty to collaborate, whereas there was a duty to compete in the previous legislation. Whilst there have been kind of pseudo joint appointments and committees in the past, because of competition laws, Though you weren't around, they were done through loopholes rather than actual being joint committees and joint appointments. So now you can actually have joint appointments and committees. Whilst commissioners do not have to put things out to tender, they still have the option to. They just don't have to automatically. So that's the key things there. A lot of the other stuff was all about tidying up the kind of legislation and the kind of structures. So pre this little bit of legislation, there were officially 3 different bodies looking after the NHS in England. There was NHS England, who was the commissioner, and then there was the Trust Development Authority and Monitor. Now, these were kind of historical bodies that were legal entities. Monitor was set up to look after foundation trusts, so to oversee and give oversight to, and regulate foundation trusts. And the Trust Development Authority were there to encourage or support those providers that weren't foundation trusts to become foundation trusts. Soon after the introduction of foundation trusts, they realised that actually being a foundation trust wasn't all that, and there were many organisations that employed, let's say, less than good ways of behaviour in order to become a foundation trust. They cut lots of corners, and subsequently they struggled when they got that autonomy. Not all, just some, but in order to, and it meant they had much more independence, which subsequent governments thought was a bad thing. So quite quickly they realised that actually they didn't want that encouragement of organisation to become foundation trust, so they merged together to become NHS Improvement. So NHS Improvement was the regulator, and NHS England was the commissioner. And then they also then worked out a few years later after that you get mixed messages. So the commissioners were saying you have to do this, you have to have certain levels of safe staffing, you have to have, you know, all these kind of things that were required. And then the regulator, who was mostly a financial regulator in many ways, were saying, no, you can't afford to do that. So mixed messages were coming back down from the bodies at the top. So again, probably 3 or 4 years ago, they merged. And initially they were called NHS England and Improvement because they had to be separate entities. But now, with the new legislation, there is just one body that is responsible for the NHS England. That is NHS England. So that is the kind of main big changes that have happened as part of the legislation. Another change, which wasn't asked for by NHS England, but has been added in by the government, is so NHS England has been an arm's length body, so every year there's a mandate issued by Department of Health and Social Care saying the kind of, we're giving you this money to fund you, but you have to achieve these kind of pre-metrics and things like that. And with the Secretary of State not really ultimately responsible, it was the responsibility lay with the Chief Exec of NHS England. But with the new legislation, they've increased the power and responsibility of the Secretary of State for Social Health and Social Care. So any questions on the structure of the NHS? I said that the video is available. It is a summary. It is quite quick, but you can watch it again and get your head around it, because it is quite complicated and constantly changing, which doesn't help. So it is the 2023 update that the link is in, that somebody's put the link in. There are previous iterations. We've made 4 or 5 of these videos over the years. A question: is there, if this is still the public money? Yes, it's though. It's just the way that it's how budgets are differentiated. They have revenue spending and capital spending. It's not uncommon even within businesses that you have money allocated for your day-to-day spending, and then your big budget spending. And mostly that's because the big budget spending is spread over multiple years, whereas the day-to-day spending is much more aligned to a specific financial year. But as we've noticed in the past multiple times, money does get moved from one pot to the other. So whilst there are some restrictions and constraints, it's not absolute. Okay. So payments and systems in the NHS. It is another area that's changing quite often. and commonly, and I don't think we've come up with an ideal payment system in the NHS. We've got one. The one that we've got now is the same one we had last year. So the one for April 2024 onwards for that financial year is the same payment system as the one we've had for 23-24. Before that, we've had a variety of different ones. So what I thought I'd do is start with basically going through the building blocks. There are different ways in which services can be paid for providing a service. So organisations can be paid for providing a service. These are the building blocks that are used in every payment system in the world. So whatever payment system that is used, it's based on one of these or combination of one of these different methods. There are 7 broad building blocks, and put together they make a payment system. So the first one is called block contract. A true block contract is a lump sum payment to provide a service, and it doesn't depend on the quantity of demand or supply. So it has good, and with all these things there are positive benefits and negatives. The positive for block contracts is that it's predictable. So the provider organisation knows how much money it's receiving, and the commissioning body knows how much money it's paying. Okay. It's most commonly used, or has traditionally in the past been most commonly used for things that are difficult to measure. So where you can't measure levels of activity very accurately, you tend to use that. So in community services and during the pandemic, because activity was so variable, it was very difficult to measure and be accurate about it, they used these block contracts. They're normally based on some, calculations of activity in the past. So you often take what your past activity is and the cost it costs you to deliver that, put a uplift, efficiency factor, whatever it is, and then negotiate how much that's going to cost. The problem with block contracts is that it doesn't depend. There's no strict block contract, there's no dependency on the quantity or demand of supply, which means that if your activity and everything's based on you doing 100 lap appendixes or 100 hip replacements and you do 110, you're not going to get any more money. So you lose out as the organisation, provider organisation. If you do 90, then the commissioner's got less value for money. Okay, so it's not ideal in that way. It doesn't encourage organisations to do more than they plan to do. Okay. Capitation is a population-based payment system. It's used to work out how money is allocated to health boards in Scotland, ICBs in this country, in England, and also it's the main bulk of the GP service, global sum payment of GP funding. So it's a per patient or per person money, with the population being adjusted for various factors. Now it can be that, and the differences and kind of controversies is all around how you weight the different factors. So whether it's age, socioeconomics, various other demographic data, whether it's so that's where the complexity bit comes from. It's how you then weight those and how you calculate the weightings to work out how much money each area gets. So the Cahill formula is what they use in GP services, and there's different formulas for different other bits. So that it is a increasingly used method of payment systems, population based. And pathway of care is one that's been used in the past. It's currently, I don't think it's currently being used. It is a single payment to cover a whole pathway care. So the one that has been used for in the past is maternity services. You've got one payment for antenatal care, one payment for intrapartum or the birth bit, and one payment for postnatal care. And the idea was that you could have a lead provider that takes responsibility for the pathway, and they could subcontract out different bits of the pathway to different people. The problem is always about where if the complication level. So antenatal care, you had 3 different kind of complication levels. So low risk, medium risk, high risk. There were 5 different levels at the kind of birth bit, and then 3 or 4 different levels at the postnatal bit. And what they found was actually you got your payment depending on what you started off as. So if you started off as a low risk pregnancy, then the organisation would get, or the provider would get, a low risk payment. It didn't matter if the pregnancy became high risk during that period, you wouldn't get an increase in that payment until you became during the interpartum stage. And so it wasn't really reflective of the costs being incurred by the different organisations. It might still come back in a different form in the future, but currently it's not being used. Pay performance is used as in multiple different in ways. It's normally part of every contract in some way. So you get QOF payments, which are the Quality and Outcomes Framework, which is can be up to 20%, 25% of a GP income. And then you've got the sequins, which is commissioning for quality and innovation, which is what's used in acute community mental health organisations. The value of the sequins is gone down. So it used to be 2.5% of the contract value. It's now much smaller. It's 1.25%, and that's because sequins change every year. And there were two things. One, lots of organisations were just accepting that they were going to make the sequin, and so if they didn't reach it, they would get they would feel as if it was penalised, rather than a kind of encouragement. And the other one was that because they change every year, potentially, you have the ongoing costs from that sequin, and it didn't always work in the way it was intended to encourage best practice. Best practice tariffs, which are part of the kind of activity-based care, which I'll talk to at the end, seems to be a better way of doing it. I'll talk to that in a second. So per diem is used a lot in other parts of the world, not so much in this country. It's a lump sum payment per patient per day of care, and you can have level 0, level 1, level 2, level 3 amounts of care, different payments based on the intensity of care needed. But as I said, it's used in some kind of nuanced way rather than anything else. And then finally, case-based, activity-based reimbursement is probably the thing that's being used most across the world. It's been called different names. You might have heard of it as payment by results. It's the national tariff or the NHS payment system. There's different ways of calling it, but essentially these are the more activity you do, the more you get, more money you get. And it's based on combination of complexity of diagnosis. So you take your diagnosis, any treatment that's been offered, and patient characteristics, so comorbidities mostly, and other bits and pieces. They get put into a software program, and it comes up with an HRG, a healthcare resource group, which is what the tariff is linked to. They'll talk a bit more about that in the costing and coding talks later on today. Best practice tariffs are a kind of combination of case-based and pay performance. You basically get a slightly higher tariff if you can, if you meet certain quality criteria. So the most there are multiple different best practice tariffs. One of them is for like the neck of femur, fracture neck of femur pathway, where if you reach certain targets, orthogeriatrician review, time to theatre is less than 36 hours, and various other early physiotherapy, rehab, the path, if you meet those criteria, you get a higher tariff. And so that's probably, it appears to be a better way of incentivizing better quality. Case-based, activity-based was the kind of entirety of acute care for many years. It was really good for elective work, and it was probably really important in driving down waiting lists then. The problem was that it probably wasn't truly reflective of the acute care burden of emergency work. And so the sites where you had either had split model where you had a cold site and a hot site did all right, and sites that were probably more elective focused and didn't have emergency care probably benefited more. But it hasn't quite, it didn't quite reflect the acute elective balance of a lot of acute provider organisations. And then there's pass-through payments, which is where the cost of delivery is paid by the commissioning body. It's basically for things like high-cost chemotherapy drugs and very, very specialist, super specialist services. So what we've got currently is a mixture. It's currently called the Aligned Payment Incentive. And this is used for almost all the contracts in England. And there's a fixed element, which is kind of almost like a block bit, which is based on agreed level of acute activity, maternity, mental health, or community ambulance services. It's where you put in your expected best practice tariff achievements and sequin achievements. You put in your CNST contribution. So when you're working out that, negotiating that this bit, you put all the costs of doing all that stuff in there. And so that should be your baseline that covers most of your costs. And then, as I said, in order to encourage organisations to do more elective work, there's this variable element, which is the case-based element to it. So the more elective activity you do, the more money you get. Okay, and that's for elective, ordinary, elective, and day case, outpatient procedures that have a tariff allocated to them, and certain other things. Okay, so that's your first bit of your variable element. And the second bit is much more about your whether you achieve your best practice tariff or sequence. Okay, so that's the bulk of the contracts that are negotiated. And then you get these low volume contracts, activity contracts, which basically are for out of area contracts. So if, for example, people, there's lots of people that go on holiday from London to the Lake District, say, and they probably get, you probably have enough hospital admissions there from injuries and this, that, and the other to have some sort of contract, but probably isn't worth an awful lot. And probably same with London to Cornwall, to be honest. So there's these kind of low values for people, holiday makers essentially, or out of area treatments. So that's the aligned payment incentive. Now I've probably gone way over now. Oh yes, 7 minutes over. Okay. Any questions on any of that? The slides will be shared, and because we've got the talk of commissioning in a second, they might be able to answer some of the questions that have popped up as well. And I don't want to spend too much time. What I'll do is I'll during the coffee break, if we haven't answered any questions that are already there, I will come back to talk about cap and collar and service specifications, but it may or may not be covered in what Anthony's going to be talking about. So apologies, Anthony, I've run a little bit over. So we've got Anthony Brown, who's the Director of Finance Strategic Commissioning at NHS North Central London ICB. Is that right?
Yeah, it's a bit of a mouthful, isn't it? I think, and we've just restructured as well. So I'm now a Director of Business Partnering. So, and you'll get a brand new presentation in the next couple of weeks once we get over the small burden of planning round and year end. So all of your finance colleagues at the moment should be looking a bit like me, very tired with hair falling out. But we'll hopefully get there and we'll get you a bit of an updated presentation. I will just share the presentation that I've got on the screen, if I may. I'll just pop it into slideshow mode if I can. Oops. Can you see that? Is that on screens okay? Yeah, I'll take I've got a hand up. Is that an accident, Emily? Okay, what I'll actually do then, in terms of housekeeping, I won't pause. I'll go through the presentation for you, and I'll take questions at the end. But if there's anything that pops up and you think you'd like to know a bit more information, two things. Obviously, my email address is there. I'm more than happy to take queries and questions during or after this. You can pop them into the chat as well, of course. And then I can also point you hopefully in the right direction if you've got any kind of specific questions for your own organisation. So this is a general introduction to commissioning in the NHS, but I've given it a bit of a start towards London, given that I work in the North Central London system, which is Camden, Islington, Haringey, Enfield and Barnet. But most of what I'm going to go through applies to all systems inside and outside of London in England, that is. So to start off, I thought I'd just give you the nuts and bolts in terms of what happens within commissioning if you're completely unfamiliar with it. Really, commissioning is just a cycle in terms of strategic planning here. The most important thing about commissioning and indeed about the NHS in general is that the patient or members of the public are at the very heart of everything we do. And the wheel here on the right hand side of the slide just shows exactly what is supposed to happen as we go through the year in terms of making decisions about services that we buy in for the local population, and then the various steps that we need to take in terms of ensuring that there's value for money delivered, importantly in terms of finance, quality and clinical care delivered to the greatest possible level in terms of making sure that we're providing a full range of services that contribute to the wider population health in a particular area. So a bit of a mouthful, but at the heart of things, it is a series of planning steps in terms of buying in services, if you like, for the local population. And most of you actually can probably apply what's in that wheel to what you do locally. So if you work, for example, in general practice, you'll commission services, for example, for IT, for various different diagnostic services at hospital trusts as well. For example, you might outsource services if you're in secondary care. That is commissioning in itself. However, I suppose the difference here is that the commissioners, and I'll come on to who they are, do that as the day job. That's their modus operandi. So who are the commissioners, as I've said? So we've got three main bodies of commissioners in England. We've got NHS England. They are the regulator as well as the parent body of all of the integrated care boards and have that direct link up to the department. They're responsible for specialist commissioning services at present. However, there is a massive exercise happening nationally at the moment, or is indeed some of it's already happened in terms of switching over services from NHS England down more locally to regional level. But for the time being, to keep things simple, they are the parent body, and they commission services in terms of specialist cancer, things like AIDS, HIV services also go through them, cystic fibrosis, for example, and rare kind of liver diseases, kidney function, etc. go through NHS England. They also provide some public health services that I've mentioned here in terms of screening, and they provide also the commissioning services for, or responsible rather for the commissioning services in prisons and things like regional secure units. Next on the list we have local authorities. Local authorities, you might be surprised to see them popping up on an NHS set of slides, I suppose, in terms of commissioning services, but they play an exceptionally important role in terms of public health commissioning, and they've been responsible for that since 2013. So there's a big link and overlap in terms of public health and general wider health. And especially as we've seen in the last few years during COVID, that's played an increasingly important role in terms of how we plan for services and how we buy in services in the future. Aside from that, then they also have, via the public health movement in 2013, where that function moved over to the local authorities, they've retained services like sexual health commissioning and school visiting, school nursing, etc. So you will have some interaction with local authorities, and they are responsible for the services listed there. Finally, it's a bit of a catch-all. The Integrated Commissioning Boards, ICBs, as they're abbreviated to, are the final body that do basically everything else that doesn't fit into the two other boxes there. So to keep things simple, it's acute services, mental health and community health care by and large. So that will be district general hospitals, large sort of mental health providers, and a myriad of sort of community services, whether that be provided by the NHS, voluntary sector, etc. Within that as well, ICBs also buy not just from NHS but also from non-NHS bodies. So a large chunk of that is for things like prescribing services, equally continuing healthcare, as I've listed here. So placements for individuals in residential nursing care go via the integrated care boards and to an extent via the local authorities as well. And then finally, of late, well, the last couple of years, work has been continuing to bring dental, optometry and pharmacy commissioning into the ICB as well. And that follows the movement or delegated responsibility from NHS England for primary care services. So if you work in primary care, you will have worked with the ICBs or their predecessor, the CCG, for many years, and they will be responsible for payments since 2015. So moving on, in terms of like the system then, so I must admit that when the reforms first came in, this confused absolutely everyone because we love an abbreviation in the NHS, and I've got a cheat sheet at the back of my presentation to keep people up to speed with what I've listed here in my presentation. But an ICB and an ICS, they all sound really similar in terms of function. I can't remember this one. Sorry, in terms of naming convention and you would think function, really the ICS is the system. So that's the abbreviation. I'll just pull all these up at the same time. So the ICS is the overall system. So it contains lots of partnership organisations within there. So very simplistically put, in North Central London, we've got 10 trusts that sit within our ICS. So trusts like the Whittington, UCLH, Royal Free, Great Ormond Street, they all form part of the ICS or overall system, I suppose, within North Central London. And then within that, we've got something called the ICB, which is the Integrated Care Board, which really is just the to put it very, very simplistically, became the new form of the CCGs, however, with a much more wider set of responsibilities within that. So you can see that I've highlighted here both roles being slightly different and the membership being slightly different. But to keep things very, very simple, if you think about the ICB as the board or membership organisation, the actual sort of statutory function within the ICS, the wider system, and that was formerly where the CCG would have sat. So it's kind of replaced them and then had an additional set of responsibilities put upon it in terms of population health and wider health responsibilities that I'll come on to. The important thing on this slide as well is the governance structure. So over all of this sits NHS England as the key regulator, and then alongside NHS England is the CQC in terms of regulating quality and outcomes. You will all be familiar, I'm sure, with both organisations. The NHS England's role, I'll come on to talk about in a couple of slides' time as well. I've got a video here. I think a colleague put up the new link to the new video. I mean, we're constantly changing in terms of this, so that all of these videos are rapidly out of date. I thought this one actually was general enough to give you kind of a flavour. I won't show it to you now because you'll probably be worn out by King's Fun videos. They are really, really nice to look at and understand and give you the key messages. However, in your own time, I'd invite you to come back and have a quick look at this one because it gives you a bit of a recap of what I've just spoke about. So just to move on then, in terms of the reform and how we got to where we are at present, we started off with clinical commissioning groups in 2013. I'm pretending that PCTs, etc., didn't exist, or strategic health authorities, if you've been in the NHS for long enough, didn't exist, but of course they did before 2013. So there's always been a commissioning function. However, the largest reform in terms of the current state was 2013, the move away from PCTs and the establishment of the CCGs. After that, then we had a period of, I guess, constant flex, where we were increasingly moved towards system working and system targets. So 2015 rather through to 2019, and then in 2019 it saw the advent of the recommendations that would then become part of the Health and Care Bill of 2022, thereby forming ICSs. So I suppose that the takeaway here is constant reform, constant redesign in terms of actually how the health system works, the setup of the health system and the management of the health system, as each of the governments had their sort of input into actually how health and care services should be delivered. The latest report was the Patricia Hewitt report in 2023, and then since that, I suppose that you could also add some of the work that the former health secretary put in terms of some of the reforms around the ICBs more locally, and the requirement to shrink the ICB footprint by 30%. Moving on then, in terms of actually what this looks like in hopefully a rather simplistic format. I like pictures rather than words. So we've got a map here on the right hand side that shows indeed how we split things across the country. It's color coded, so that the colors do mean something. They're the regional areas of NHS England control. So being London centric here for a moment, if you allow me, 7, 8, 9, 10, 11 are our region, the London region. And so we report to London region of NHS England, and our ICB, and indeed the ICS, is at number 8 there on the map, which is North Central London. The 4 key aims then I've listed here, and those kind of wider responsibilities that I talked about in the previous slide, are obviously not just to focus on improvement in population health and care. There's wider focus to start to talk and think about inequalities, and, as you would expect, outcomes and experience in terms of the patient journey through healthcare services. Equally, and really important for me, is the productivity and value for money challenge, being a finance person. And then broader from that as well, and a new requirement is the wider determinants of health and social and economic development. So developing that, thinking about things like a healthy population and the impact that might have on unemployment across a particular area. I've transposed in here just a very, very high level schematic of what we've got as a strategic plan within the ICB. So it's very, very simplified rather, but it gives you kind of an idea of how then we start to take those 4 key ambitions that we set out on the previous slide and deliver them. The key words for me that I've just picked out here are the prevention strategy and things like integrated care and working together as a system, and they complement the national targets as well. So this is the NHS England plan on a page for 23-24 rather, and it shows the main targets that NHS England have set itself, and of course if the regulator and the parent body set itself these targets, then they filter down throughout the system. And most of the things on this slide you'll recognise either from your own work, or national and news reporting on particular areas of concern or areas of performance that need to be redressed. So going through here, the A&E waiting times, I know we've already spoken about on this call, things like access to GP services, and then importantly, again for me, being finance centric here for a minute, number 7, the productivity and efficiency increase, and the requirement to deliver a financial balance across the system. Finally, then sort of developing all of this then and just showing you how it works in practice. I'll give you kind of a high level explanation of what the ICBs are moving towards in terms of system working at a very local level and then wider across the ICS, and I'll try and apply that to some real examples then. So just setting out here the different categorization of how each of the ICSs and ICBs work. It's obviously really important given that the scale, and we are quite a large system of circa sort of 2 to 3 million in north central London. It means that if we did everything at scale, it would absolutely not address those differences and pockets of deprivation, pockets of prevalence in terms of different diseases. So we cut the work up accordingly and focus on a neighbourhood level, a place level, and a system level. Sorry, I've skipped along. So moving from a neighbourhood level, this is the lowest level that we have in terms of commissioning and work across the system. It's as you can imagine, pulling in clinicians such as GPs, dentists, optometrists, and pharmacists. It tends to focus on primary care at this level, and you will hopefully be familiar if you do work in primary care, but even outside of new functions or primary care networks, so clusters or groups of practices working together to focus on what they need to commission or how they would deliver services for their local population. Moving upwards from that, then we start to then see those PCNs and those clusters of primary care professionals then working with the wider system. So then focusing on more involvement from local acute trusts, mental health providers, councils, and then the voluntary sector as well. And this is where you start to build up services at a place level. So within North Central London, we would think of place as mean perhaps a local borough, so the London Borough of Camden, for example, whereas within the neighbourhood level, it would be an area within Camden that would be of particular focus. And then finally, I think I've skipped over the system slide here. The final part of putting all that together would be at a system level. I think I would just bring us through actually to how we actually do this at an ICS level to give you a more contextualized example. So this is the ICS or the system level view of what we've got in North Central London. So it's 5 boroughs, as I've already mentioned. The makeup of our system is the fact that we've got quite a lot of very different providers there. So we've got 10 in total that actually sit within our system, but we've got 12 different providers that provide services for North Central London, given that some of them are slightly outside and on the border. And you'll see, just looking down the list there, that we've got everything from district general hospitals, local mental health trusts, to nationally recognised or internationally recognised organisations such as Great Ormond Street and UCLH, Royal Free and Moorfields, for example. So as a myriad of different organisations making up what we've got in the North Central London system. On top of that, then, not forgetting the fact that we've got primary care networks. So within this, and not numbered here, are 33 primary care networks, and they all serve a population of just over 1.5 million people in North Central London. The complication then, of course, is that people move around, as we've already mentioned in these presentations. And so if people move around, so does the money as well. So you can't just say to an individual living in North Central London that you must remain within the boundaries, and you can't have your health or care services delivered from outside of that. And as such, the way that we get funded is based on our local population within our fixed area. So the money that we get from NHS England to deliver care and services for our residents is for the residents of North Central London. But of course, those people will move around and have services delivered from elsewhere. Equally, given the fact that we've got large tertiary trusts and nationally renowned organisations providing services within London, we do tend to suck care in from outside of the patch. So you can imagine that if you lived, say, in Harrow in northwest London, the journey into central London wouldn't be a problem. Equally, if you had a specialised requirement for services, visiting Gosh, for example, would be seen as a common practice in terms of the pathway of care. And so I've tried to show here in terms of the complexity of how things work, but from a system perspective, our trusts, the ones I've listed on the previous page, attract £5.6 billion worth of funding, but within that, £3.5 billion comes from North Central London ICB, and the rest of the money comes from a myriad of different providers or different systems outside of North Central London. So highly complex in terms of how the funding flows, and the key part for us in terms of our role within commissioning finance is to support the trusts and understand those flows, how these things all fit together, and importantly how we can manage financial balance when you've got such a complexity of different streams of funding coming in from different areas. Just showing you then much more simplistically, let's keep this as simple as possible because it can get complicated, is the split of how the funding works within our ICB. So overall, we receive £3.5 billion worth of funding each year. Not all of that will obviously go into the trust that I've just mentioned. So we put just under 1.8 billion into the acute side of delivery. There's obviously a huge amount of additional responsibilities. If we focus all our money on acute and didn't focus anything on the prevention side of things or on continuity of care, primary care, then we would have more and more requirement to pull funding into the acute side, and it would eventually lead to a position where the system would become unsustainable. So we plan carefully how that funding is split across the sector. A lot of the attention at the moment is about prevention. A lot of the attention and focus is obviously about addressing waiting lists and addressing backlog. And then equally, we've got a huge challenge in terms of the UEC, the urgent and emergency care pathways, and how we properly address and fund those areas. And to do those right, the key part of our role is to also make sure that we don't completely inundate those areas of the system as well, and we make sure that care is delivered and is funded appropriately in the respective areas to the left-hand side of the pie chart here. So the split shown on the pie chart gives you kind of a flavour of how things work across North Central London, but it will be fairly similar, I would have thought, certainly across London, and then in other parts of the country you'll see a fairly similar sort of pattern of expenditure. Then finally, just to sort of round off in terms of some of the work we do at system level. So within finance, we've got several principles that we've set out across our ICS. They will be not massively dissimilar to what you will be having in your particular area, and I'm sure within your organisation as well. It's all focusing on transparency. It's about if we can do things in a standardised way. It's about that sort of internal challenge and making sure we're delivering value for money and we're accountable for public money, and equally then making sure that we have a sustainable long-term plan as well, given the financial challenge that the NHS is under at present. It wouldn't be a finance presentation either without sort of mentioning some of the more vanilla stuff around regulation. We've got a massive set of targets to hit in terms of the financial challenge. Some of those are listed here. The key ones on this table are the financial balance principles. Within the ICB, however, we need to make sure that we're not exceeding the amounts that we get from NHS England in terms of funding, and there's very serious penalties which I'll come on to in a moment if there is any kind of pressure from a system or an ICB perspective. So really important that we get congruence in our goals in terms of financial targets at a trust level and at a commissioner level, and then equally as a system overall that we balance off. And the regulation that I spoke about previously has developed into a position where we're now able to tweak things. So if a certain provider is finding it difficult to come in at a certain level, then other providers can offset that. And the system balance is the key part of what NHS England are looking for here. If you get in real trouble, then just to round off here on a happy note, we've got something called the system the strategic oversight framework, rather. I've misdescribed it there. So, yeah, so it's the strategic oversight framework, or SOF. There's 6 different levels for SOF here, which sorry, 6 different key delivery areas rather, and then 4 different measurements for SOF. So this is like the league table, I suppose, in terms of high performance and little regulation to various serious and complex issues, and a lot more regulation. So what we've got in this table here works from the previous slide of the assessment of how well a particular area is performing, a particular system is performing. This is where NHS England come in, and to a certain extent the CQC come in terms of understanding their performance in these 6 key areas. Finance and use of resources is obviously the one I tend to get dragged into, but we'll have other involvement across each of these different areas, and then you'll get graded in terms of your overall performance. And this is how, generally speaking, we're regulated and managed from an NHS England perspective. The SOF 4 side of things is what tends to make HSJ. Most systems at the moment tend to float around sort of 2 and 3. There's very few in 1, and there are a few that have moved into SOF 4. I think around Manchester of late are in SOF 4. What that means in practice is a lot more regulation, attention, sign off of financial plans, sign off of financial delivery, etc. From a regulator perspective. So it means that you're slowed down in terms of actually your decision making until you can actually provide a plan and a recovery strategy to move out of that area. On that joyful note, I've just to round off, I've listed a glossary or jargon buster there for you in terms of some of the terms that I've mentioned in the presentation. And like I said at the start, if there's anything that people want me to go through, I'm happy to have a quick chat now. And if not, then you have my email at the top of the presentation. More than happy to have follow-up questions and to try and help out as much as I can. So back to you, Kate.
Thank you. I think there's been a couple of questions in the chat. So it says something about, would local authorities commission services under health budget or social care budget? I think it was probably related to something you mentioned earlier in your presentation.
Yeah, so they would get a what is the public health grant sent over to them from the Department of Health. So it would be it's funding for the local authority. So actually, let's keep this really simple. So for public health services, they get funding directly from the department for public health services alone. However, and there's always a however here, there's a myriad of services that we provide in conjunction with the local authority here. So if you think about potentially a relative that will have gone into a care home, for example, they'll have an element of that care that is social care related potentially, and an element of that that's nursing care related to address their health needs. So you, as you can well expect, there will be a contribution from health and a contribution from the local authority, and then a sort of a series of agreements that underpin that. Aside from that, the other big area of overlap that we have with the local authority is something called the Better Care Fund, which is there to address things like discharge and flow within the overall health system and social care system. So I'll simplify it by saying that most of the money that the local authority get for public health services is a grant from the department, and is quite clean. It's there for public health services, and then there's a huge amount of overlap and funding that crosses in both directions, by and large from health into social care to fund services that support both health and social care in the wider system. So complicated, but the simple answer is that they get direct funding for the stuff that they're directly responsible for.
Thanks. And then there was something about integrated neighbourhood teams. Is that something that's coming? Is it already there?
Yeah, so much of what I put in that part of the presentation is from Fuller, and I'm sure you'll if you've not been familiar with the Claire Fuller report on primary care and sort of system and neighbourhood delivery, it's very much worthwhile reviewing that. Integrated neighbourhood teams absolutely are part of the piece that that the Fuller report talks about. So I'd invite you to sort of go back and have a quick review around that. It's really just a function of how we deliver things at a local level, I suppose. And so I've put in the jargon buster there some of the terms. It's an iterative thing completely, and so we're seeing lots of different means of actually delivering services at local level in different areas, but Fuller tries to sort of pull it all together and make some sense of what's actually happening and give some guidance about how delivery can work better at a local level. So I would suggest that if colleagues wanted to find out more about that, that would be the report to go to, and I can put in a link to the chat if that's helpful.
Thank you. And then I think finally for you, I think, is how are regions funded NHS England to ICSs? Do ICSs enable regional capability?
Yes, they do. I mean, so we get funding directly from NHS England, and that's given to us at an ICS level. So we'll receive, I think I put in the slide there, about in the region of sort of £3 billion worth of public funding would come directly to the North Central London ICB, and then we would distribute that out amongst all of the different healthcare providers. It's that pie chart that I showed you in the presentation. That's how we would distribute that money across the system. And then in terms of sort of a regional context, then we would have conversation then after that, not with the national NHS England team, but well, we would do if we are often talking to the national team about various different things, and depending on performance or funding constraints or your overall sort of position across London, you will have a conversation with either the national team or the regional team. But the regional team of NHS England are the area that we tend to have those discussions with most of all. So I suppose to answer the question, it does actually enable regional capability. We do have an awful lot of conversation, obviously with other parts of London as well, to make sure that we're getting the contracting right, we're getting the services right, and we're not doing things that would otherwise complicate patient pathways as well. So a really good example of that was a couple of years ago where we had cancer and cardiac services and at Barts and at UCLH. Of course, that both those services still exist to a certain extent at both of those large trusts. They're not massively far away from each other, and so the decision was taken to have UCLH focus on and put in quite a lot of the cancer services and cancer funding, and the specialism of cardiac to be more developed on the Barts side of things. So the conversation in terms of commissioning, where we develop services, how well services are developed, and how the funding flows is a really, really important discussion to have at a London level. So that's where the London region, the NHS England London region fit in terms of helping out with the more sort of strategic London level discussions. But there's still that role for each of the different parts of London to have that conversation equally as well.
Thank you. Thanks, Nancy. I think that's most of the questions to you. I'm going to go back a bit to some of the questions that were at the end of my presentation to make sure I covered all of those. And you might be able to help, actually. We've got a question about community services block contract, but with no service specification. As you're probably more into it than I am, any comments on that? Or
yeah, and we've got a sort of similar question about kind of community trusts still being the poor relation to acute trusts as well. And I suppose so I can talk about absolutely what we're doing in North Central London, but I think it would answer the same question. So on our patch at the moment, what we're trying to do is to make sure that we're developing the community services offer and so that sounds like such a commissioning term. We're trying to make sure that community services have a core offer that they can deliver for patients, and it's consistent across the patch. And I think that there's been underfunding because of the mechanisms that you just described actually in your presentation, and the requirement for things like PBR, so cost and activity, meant that a lot of the funding in the NHS was pulled into the acute side of things. So it was overperformance. It was often pulled in to the acute, and it was driven by that. And community, and to a certain extent mental health, has been block contract delivered for many years now as well. There is work to develop a tariff or a currency for mental health to try and support that, and there's also been a focus on mental health in terms of the investment standard, so the target that each of the systems need to put in terms of expenditure in mental health, because there's a realization that mental health and physical health we're not at parity in terms of investment. But I haven't spoken about community here at all, so that's sort of fallen in the middle here in terms of investment, and the key risk here is that if you do not have properly funded sustainable community services, then your acute services are going to get completely overrun, either immediately or in a couple of years time, 10-20 years time, with population growth or with increasing acuity in terms of presentation. So I think that there's a couple of key things here. It's about right sizing and making sure that the amount of funding moving into community services is at the appropriate level. And there's a really important role for the commissioners here, and indeed public health, to start to plan that. What's the population looking like? What's the prevalence of disease? What are we seeing on the acute side? And then to get that right, you need to have service specs within the contract. So in terms of understanding what you're buying, making sure that it's really clear in terms of delivery. Can we compare one community organisation to another? It's really, really important. So we're trying to make sure that we've got clear service specs and clear, we can clearly segment a contract and say, right, I can see a services in there, it's being funded, we're doing things really transparently here, and we're identifying, there might be not enough district nursing in a particular area, we need to beef that up. We might be overfunding something in another particular area, you might need to move some funding around. So it's really, really important to have a service spec there that's properly developed. But the key part of all of this at system level is transparency about where the money goes and about quality and outcome in terms of the contract. So completely subscribe to commissioning for community needs much more attention, so we're trying to focus our attention on that in North Central London, and we've got a massive programme of care to redress that within North Central London. We're investing, I sound like a politician here now, we're investing £60 million over 5 years on that. We've all signed up to that. You can go to our website and see how that plan is developing, and it's a really ambitious plan, and we do hope that all of that can be pushed out to the right areas of community. But to get all of that right, and to make sure from a financial governance perspective, and to put my director of finance hat on here, I need to make sure that money's being well spent as well, and I can understand what parts of the community services are being funded by this new investment. So really, really important that we have transparency in terms of service specs as well in there.
Thank you. I'll talk about some of my thoughts about the issues around the payments, how the payment system has probably not helped, or the differences in payment systems has probably not helped the issues with community and mental health services a bit later on, because we're running a bit over. And then just a couple of quick questions. I think just that I got a cap and collar, basically related to the activity-based contracts that were purely activity-based, and it was just one was as a lower limit and an upper limit, just meant that there was restrictions, and so an organisation couldn't do thousands of operations and basically overload the commissioner, and the commissioner would then go bankrupt or not be able to provide funding for other areas, and also guarantees a minimum kind of for the provider. So that's what a cap and collar is essentially bookends for the activity-based contracts. Foundation trusts are funded, essentially they are now funded in the same way as all the other organisations, in that they are commissioned to provide services by the ICB in the same way as all the others. They are theoretically independent, but not really independent, and the government is slowly changing legislation to bring them back into the fold to reduce their independence because of issues in the past. Mental health for young people at the moment is funded primarily through, well, the specialist mental health, so hospital mental health is the CAM services are through specialised commissioning at the moment. Is that right? Still, still.
No, so CAM services are a mixture of the commissioner, the ICB, and specialised as well. So it depends on the tier of CAMs. But most of that will be flowing down to the ICB in due course as part of the transfer. Yeah, and the wider part of that in terms of actually the planning and funding, children's services in mental health in particular, the growth in that should be outstripping adult services. So the percentage growth year on year should be outstripping adult services. So we'd invite you on this one to have a look at something called the Mental Health Investment Standard, which sets the target for each organisation in terms of increases in expenditure. So again, I'll put these things into the chat so people can come back to them. And I think somebody else said something about the glossary, the jargon buster. I'll just make sure that the pack is available for people as well.
Yeah. So we're going to have a quick. We'll probably have a slightly shorter screen break of maybe about 7 or 8 minutes because we are running over. And we're going to talk about procurement for in a second with Mark Ibbotson. I will say that there is a one NHS Finance glossary that we'll send out as well. It's a PDF. It's about probably 10 pages. It covers all the it's a quick reference guide for loads of different terms you might find in NHS management speak, particularly finance in the finance world. So you'll get that with your packs and slides. So if we get back, we'll try and aim to start in about 7 or 8 minutes, enough time to put the kettle on and make a cup of coffee or tea, and pop the loo. And I'll put the agenda up. Aoife, can we put the agenda up on a link or something, please? Yes, just so that and that'd be great. Yes, so we'll see you in 7 or 8 minutes. Thank you. Right, I think we'll slowly start again. So I'd like to introduce Mark Ibbotson, who's talked on these events for a while now. Who so thank you, Mark, for coming along again. And you're the learning lead at development lead at the Healthcare Supplies Association. So thank you very much for coming along and talking to us again.
All right, that's no problem. Good morning, ladies and gentlemen. I like to try and use this session as a bit of a question and answer. I'll talk about a little bit about procurement, and then if you have any burning questions, then please feel free to fire them at me. I know you're a little bit behind schedule, and normally I can we'll make a little bit of time up. But I think the main thing is that procurement is about 5 things. It's about having the right quantity in the right quality at the right time in the right place at the right price. Very, very simple philosophy. And the amount of times that we get it wrong is quite incredible. And I think I was just listening to the last speaker, and he was talking about or trying to answer questions around not having service specifications for some of the stuff that you do. And the issue with that is, if you don't know what you're buying, how can you manage it? And I think one of the criticisms that the NHS frequently comes under is wanting to change things. Now, there's no issue with changing things, but you need to have an idea of what it is that you want in the first place. And I'm sorry if that sounds a bit kind of in your face. It's not meant to be. However, the amount of service contracts that I've been involved in where people want an input, and that's fine, but then they want to start changing it further down the line. And as soon as you start changing it, the supplier comes along and says, yes, we'll change it, no problem, but it's going to cost you. And I think one of the issues that we have at the moment is, again, as the previous presenter said, budgets are getting tighter, and they're only going to get tighter and tighter. So going back to fundamentals, what is it you want? How often do you want it? Where do you want it? Are all kind of simple questions, but they're actually quite complex answers. Because at the end of the day, a lot of you guys are treating patients and everybody's different. If we were all the same, it might be a little bit different, but it isn't. So communicate with people in procurement. I know most people seem to think that you sit in a darkened room and don't like answering the phone to anybody. And that's perhaps a slightly facetious comment. Talk to people. And one of the things that I used to like doing, and I sometimes used to have to take a tin hat, is go and meet people. Go and chat to them. Find out what it is that they want. Because what you get on an email, or perhaps what you might get on a requisition or whatever, isn't actually what they want. So please go and talk to them. And I found the best place to talk to people is around a coffee machine, because it's less formal. You can actually have a conversation rather than a formal chat. And I know there are a lot of issues around at the moment with procurement. There's the new act that's due out in October of this year. There's also the PSR, which is coming into effect from the 1st of January this year. And all these have an impact on you. And sometimes trying to get through that information is like platinum fog. So the guys in your procurement teams, whether it's at ICB level or whether it's at trust level or it's a community base, ring them up and ask them, or even better, go and see them, or get them to come out to you. Because one of the issues that I've generally found is the communication that actually kills the procurement rather than the facts and figures that you dealt with. There are certain trends we have now within procurement. There's obviously an emphasis on sustainability and what sustainability means. I mean, we've got 350 kind of different trusts and formats. It'll mean different things to different people. So let's have a look at what sustainability means. We've also got a greater use of technology. I know some of our technology is quite old, but the rise of the digital arena is happening. And it's also going to have a knock-on effect for some of the kit that we have. Will it all talk to each other? I have a very simple thing. I use Windows on a Mac, and they hate talking to each other. And it's little things like that, yes, oh, our kit will do this and that and the other. And when you actually plug the two together, it doesn't. So again, technology is brilliant, of course, until it doesn't work. And that's a different issue. That's when you need service contracts in place to get it sorted out. There's also an emphasis on risk mitigation. And a lot of this stems back to the specification. We are risk averse by nature. Certainly procurement people are. And if you get lawyers involved, they're probably even more risk averse. So let's have a look at what risks we can take out, because every risk that we take out and try and push over to the supplier, there's going to be a cost involved in that somewhere. Emphasis on supplier relationship management. One of the issues that I had all through my working career in procurement is that reps coming in to see clinicians and persuading them that their kit is the only bit that will work, whether it's goods or whether it's services or whether it's physical kit, capital kit. And of course, when I go and start talking to them about, right, let's get the procurement together. Oh, there's only this bit will do this particular function. But if I ask 5 people in different trusts all the same question, I'll probably get 5 different answers about which is the best kit for whatever it is. So I think we've got to look at what's kind of best value. I'm not here, and your guys aren't there, to get the cheapest piece of kit that you need. That's not our job, because at the end of the day, we've got to look at the best value for money over a period of time. Now, sometimes budgets may restrict that, but if you can put good business cases towards DOFs, then that goes a long way to actually trying to resolve some of the issues that we have. Okay. And there is a trend in procurement from going from tactical to strategic, and that's one of the roles of the ICB or ICS, depending which part of the function you come from, as to whether we can do things more collectively. And I know filtering that down with DOFs and clinicians can be quite a political, a minefield route, let's say. But at the end of the day, I've always found that people are very good at spending other people's money. And the thing is that a lot of DOFs seem to have this old biscuit tin that they used to produce money out of. That ain't there anymore. The financial pressures that you are under, you're going to have to take some fairly bold decisions over the next few years, because I can only see the financial situation getting worse. I can't see it getting better. I mean, we've only got to look on the television and the current affairs programs about mental health, particularly, and the way that that's grown over the last few years. And we seem to have more and more diseases and diseases that fracture. I mean, when I was a kid, you kind of got chicken pox, measles, and you had your tonsils out, whether you liked it or not. But at the end of the day, we're developing more things. We had COVID, and we don't want to be back in that situation where we couldn't get goods and services that you required. And we all kind of got through it eventually, but the stresses and strains, particularly put on you guys who are on the front line, was incredible. We tried to support you, and I think most of the time it probably worked. Sometimes it wouldn't, because we got let down. But that's, again, an element of risk mitigation. How do we deal with that? How do we ensure supply chains are there to ensure that you get the goods? So we learned an awful lot in procurement about basic economics, supply and demand, and what the dollar would be able to buy you over in China. So I could see areas around people literally being on the docks. One had a bigger wad of money than the other, so the one with the bigger wad of money got the goods. But we had to wrestle with that. And there's also an element around, do we start to look at looking more locally to source things? But there may be a cost to that. So we've got to do all these kind of balances. So again, we talk about transparency. Suppliers are very quick now to take us to court if they think there's something wrong in the system. And it's an area that we don't really like. We don't like to be in the public eye around finances, about one supplier saying that I feel aggrieved about this. So we've got to show equity. And a lot of these new acts that are coming through are trying to do that. You follow a process, and I'm afraid, you know, we have to follow the process. But it does give you a little bit more flexibility. And talking to suppliers, what's happening in the marketplace? What's doing here? What's doing there? What's the best thing for this? And actually talking to suppliers, which is a healthy thing. Although when you start getting to commercials, that's kind of when you probably need to bring your procurement people in. Is let's find out what's happening in the market, because what you don't want to be doing is buying old kit. So again, what I'm trying to get round to, or coming back to, is let's think about quality, quantity, time, place, and price. Because if you want top quality, the likelihood is you're going to have to pay top price. That's not always the case. And one of the advantages of having an ICB in place is potentially they can do a more collective one around all the trust that you have. Generally speaking, the more that you buy, the cheaper the unit price is. Doesn't always happen, but that's quite often the case. But it's also about making sure that everybody gets what they want when they need it. I've done some brilliant deals in the past, got some cracking prices, but they've sold the stuff to somebody else because they can get a better price. So again, that's about risk mitigation. That's about trying to manage your supply chain. So there are all sorts of issues happening. We've got local suppliers, we've got NHS supply chain who do things on a national basis. They develop frameworks that you can buy off. They produce category, we used to call category towers, but they are about trying to manage the market globally. There'll always be stuff that you buy locally. You know, things along the lines of funeral services can only really be managed locally or in a geographic area, because it's just not practical to do it any other way. But what we need to look at is how can we work together to make the book that we get from NHS England go that bit further and improve the quality of the care that we give to patients, because that's what we're here for at the end of the day. I'm a back office service to you guys. I try my best to get what you want at the best commercial rate we can achieve in order for you to be able to do more. And I know that's difficult at times, and I'm not always the most popular guy at the table. But at the end of the day, we've got to do a balance between ourselves, and that comes down to communication and face to face. So, you know, I've had conversations with people, and you can hear crisp packets rustling in the background, and you think, this person didn't take the nails to me. So we're not. So hope, and people will ring the office next door. Just get off your button and just walk around. It's simple. And go and give the coffee machine a hug. The amount of information you'll find at the coffee machine is phenomenal. So what we're trying to say here is, let's communicate. Let's be quite definitive in what it is that we're looking for, whether it's good. It's easy to do goods. You know, you can see it, feel it, touch it. It's more difficult to do services. Okay. So I think we've got probably about 10 minutes left. What do you want to know? And I'll sit here and I'll put my tin hat on, and I'll take any questions that people want to throw at me that I can answer reasonably. If I can't find an answer, if I haven't got an answer, then I'll find one out and come back to you. Deep silence.
I'd raise my hand. It's probably so many people you can't see my hand.
Okay.
I just wanted to ask, is it, I'm a clinician.
Yeah.
Is it not, it's almost a politically incorrect question. Is it mandatory for a clinician to be to have input on procurement, or should it be?
The NHS doesn't like mandating anything, does it? Because then it has to take responsibility for it. If it's one of the biggest benefits over the recent years has been the introduction of clinical procurement people, because I can talk legal, I can talk commercial, I can't necessarily talk clinical, and sometimes clinical can't talk legal or commercial. So, and I don't mean to offend anybody in that respect, but if you are buying something, I would say that perhaps non-consumable, then it's critical that you're involved in that conversation, because you're going to use it. I mean, if I'm buying a tin of beans, I know what a tin of beans looks like, what it tastes like. If I'm buying a clinical piece of kit, I've probably got a good idea of what it may or may not do, but you're going to use it, so you need to be involved quite heavily in that decision. That's my view, anyway.
Yeah, I'll use your caveat of not without offending anyone, but we find that most of the time, at the beginning when you've talked about service contracts being changed or needing change, costing more, most of the time, you may or may not agree with me, it's because people on the shop floor haven't been involved in that decision. I probably sound like a grumpy consultant, but that's my experience, that whenever service contracts are signed off, big, things are kitted out, but no one actually asks the people who are on the shop floor.
Well,
and I think that is critical to costing, especially because clinical services are constantly evolving. What we did, I'm a breast radiologist, what I did 5 years ago in my service has changed. What I need now, what I use now, unfortunately has increased because of the complexity of what we do. And it's the same thing for costing as well. I feel like every step doesn't get involved, and which is why I'm on this course, because I thought, you know what, I need to, if I expect people to ask me, then I need to know what I'm talking about.
I mean, I take your point. I think there are a number of issues there. That one, if you have a committee of people, a large committee of people trying to define something, it takes forever. Okay, and I've been in situations. I've been in situations where we've had, let's say, on orthopedics, people saying, "I'm representing all my colleagues," and at the end of the day, some of those colleagues turn around at the end and say, "Well, I'm not using that piece of kit." And you kind of go, "Well, we've engaged with people. We can't engage with it." Obviously, it depends on the service. I mean, I used to have about 50 orthopedic surgeons, so you can't take all 50 out of service to discuss nuts and bolts. Yeah. But I think it is about communication. It's about understanding the process, what's involved, because quite often you find you'll buy a service or a piece of kit or whatever and find, oh, we haven't included that. Or the director of finance will say, well, I know it's going to cost you 200,000, but I've only got 150. What are you going to chop out? So I think what we have to do is, if you're not happy, go and talk to somebody. And whoever, normally you have a project manager in charge, and procurement may or may not be brought in at the start or towards the end. But you've got to flag up these things. Have you thought about this, and this, to make sure that, because a lot of people look at care pathways, but the care pathways are quite complicated, because if you've got diabetes, you might end up with ulcers, and you might end up with this or that and the other. So it's not just that care pathway, it's about looking at the bigger thing. However, whatever the bigger thing is, you have to specify. And this comes back to the point that the previous presenter said, you need to understand what you're buying. Yeah. Does that make sense?
Yeah. Yeah. I get the point, and I also understand, what you said about not everybody can be at the table. But I
Yeah.
also realize that a lot of people avoid us as clinicians because then we bring complexity to what would be easier to just sign off and send.
Yeah, I kind of get that. I mean, because, and that's where, to me, that critical link of the clinical procurement people, because they talk your language, they will understand perhaps the nuances of what you're doing. I don't. I'm a generalist. I mean, when you consider, I mean, I was one of the largest acute university hospitals in the country, and I'm a generalist. You know, I have to keep that hospital going with baked beans or a CT scanner. So I don't have the depth of knowledge that perhaps you as a clinician would expect me to have. I would have a reasonable idea because I'd do some homework before I came to see you, and at least we can talk the same language. And that's what I'm saying, that these clinical people, clinical procurement people, will understand the language that you're talking, whereas I perhaps don't. So that could be a link that you may well have at your organisation,
or maybe should lobby for.
Yeah, by all means. They're a great tool.
Thank you.
Okay. Anybody else? Oh, the silent majority.
There are questions in the chat.
Yeah.
Oh, right, sorry. Let's have a look. Okay. How far back do I go? Now, it's good practice shared if a trusted ICB. Let me start at the bottom. I feel the biggest now management in the NHS generally is managing with key stakeholders. Yeah, I think that's an observation. Too many people attend meetings, nod their heads to give ill-informed opinions. People are strange, aren't they? I mean, a lot of stuff is now done by video conferencing, and it's very noticeable that certain people try and hide from the camera. They don't want to be seen and they don't want to contribute, yet they will criticise at the end. I think that's where you need a good, strong project manager to get that involvement or inclusion into the decision. It depends what the culture of the organisation is as well. We merged two organisations together. One was quite a bit of a laissez-faire organisation. The other one was very much a dictate. So when the two cultures came together, it was very, very difficult for a period of time. But there's no point in just being told what you're going to use. It might not be the best for your patients at the end of the day. And that's certainly what I always thought I was there for. Clinical and service directors need to build relationships. Would totally agree with that. I think the kind of theme that's coming through is you don't get enough involvement. And I think sometimes maybe you wait to be asked, but maybe you need to kind of volunteer your service a bit earlier in the process, perhaps when you find it out. Good practice is shared, certainly at ICB level, and there are certain portals that the procurement have access to, where people will always tell you about what's been done well. I also think we need to start saying, well, actually, this didn't work too well, and it didn't work too well because of this. So when we've actually done a procurement, or call it a project, do we go back and look at lessons learned from that project? We probably don't spend enough time on doing that. And I think that's where, because we're firefighting most of the time, and particularly you guys, let's try and just take a little bit of stock, because then we hopefully we can improve it next time.
Hi Mark, it's Pam.
Hello.
Yeah, I'm just helping AK chair the session while is off doing something else, and I'll be chairing the session this afternoon. There were a couple of questions towards the beginning of the chat, generally about why stuff is more expensive through procurement and frameworks, whereas it's cheaper to get through directly on things like Amazon and other direct suppliers. I kind of know the answer to this, but I'll let you as the expert give the official guidance.
Yeah, thanks for that. I think that there are a number of reasons. One, there's a cost behind the scenes. If you buy something what we would traditionally call non-stock, the cost of the back office to actually procure that is significantly higher than if it comes through either a supply chain or through some of your Oracle. A lot of people are on Oracle now, Oracle systems. Also, some of the stuff that's bought isn't fit for commercial purposes. It's only fit for domestic purposes. And the classic one used to be toasters. How many toasters set off the fire alarm and the fire engine comes? We got to the stage where the fire service said, we are going to charge you if we get any more toasters that burn the toast and set the fire alarm off. So I think it's a bit like the traditional kind of PCs that you used to get. Like the trust might say, right, it's 800 quid for a PC. Oh, well, I can get one from PC World or whatever for 250. Yes, but you haven't got all the software on it. You haven't got all the firewalls, etc. So it's not just about the cost. It's about the whole package and why we don't, plus the fact we don't always have direct access to things like Amazon. And I know it's always going to be, it's been there ever since Adam was a lad, this kind of discussion. Procurement will try and make sure that they tick all the appropriate boxes for whatever it is. If it's 50p, I don't suppose it really matters. But once you start getting more and more than that, and again, I go back to the point I made earlier, it's about risk mitigation. If you go, I've had one or two stuff from Amazon on a personal basis, and when I've got it, it's just not fit for purpose. What it says and what it actually is two totally different things. So hopefully that kind of gives you a feel for that. So is there any more?
I think there was a question around whether we do national procurement and regional procurement to obtain bulk purchase discounts, and whether that's something that we do as a procurement team.
I think some of that depends on the trust or trusts. We're looking at national. NHS supply chain are principally a national body. There are other ones. Some procurement in ICB varies across the patches. Some are trying to do more and more collective procurements, but getting people to agree. Getting people to agree in a trust is one thing, but getting them to agree over a patch where traditionally there might be political issues, let's say, between trusts, is very difficult. So I think one of the trends that I mentioned earlier was about transactional to strategic. The more we get in place on a national basis, and not everything's suitable for national. If you're talking about your local fruit and veg and all that kind of stuff, that probably needs to be done more locally. If it's frozen, that's a different issue. Certain things will sit on a national basis, then on a low regional basis. I mean, many years ago, and generally what goes around comes around, we used to have sensitive responsibility that used to specialise in certain areas. Some people may remember that. So it may well be that an ICB will look after a certain a certain set of goods for the whole country and kind of share it out a little bit. So I think some of the stuff is right to be done nationally. some of it is right to win regionally, and then some of it is right to do locally. And I think that it varies on the product or service. Anything else?
So before I go back to the chat, I just wanted to check whether our next speaker was available. I think it's Georgina Dean. Hey. Oh, hi Georgina, how are you? Long time. So I think I'm not able to hear you actually, Georgina. Let's try again. Can everybody hear Georgina?
No.
Okay, so we're just going to Mark, you've been wonderful today. Wonderful talk. There's been lots of engagement and lots of questions. I was just checking the agenda for today, and I think we've gone slightly over time. I'm going to give an opportunity for one last question if anybody wants to perhaps say any last comments or any last questions for Mark. And if not, then we can kind of move on to our next presenter.
If there are any, if there are any questions, please, if you collate them, then send them off to me, and
Fabulous,
I'll do what I can to. But other than that, thank you very much for your time.
Yeah, thank you with your expertise on this very specialist subject, and wish you a wonderful rest of the day. Thank you.
Okay, thank you.
Thank you.
Bye.
Thank you, Mark. Hello, Georgina. We're going to try and see.
Can
if
you
we
hear
can
me
hear
now?
you. Yes, we can.
Okay. I left and rejoined, so there we go.
I'm helping AK chair the session today, and I just wanted to make sure that we were running on schedule, and I was a little bit concerned that we'd gone over time, so I just wanted to check that you were here, and wanted to welcome you to the Demystifying Finance session. So I've known Georgina from, I think it's about 12 years ago, 10 or 12 years ago, when we used to work at Birmingham Children's, and lovely to see you again. And Georgina's going to talk to us today about the journey to an integrated care system. So Georgina, I'm going to hand over to you, let you introduce yourself, and just take it away. And I think you've got the final session before lunch.
Oh, that's never a good session, is it really? So
I'm
sorry,
sure you're gonna wow everybody.
Well, I have got some slides. I don't know if they're going to put up, or shall I share them?
Yeah. I think if you share, it might be easier, unless Aoife.
Yeah, it's up to you, Georgina. If you're happy to share them on your end, if
Yeah,
it's easier. But if not, I do have them as well.
Actually, will you do it, and then I can perhaps keep an eye on hands.
Yeah, of course, no problem.
Yeah.
Just give me 1 second, and I'll get those up for you.
It was quite interesting actually hearing the end of that that discussion around procurement. Procurement does sit under me as well, as often is the way. Sorry, I'll introduce myself first. So my name is Georgina Dean, and I am the Chief Finance Officer at Black Country Healthcare. So we are a provider of mental health, learning disability services across the whole of the Black Country. For those of you who are thinking, where on earth is the Black Country? We're sort of next to Birmingham, just below Staffordshire. I saw somebody go, yeah, I can see West Midlands ambulance person, yeah. So we cover 4 boroughs, but I'll talk a little bit about that in a moment. But yeah, procurement, it's an interesting one. And one of the things I'll talk about in our as we go through is actually what the role of a system is, and the role of us as individual organisations and anchor organisations, because I think we've got a big contribution to make to our local economies. So I'm a big fan of buying local as much as we possibly can, where it's practical, using local contractors again as much as we can. So we'll talk about that as we go through. So I think you had a session this morning on commissioning, didn't you, as well? Which probably is helpful background to this. I obviously work in a provider organisation rather than the sort of the ICB commissioning organisation. So I suppose you'll get a bit of a provider slant on this, I'll be honest with you. So I was asked to come and talk a little bit about the journey to ICS, which another acronym for us all to learn, integrated care system. But before I started, I thought I'd explain a little bit, for the benefit of those who don't know the Black Country, a little bit about the Black Country and some of the challenges that we face So if we go on to the first slide. So the Black Country, so we've got 4 boroughs in the Black Country, which you can see on the little map there, Walsall, Wolverhampton, Sandwell and Dudley. So all grouped together to be called the Black Country, but 4 very different places, as you could probably in your own areas have similarities like that. And even within Dudley or even within Walsall, you've got big differences. But generally speaking, it's recognised as being one of the most deprived areas in the country. So if you list all the integrated care systems in the country in terms of deprivation, Birmingham and Solihull is the most deprived, and then we come next. What does that actually mean? Well, we've got our life expectancy is lower, very challenge in terms of health inequalities. And what we saw through COVID is that these things were exacerbated. So very multicultural. So actually, when we're planning services and delivering services, really having to think about how we adapt those so that we are able to reach our population. Yeah, so like I say, particularly hard hit through COVID, I would say. Some of the trusts, so particularly Sandwell, I think, saw levels that were very, very high. And like I say, it's really exacerbated some of the health inequalities that were already there. But this just gives you a bit of a feel for the size of the Black Country. So total budget for the system in terms of allocation coming to the system is about 2.8 billion, probably about £3.5 billion if you bring in all the other bits of income as well. So a big, complex and challenging place to work. And if I'm honest, I think we've got the 4, as you can see. Each of those areas has their own local authority and has their own acute trust, and previously had its own CCG. So my trust was formed in 2020, and previously you used to have one mental health trust that covered Sandwell and Wolverhampton and one that covered Walsall and Dudley, and I joined after merger. And we can see such variation in how services have been commissioned and delivered in the past. You've got 4 ways of doing everything as a minimum. So historically, we've had 4 acute providers. You'll probably all be familiar with, the way that it worked in the NHS was very much a market sort of driven approach. So lots of competition between those different organisations, and then that sort of commissioner provider split, as we would call it in the past. So I used to actually work at the region for NHSI and then NHS EI, and I think the Black Country was always seen as being one of those areas where nobody got on. People don't, relationships aren't great, shall we say. So when we move forward and we say, well, you've all got to work together as a system, you've all got to come together, then it feels quite a challenge when you're starting from a place that isn't that sort of working together in the same way. On top of that, West Midlands Ambulance headquarters sits in the Black Country, and therefore from an ICS perspective, West Midlands Ambulance, despite being a regional service, sits within our ICS, and I'll talk about what does that actually mean in a little bit when I sort of talk through how we have to work. So that's just another bit that we have in the Black Country. So we've got all this complicated stuff going on. The deprivation is terrible, the competition. But if I take you to the next slide, it's got some of the health challenges on there. But if I take you to the next slide, it's just pulling out some of the issues, some of the challenges we've got around the Black Country. So when you look at some of those challenges, it's obvious that organisations working in isolation are not going to be able to solve these problems. So for me, looking at the population as a whole and everybody working together for the good of that population, it makes real sense, doesn't it? Let's work together and let's sort of pool our resources, as it were, and our knowledge and our understanding and all of those things, and actually let's work together for the good of our population. So it makes sense. Like I say, a lot of these things, I'm probably talking to you'll know about this anyway, but people's health is not determined by the NHS generally. I think I think the stats are that 80% of your health and your, outcomes are determined by other things in your life and not what we do in the NHS in terms of treatment. So things such as housing and employment have a much greater impact. And actually, again, the ICS is very much the NHS, but on top of that, we have the Integrated Care Partnership, which then tries to bring in these different organisations like the local authorities and housing and education and the police. The idea being that we can then start to look at some of those wider determinants of health, which ultimately in the long run should help us to make our population healthier. So during COVID, I think we were, I don't know if the right forced is the right word, but I think COVID, for many reasons, obviously was a bit of a change in how we worked. But there was a lot of collaboration, wasn't there? There was a lot of mutual aid between organisations. And from a financial perspective, all the normal rules went out the window. And we were told just to get on, do what you need to do, and the money will be provided. It didn't last very long, but that's how it was. But pretty much what they said is, this is the money for your system. Just go ahead, do what you need to do. And so all the old ways of doing things like payment by results and everything, that was all stopped, because the idea was that people needed to work together and not be focusing on those sort of things, and just make sure people had the resources that they needed to deliver the services. So it was all about collaboration and mutual aid. So if we go on to the next slide, so we've got that sort of, the idea of an ICS was coming anyway. I think COVID, in a way, emphasised why it was probably even more important that we work together to address these things, but also to help that recovery through COVID. So this is the sort of definition that's given about what an ICS is there for. So it's very much, I'll be honest, it does talk about local authorities and others, but in reality, on a day-to-day basis, it tends to be the ICS, which is the NHS organisations that we talk about. And you can see the idea is that it's about health outcomes, inequalities, productivity value for money, and social and economic development. And probably just picking up on that last one, because the top three, you'd probably think, yeah, that makes sense. But actually, I think the fourth bullet point is really recognising that the NHS and the rest of the public sector now, particularly somewhere like the Black Country, years ago would have been heavy industry where a lot of people were employed. Actually, the NHS is probably the biggest employer now, if you look at it across the Black Country. So actually, if we're giving employment to people, we're putting money in people's pockets, they tend to spend locally. So actually, as an NHS organisation based in the Black Country, we can really support that social and economic development of the Black Country. So things, as I said before, about buying locally can have a really positive impact on the economy in the Black Country. So it's a bit more, so it comes back down to a bit around social value rather than just the cheapest price sometimes. So we're trying to look at things like that. So I'll give you an example. We've got some work being done at the moment. For those of you familiar with the Eradicating Dorms scheme through mental health. So we've got a big capital scheme going on. Our contractor who's doing the building work is currently going out to look for local people to come and work with them on that build. For us, that's a really, really important part of that social economic development. Actually, as an NHS organisation, we can give people opportunities to get into work, for example. So if you think if we can do that locally just with my organisation, if you take that across the whole system, you can imagine the impact we can have. So that's the purpose. It's all, like I say, it makes sense with where we're coming from and where we need to go through. And if I take you to the next slide, it sort of tries to show you how it all works. Now, this is where it gets a bit complicated, I think, sometimes, and people don't necessarily understand the differences. So as I've talked about, we've got our integrated care system, which you've got the integrated care board at the centre of it, and then the integrated care partnership, which is where you've got your wider partners like housing and education, local authorities, police, etc. And the idea is the integrated care partnership comes together and they set almost the strategy and the priorities, and this is what we think we need to do for our population. And from a health perspective, the ICB then is the one that decides, you know, and does the planning. It says buying, but that's probably quite an old-fashioned way of looking at it. So that's the idea of how it should work. Beneath that, we recognise, again, it's a little bit like the guy said in the previous one, there are things that you have to do at different levels. So there are some things that you must do at system level. There are some things that you do at neighbourhood level. And you can see how that's represented in the diagram. So at that neighbourhood PCN level, where you have your integrated team working, and then at a system level, so for example, my organisation, we manage our inpatient service at a system level because that makes more sense and allows us to get the improvements and the benefits that we should. So it's quite, but it can be quite challenging because you're trying to work at that system level, the whole, but also make sure that each of those neighbourhoods or those places are getting the tailored approach that they need. And that's what I think, that's one of the things where we struggle. We're certainly struggling in the Black Country to get that right. Because if you live in Walsall, actually your needs are probably can be quite different to if you live in Dudley. So how do we give that sort of, like I say, make that bespoke and tailored to you, but also the things that need to be done, like I say, at that bit higher population level, that we can do that as well. So it's a constant challenge to what do you devolve, what do you keep central, and I don't think we've got that cracked yet, but I certainly think that we're not the only ones struggling with that at the moment. We've obviously got the health and wellbeing boards as well. Again, we have the 4 because of the 4 local authorities who sort of hold us to account. So if I'm honest, at the moment, it feels like lots and lots of extra meetings, being totally frank with you. I think we're starting to see some little shoots coming through, but a lot of it at the moment is just been like setting things up. Who's in place? How do we run at place? How do we run at neighbourhood? What has to be done at systems? There's a lot of discussion about that at the moment. We, as my organisation, are in a slightly different position because we are the only provider for mental health and learning disabilities across the system. So we have to operate at all of those levels. And we took on, from when the ICB was formed, we took on responsibility for commissioning services as well. So we took that from the ICB. So we now hold the budget for all the mental health, learning disability, autism services for the Black Country. So for us, that's been a fantastic change because now we can make the decisions, and certainly our clinical teams have much more influence about where we invest and what happens next and how do we change the services that we provide. So we're really positive about that. Again, it's still early days, but we think it's a really good way forward, and I think that's one that should be one of the benefits of the system working, is about how others in the system can step up. So we also have an acute collaborative where the 4 acute trusts come together, and again they're looking at, you know, certain pathways and how could they do that differently together. So this is the theory. Like I say, I think it's work in progress at the moment, but the potential benefits are huge. But if I'm honest, it always comes down to relationships. Whatever you do, it always comes down to people working together, whether it be at a local level or a system level or whatever, to come together to do the right things. And I think one of the challenges that we have, and I'll talk about the money bit linked to it in a moment, but is that you are still separate legal entities, but you are being told that you must work together in this integrated care system in quite a formal way, and NHS England regulate us at the system level now more than at an individual organisation level. So you have this conflict almost between, I've got my trust board who are, you know, our non-executives. Their role is to ensure that our organisation, you know, is successful, gets the best it can, but at the same time you've got this responsibility to the system to support the system and do the best for the system. And I think that sort of sovereignty question is one of the most difficult ones at the moment, because an ICS is not a legal entity. It's a collection of people coming together. And when it comes down to it, if there's an incident, if there's a problem, it's the individual organisation that has to, you know, deal with that. It's the individual organisations who are holding the risks on a day-to-day basis, just exactly the same. And I think that's where it gets quite difficult at times. So if I take you on to the next slide. So like I say, during COVID, they changed a bit about how the funding worked. And so our system before, the money would have gone to the CCGs, and it was all a bit of a mystery. Nobody really understood how the CCGs worked, and they got some money and it went somewhere, but we all had our own individual contracts, but we didn't really know how it all worked. Whereas now that we've got the visibility of that. So at the moment, when I finish here with you, I'll be going to join an ICS finance directors meeting, where we're all sitting around together to talk about our financial plan for next year. So we've got the 2.8 billion that comes into the system, and it's got to fund all of those things, everything for our system, all of those different areas. And we have to sit together and work out the best way to spend that money. And we've only got the 2.8 billion. So it's not like I can say to the ICB, you know, you might have done to the CCD, well, you've got to pay for this. I've got growth in services over here. You've got to fund it, because we're all part of the same system now. So you're just moving money around within the system. So it's a very different type of conversation, and actually quite difficult, because you've still got your own, you know, I've still got to break even myself. So it's a different type of conversation, and it's quite it's really challenging. I'm not going to lie. If I take you on to the next slide, so we get the system allocation. We have to work out where it goes to. Is the next slide coming? And what they've done in the new sort of legislation that came out is that not only do we have a statutory duty to break even as an individual organisation, i.e. you can't spend more than the income you get, we now have a statutory duty to work together so that the system breaks even. So what does that actually mean? It means last year I had to make a surplus to support my acute colleagues who were overspending. Now, as clinicians potentially in the room, how would you feel about that money going from your services to fund another part of the system where they were struggling? You can imagine the conversations I had to have internally about that. It's really difficult. And I know my colleagues at West Midlands Ambulance were in a similar position and weren't particularly happy about it either. But we did it for the greater good of the system. But it's, like I say, it's a different type of conversation than we've had before. But it is a duty that we now all have. So we, like I say, we have to come together and say, how do we best use this money? At the moment, it's very much based still on those historic contracts. So you take money off one bit, you give it to someone else, but there is no more money overall. And I think that's one of the challenges. One of my concerns about how it is so at the moment in my system, they're talking about devolving some of the budgets to say the 4 different places. So we'll put, you know, Walsall will have so much money, Dudley, whatever. Devolving some of the money directly to the acutes in a different way so they manage more of it. My worry about it, if I'm honest, is that we then just keep spending the money in the same places we've always spent the money. And if we're really going to change things for our population, we probably need to start, we're going to have to think about how we move money across the system. You know, do we need to put more into primary care and prevention actually, and be brave about that, so that actually we start to try and cut off the demand into the secondary care services. But at the moment, obviously, people are dealing with what's in front of you, and that's always one of the challenges in the NHS, isn't it? That you're trying to think about tomorrow and how do we make it better for tomorrow whilst dealing with the challenges for today. And I don't think this makes it any easier. I was talking to a CEO from another system near to us, and they've agreed within their system providers and the ICB that they are going to take a chunk of money. Mainly it will come from the acute providers to put into more health inequalities and prevention, because they realise if they're ever going to shift the health of their population, they've got to do something bold. They're not quite sure how they're going to do it yet, but they've all made that commitment that that's the right thing to do, which is really interesting to see how that works. But I think that's part of the system. We should be able to make those sort of brave decisions about where the money should go, rather than necessarily where it might have gone in the past because of old contractual routes, etc. So there's lots of opportunities, I suppose, is what I'd say, from working as a system. But it's so different to how we've worked together in the past. I think it's just getting people to think differently. And like I say, sometimes you have to not think about your own organisation, but think about the wider system and what's the best overall for our population, even though it might not be the best for my organisation, which is really difficult. The other bit that's quite challenging, and I did see some of the chat before when somebody'd ask about foundation trusts. Makes no difference these days whether you're a trust or a foundation trust, to be honest with you. You don't get any more freedoms or anything anymore. That's all long gone, unfortunately. One of the benefits of being a foundation trust in the past is that you could decide yourself how you spent your capital and how much you spent, and that was one of the benefits of having a surplus and cash in the bank and all of those things. None of that anymore. So I've got cash in the bank and I can't spend it how I want to spend it. I've got wards which need refurbishing, and I've got really poor estate, but I can't spend the cash that I've got in the bank because we're now set a limit for us at a system level of how much we are allowed to spend each year. So again, we have to go through a process of divvying that up across the different providers to decide, the best way to do that. Again, we haven't really got that cracked in terms of a proper risk-based prioritisation process. But just to give you a bit of a sense, we as a system, so 4 acute providers plus the ambulance service plus my organisation, we get about 80 million a year. I think probably about 20% of that has to go on the new ambulances, because clearly they have to be replaced on a regular basis. You add a few scanners in there and stuff, it's not very much money when you look at it across 4 acutes, like I say, mental health, learning disabilities. It's not a lot of money. Now we know capital is quite short in the NHS as a whole, but now I end up in a battle saying, no, I really need to, replace these doors because of ligature risk, at the same time as you've got somebody saying, but I really need a new MRI. And like I say, we haven't got it cracked yet about how we do that in the right and fair and proper way, but it's a real challenge. And I think it's that debate as well about people are saying, well, if we're going to invest money in capital, we should put it in an area where we know we've got a backlog, where we've got waiting lists, which that makes sense, or where we can use it to facilitate a change, a transformation in services, which might help. But how does that help my team base where the roof's leaking and I need to, to me, it's because we've got poor estate, that sort of stuff would never get picked up in terms of transformation and productivity and everything. So it's really challenging. I think from the capital perspective, I think we've probably moved a bit further on that, if I'm honest, and are working together to look at how we can do things differently. How do we share buildings more, for example? How can we share some more services, maybe keep the money within the NHS? So I now buy all my food from my neighbouring acute trust, whereas before we used to buy it from Tillery Valley. So better, because the money stays in the system. Jobs for local people, more local produce, and actually the quality is so much better. So it's a win-win-win all around for me. Interestingly, the procurement people tell me I'm not allowed to do that because I need to go through a procurement process and use a framework. Guess what? I've ignored them. Shouldn't say that, should I? But that's what I've done. I've ignored them because ultimately I think it's the right thing to do, and the more that we can do that sort of thing, the better, I would say. So it's, I think the journey to ICS isn't over. I think it's taking us from a place where we were pre-COVID to something very, very different. It's absolutely the right thing to do and absolutely the right way that we should be working together. But it is really tricky. I probably spend half of my time in system type meetings now. So from a sort of even just a work day-to-day workload, etc., it pulls you away from your organisation as well. So you have to think about that, because obviously you don't want to let go what you've got in your own organisation. It's definitely, you know, we all know each other a lot better. But I think we've got a long way to go, if I'm honest, till we really start to see the benefits that come out of it. I think I'm just going to look. Yeah, I think that's my last slide. So we can take that down. So that's just a very honest view from me about how it feels to be part of an ICS, why I think we're doing it, how it's actually working in reality. I'll be honest, I spent last Thursday, it was, in a room with my ICS colleagues, CEOs, CFOs, directors of strategy, etc. And I spent a good chunk of it defending why mental health deserved the mental health investment standard and why it shouldn't be just absorbed into the bottom line. So that's a bit of a reality for me every day. Thankfully, the national team are very clear on things like that. But when there's a lot of pressure elsewhere in your system, it's not surprising people say, well, have you not got a bit? Can I not have a bit of what you've got, please? So that's a bit of a constant battle discussion that I have, like I say, across. I'm just going to look now at the questions. Yeah, Black Country. I see somebody's explained that. If you ever want to come and visit the Black Country, we have the Black Country Museum, which is fantastic. Well worth a visit, give you a bit of an idea about the Black Country. And we also have a castle and a zoo in Dudley as well, right next to the Black Country Museum. I mean, if I didn't come from the Black Country, would I have visited it? Probably not. I'm not going to lie, but I think there is something. And Josh is laughing, but I think there's something very special about the people of the Black Country, and understanding them. And most people who work in the Black Country know the Black Country, and they love working there. People don't tend to move. I mean, you're probably the same in lots of your localities as well, but you need to understand your population, don't you, to be able to really deliver services. So, for example, I can say Plymouth, very different than to Plymouth. I think, for example, when we hear about things like the NHS app and all that stuff, the digital inequality in the Black Country, you cannot rely on technology as a way to communicate with your patients. It just will not work. So you've got to think about alternatives. During COVID, MyTrust, we gave out hundreds of iPads because with virtual appointments, it's the only way that we could actually ensure that we could still, talk to the patients, because otherwise they just didn't have that. Yams. Yeah, don't call us Brummies. That's all I'm going to say. Yes, I'm just looking at the comments. Yes, system CEOs agree to system-wide process would make things much easier. And I think at that high level, they'll know, yeah, we all agree these are the most important things. Like anything, the devil's in the detail. And when you start breaking it down and saying, well, that means that your organisation might lose some money or lose a service or whatever, then people are a bit like, oh, hold on a minute, I'm not sure whether that's what I really thought. But yeah, that is supposedly the benefit of it. How do you know how much money needs to be put where? Yeah, it's a very good question. At the moment, that's not how it works at all. It's all based on history. It's exactly what we should be doing. We now have, I'm sure you're all probably got the same in your systems. Our system, by the way, is heading for about a 90 million deficit this financial year. We're absolutely in the bad books with NHS England. And one of the things we've done is, one of the things we get a lot of challenge on is the fact that our workforce has grown significantly since 1920. And you'll all have heard 1920 because it was pre-COVID, everything's compared back to 1920. But actually, we can't explain why the workforce has grown by so much. And you'll all have heard probably about the productivity challenge, and your workforce has gone up by 20%, but your productivity's gone down by 10%. And we can't give a really clear narrative on that. That's the reality. A big chunk of it is definitely UEC, because obviously that's a totally different thing. And, you know, we struggle the same as everybody else around that, but we're not really using that data at the moment. And we did review business cases that had been approved through COVID to say, what are we getting? What benefit are we getting? And it was really hard because people hadn't necessarily done it in that way. It was like, we're really struggling. We need extra capacity here. We're going to put in that extra capacity, rather than it being perhaps this is what we're hoping to achieve. And I get it, because at the point in time, things were really tough, weren't they? But trying to unwind things then is very, very difficult. So we absolutely should be doing that. We're trying to do that a bit more in my organisation, because, like I say, we've now got that commissioning responsibility. One of the things we're doing in my organisation is we're spending more money with the voluntary community sector, because we recognise that our population actually, for some things, engage better with that sector than they do with us, and they are able to offer something we can't. So, as an example, our community transformation for mental health services, we've provided, it's about £1 million to the voluntary community sector to provide a range of interventions. And some of those interventions are actually helping people with basic digital skills and maths and English. Because we realise that if you help people with some of those things, that might actually help their overall health, well-being, access to employment, all of those things, which ultimately, hopefully, will keep them out of our services, which is what we want. So we're trying to look at things like that, but I'd say it's very early days. But we've got a system investment committee now, which in theory, any new investment, we should be doing exactly what's described there. What happens if you have a surplus you had to care for? No, you can't keep it. If I make a surplus, it just goes to the system. That's what happened last year. Now it's gone now. No benefit. No benefit to, that sounds awful, doesn't it? No benefit to our organisation, which is why it's quite a difficult conversation. Not that I think there's going to be many surpluses around going forward, to be honest, the way it's going. I'm just reading that about the digital stuff. But yeah, I suppose that's it. I would say it's the right thing to do. It's challenging because it comes down to people and relationships, but I hope that we don't suddenly get another big change that makes us all work differently again. It'd be good if it was actually allowed to bed in, and really we could start to see some of the benefits to come out of it as we all settle into it, rather than changing it all again. But who knows? It's the NHS after all. But happy if you've got any madness, exactly. But yeah, happy to take any more questions or anything.
I think thank you, Georgina, for a very insightful and wonderful sort of insight into how ICS finances work. I think definitely resonated with what's happening within Coventry and Warwickshire and across the country, actually, and with a lot of people as well on the meeting. So I think just wanted to say thank you again and wish you all the best for your meetings this afternoon. And thank you for bigging up the Black Country, as I'm a Walsall girl myself. So just wanted to put that there. And I think if we can all show our appreciation for Georgina, and wish you the best for the day.
Thank you very much, and
hope to see you again soon.
Yeah, thank you. Take care.
Hopefully not 10 years. Take care now. See you.
Thank you.
Thank you. Bye-bye. So I think that was our last talk before lunch. I think we'll agree that was really informative, especially if we don't always have that kind of awareness as what's happening outside of our organisation and how the system works. A lot of that talk kind of resonated with how finances work within our own organisation, and I'm sure it will be the same with your own organisations as well. So I think we've got lunch now, and we're due back at 1:15. And this afternoon session, we've got a few talks on costing, patient level costing, coding, and business cases. So if you're all happy to break for lunch now and be back for 1:15, that would be great. And hope you've enjoyed the morning so far.
Parminder, just one question. I need to nip
Yes.
out for clinic in a bit.